here we are starting our day 2 of our DIACARE 2020, and it's a fabulous start with the debate. We are waiting for our reporters. We will join soon, Dr. Pranita. So, meanwhile, I would like to invite our chairperson, respected Dr. Vidyut Sir and Dr. V. Ramkumar. Over to you, our respected chairperson, sir.
Yes. Shall we start with the proceedings? Hello.
Yes, sir, you can start.
Yeah. Yes. So,
Yes, sir.
very good morning, friends. And at the outset, I congratulate organizers to have this beautiful conference and scientific fiesta on behalf of me and my co-chairperson, Dr. Ram Kumar. The first debate today we are having is about sulfonylurea, and it is an very important and age-old question, uh, which is better, glimepiride and or a gliclazide. And we have very able speakers debating the point today, Dr. Meenal Mohit and Dr. Om Lakhani. Uh, I welcome both the speakers, and I believe Dr. Meenal Mohit is going to start, and she will speak for glimepiride. The stage is yours, Dr. Meenal Mohit.
Good morning. I'm Dr. Ram Kumar, and this is an interesting session. I thank Bansi Sabu and his colleagues for giving me this opportunity to be with you all. And it's an interesting because glycoside is everyone's favorite, but it's not marketed more because it is an European molecule and other things. And glimepiride, it came into focus because of the safety. You know, this in Carolina trial, it was compared with linagliptin, and its cardiac safety came out. So I think glimepiride got more advantage on Carolina than the linagliptin because its cardiovascular safety was established. And another interesting thing is I was there when Steve Nissen did in ASD about the safety of the various drugs. So after that, they said all the drugs which are going to be introduced, they should have cardiovascular safety. So in this arena, I invite Dr. Meenal Mohit and the Dr. Om Lakhani for their debate. I think you know the timing and other things. Okay, first one speaker will be talking, then another speaker, there will be rebuttal. That's the procedure. Thank you very much.
Good morning, everyone. I'm Dr. Meenal from Jaipur, and we are here today to discuss. I will not use the word debate. I will use the word we are here to discuss the efficacy, sufficiency of the two very beautiful sulfonylurea molecules, rather. So, with your kind permission, can I start beginning to share my screen, sir?
Yes.
Right. So, is my screen visible to all?
Yes, yes.
So with your kind permission, the chairpersons, as I said, we are here to discuss the significance of the two important sulfonylureas. Which is better? I will not read the next line. So let's prove what I'm saying, maybe, if I can, in the next 20 minutes. So, well, as I said, we are both sulfonylureas. But besides being both sulfonylureas, we are structurally different. So we have some pharmacokinetic differences, some pharmacodynamic differences, and maybe that makes one a preferred choice. I will again avoid using the word better. Maybe one becomes the preferred choice in certain circumstances, certain scenarios, not all, but yes, one molecule is preferred over the other depending upon the individualized clinical scenario. So what was it that brought us to the third generation sulfonylurea? With the sulfonylureas, we were still facing hypos, overproduction of insulin, weight gain was another challenge, durability, and the most important was that we were facing hampering of ischemic preconditioning. So came something called what? The third generation. And which is the only third generation molecule? If I ask the whole house, I don't need to answer it. So let us first discuss the glimepiride, because that is what I have been asked to do here as my job. So any molecule, if we look at the diabetic pyramid, at the three-dimensional view of the pyramid now, we look for the sufficiency, safety, security, and sustainability of any molecule. So I will begin with sufficiency. If I talk of sufficiency of glimepiride, we look for maintaining fasting, postprandial, and also the glycosylated hemoglobin. And we all know that sulfonylurea with a specific significance of glimepiride is doing its job pretty well. And in this one study, which was head-to-head trial, a 24-week study between glimepiride and gliclazide in naive patients as well as patients who were previously treated with glibenclamide, in both the groups, definitely glimepiride gave us a better fasting as well as a better HbA1c. As the chairpersons rightly used the word that Carolina trial is a recent outcome, the data is recently out and we all are very happy with the data. Carolina also gave us unknowingly, unintentionally, it gave us that glimepiride was the molecule which gave us a rapid achievement of the target and maintenance of the target by the end of the study. This is another study which is showing the significance of glimepiride, may it be 1 milligram, 4 milligram, or 8 milligram strength, controlling fasting, postprandial, as well as HbA1c, and you will find that the molecule is doing its job best, to the best of its ability. So the most important and the hit word that we are using nowadays is tackling the glycemic variability, and glimepiride with its pleiotropic benefits is giving us a very good control, a very smooth control, I would say, avoiding glycemic variability all through, controlling fasting, postprandial, and at the end giving us a good HbA1c. So the important next question, what is the pill burden difference at the maximum recommended dose? How many tablets do you recommend to your patients? Going up to 4 tablets with gliclazide or just with 1 tablet OD with glimepiride? Coming to the third important concept after the sufficiency, safety, the third important is security. What do we look at? The most important we look at is security, that is the cardiac security. As again the chairpersons mentioned that CVOT is a must. So now with ischemic preconditioning benefit getting lost with glibenclamide and other sulfonylureas, I'm avoiding using gliclazide here because Dr. Om will have his objections otherwise, but just to mention that glimepiride does not abolish the ischemic preconditioning benefit because of its dual benefit, dual action, dual mechanism of action. So in this control study, the ischemic preconditioning benefit was lost with gliclazide, glibenclamide, but only maintained with glimepiride. So moving from here, another study showing that the ischemic preconditioning benefit did not lose with glimepiride. Besides that, glimepiride is giving me anti-arrhythmic benefits, anti-aggregatory benefit, that is, it is anti-atherogenic also. It is preventing against prothrombotic states in another study versus placebo here. Then this is animal study, of course, but then it is giving me the benefits that it also blunts the atherosclerotic lesions of the carotid edema. Another study which is comparing the various sulfonylureas, and it is definitely giving me a beautiful line that glimepiride is the preferred sulfonylurea in patients with underlying CAD. So glimepiride with its CV safety parameters preserving preconditioning, because of its ATP channel, specific ATP channel actions, it is giving me the benefits of all the cardiovascular benefits, no effects on blood pressure, and it is rather improving the coronary blood flow. So with this, now third question to the house, which is the only sulfonylurea to have undergone a CVOT? Of course, glimepiride, and not one CVOT. There are just few to name. This molecule has been unintentionally a part of many CVOT trials. To name a few, Emparec, Carolina, Carmelina, Ticos, Examine, Bright. So now another important question where gliclazide or Dr. Om will fight with me saying, oh, I'm not causing hypos, I'm not causing weight gain. So let us have a look at the glimepiride profile in terms of weight gain, hypoglycemia, and the other adverse events. And you will find that the best plasma insulin is to blood glucose ratio is with glimepiride. So it has some endogenous insulin sparing effect. Can you see the plasma insulin blood glucose ratio? It is just 0.03. So let's forget hypoglycemia with glimepiride in the optimal doses. Of course, it is the physician error if we are over-treating. We cannot blame the molecule for that. But endogenously, you will find used in the right doses, there is less of glimepiride caused hypoglycemia versus other sulfonylureas. And these are few studies to document. You will find that the hypos are much less when glimepiride is compared with glibenclamide. Coming to the weight gain, again, the weight gain is least with glimepiride. So you will find few of the studies available showing that the weight change was least with glimepiride. Now, this is another study which is showing that the mean weight gain, rather there was a weight loss in the long run with the optimal blood glucose control. Even in the Carolina trial, to quote once again, there was initial weight gain, but after a period of time, at the end of the study, there was actually a weight loss of some 1.5 kgs. Now, the last most important thing, that the molecule has significant pleiotropic benefits. So it also has to, these few I have already mentioned, so I will only come to the ones which are left because I don't know about the time I'm left with. So you will find that most importantly, it is also giving me increased adiponectin, antioxidative benefits besides the preconditioning benefits, vascular health, and all these. So to talk a few words about them, glimepiride gives me an increased adiponectin levels, and we all know increased adiponectin is associated with the raised HDL and low LDL values. So glimepiride is giving me the benefit of improving insulin resistance and also giving me anti-atherosclerotic benefits. Another important study or interesting concept is that glimepiride is also known to increase the testosterone levels. So it also helps me in increasing the libido and avoiding some depression and improving the self-esteem in my male patients, especially if middle-aged or maybe older patient, I would say, is facing the challenge because of neuropathy or because of any other complication, even the waning of testosterone with aging also. So in such patients, glimepiride is giving me an edge over other sulfonylureas. Coming to other biomarkers or the anti-inflammatory role, antioxidative role, other angiogenic benefits, you will find that glimepiride is also helping me as an antioxidative molecule, improving the advanced glycation end products, eotaxin levels, FGF2. So all these plasma levels are improved with glimepiride. So glimepiride, you will find, is another anti-inflammatory molecule. And as we now understand that diabetes is an inflammatory disease, so any molecule giving me the benefit of antioxidative role or anti-inflammatory molecule will be of better benefit to me and my patients. Now, as Dr. Om Lakhani would quote a few studies, so before he jumps to them, let me give you a picture before you get biased. What was the truth of the advanced study? The advanced study, which the gliclazide has, all the companies have taken the benefit of, just said intensive blood glucose control, not the role of gliclazide, but the role of intensive blood glucose control, irrespective of the method. There was huge use of insulin right from the beginning in both the arms, conventional as well as the intensive arm. So all the benefits, microvascular and macrovascular, were because of intensive blood glucose control, not because of the intensive gliclazide use. So intensive versus standard, that was the objective and the role of the protocol of the study. The study was not gliclazide versus other sulfonylureas. The study was intensive versus conventional. Okay, another very famous study, not very famous, rather the well-quoted study by the gliclazide biased people is the Schramm study. So let me, before he goes with the Schramm study, let me tell you what Schramm study was all about. It was a completely biased, it was a retrospective study, first of all, so it did not have much value. Another point you will realize that in this retrospective study, there was a significant bias of randomization. All the age and sex and the comorbid population was given to glimepiride arm. So that gives me one important point, that glimepiride is the molecule of choice whenever you are having complications. So you are safe and confident while prescribing glimepiride to your people with comorbidities. So obviously, population with comorbidities and aged population will have some slight higher incidence of complications. So that bias was used by the gliclazide arm. Now the well-quoted, the only study head-to-head available probably is the GUIDE study. The GUIDE study, which is not so far published, it is basically a comedy of hypos if you look into. You will find that they have quoted so much of hypos, more than 50% hypos with with glimepiride and half of it with gliclazide. And do you know the facts of these hypos? They were all very mild or moderate hypos, and the hypos in the gliclazide arm were not even reported. They were all self-reported hypos, no documentations. The nocturnal hypos were not taken into considerations. Asymptomatic hypos, which may be silent hypos because of the neuropathy, were again not reported and not documented. And can you see the errors? We all understand as we go to higher HbA1c control, and the hypos should be more, because the tighter the blood glucose control, the more likely we are to have hypos. But in this interesting study, you will find as the HbA1c was going higher up, the hypos were rising. This is very interesting. And also when it was like the number of hypos and the number of patients, you will again find another interesting error. As the dose was increasing, the hypos were decreasing. At 6 milligram of emerald and higher dose of diamicron, there was no hypos. Whereas at the lower dosing of the gliclazide as well as the lower dosing of glimepiride, there were more number of hypos. So this gap, this therapeutic gap is difficult to explain, that why the hypos should be more at lower dosing or at the initiation of therapy rather than at up titration. And in spite of that, the study continued. In spite of that, the patient was up titrated in spite of all the hypos. What were we studying? I really don't understand. So giving you the crux of my entire talk, the only third generation sulfonylurea, of course, glimepiride. The better plasma insulin blood glucose profile, of course, glimepiride. Least weight gain, least hypos, equally efficacious. Again, Ramadan is one study where gliclazide will try to take its edge. But again, let me tell you, it is all individualized and you can always counsel the patient accordingly. Then the only molecule with dual mechanism of action, glimepiride. Increased adiponectin, decreased inflammation, only sulfonylureas with dedicated CVOT study backup, again glimepiride. A molecule without hampering preconditioning, again glimepiride. Glimepiride blunts the atherosclerotic lesions of the carotid intima. Glimepiride is associated with lower incidence of arrhythmias. Glimepiride is the molecule of choice in patients with heart failure. Glimepiride is the most available modern sulfonylureas. And the hypos, you will understand the significance of hypos, that it is the only preferred molecule in elderly as of the AGATE trial. And it is the only molecule which is authorized by FDA to be used with insulin. So that tells me the facts of the hypos with glimepiride. And with this slide is basically smaller to write the benefits of glimepiride molecule. So probably just to give you the last glimpse of the market review, the market status. Out of the 100% prescriptions of OADs, 40% share is taken with glimepiride. And the gliclazide market is just 6%. So there must be some reason. We are all not absolutely blind. So there must be some reason for this market bias also. Fine. So this is my last slide. So obviously you can see which is the right one and which is the wrong one. But let's be a little humble. So yes, both are amazing. Both are the sisters of the same family, sulfonylurea family, and both are equally amazing. Thank you so much.
Mohit, you mesmerized with your talk, and we forgot to introduce you. Just tell few words about yourself.
Sir, I am Dr. Meenal. I'm endocrinologist at Manipal Hospital, Jaipur.
Wonderful. Thank you very much. And the interesting thing I learned today is it's useful in importance also. That's a very new point. I think pharma people will be very happy to take this point from glimepiride. And I invite next speaker, Dr. Lakani. And Dr. Vijay Shah will tell few words. And Lakani, I want to know why it's not introduced in US and other things you will be explained. Okay, thank you.
Dr. Om Lakhani is a consultant endocrinologist from Zydus Ahmedabad, and he is a winner of many awards and a regular speaker at most of the conferences. And I had an opportunity to listen him quite a few times, and he was always the very best. And I believe he will counter very brave and intelligent disposition by Dr. Meenal, equally bravely and equally intelligently. The stage is yours, Dr. Lakhani.
I think
Thank you.
before Om starts, I should say Mrinal, excellent presentation, and we're looking to a big fight, Om. You know, we have big expectations.
Thank you,
Thank
Mithun. Thank you so much, and good to see you here.
Thanks, Mithun. So I'll just start by sharing my screen. Is the screen visible?
Yes.
Okay, thank you. So, thank you for this opportunity. And what I'm going to talk about is which sulfonylurea is better, glimepiride versus gliclazide. And we already had the talk on glimepiride aspect of it. Let's now talk about gliclazide aspect of the same. Now, let me start first with the last point which Dr. Meenal raised. That was about the market share. Okay, if we were to determine the quality of any product based purely on market share, I think someday we'll have to decide that Maruti Alto is the best car in our country, which is not, right. The largest market share for any product is a combination of the cost effectiveness of the product and the affordability, and also of course quality, value for money, and so on, right. But at the end of the day, in any country, in fact, the market share of a cheaper car like Maruti Alto, especially in India, would be much lower than that of a Mercedes, which I'm sure each of you will agree with me that Maruti Alto is not better than Mercedes, right? So that's for sure. Okay, so let's debate this by talking about the various aspects of the thing. Let's first start with efficacy. Okay, so in any product, I think I'm surprised that efficacy was not a topic which was raised vehemently, because that is one of the major criticisms, that gliclazide is not effective enough, and that is what has been told. But let me just burst this myth. That is actually not true. You can see from this study from Meloni, where you had 121,000 patients. Okay, not a small number, huge number of patients, where you had these three drugs compared: gliclazide, glimepiride, and vildagliptin, as an add-on to metformin. And clearly you can see from here that the HbA1c reduction was higher in gliclazide compared to the other two agents, right. Again, if you see the effectiveness in terms of the same study, HbA1c reduction, as you see as the time progresses, the HbA1c reduction by week 27 is similar in both the groups, glimepiride versus gliclazide, and the fasting blood glucose reduction is also very, very similar. And what you also, Dr. Meenal talked about is the rapid onset of action. Again, if you see fasting plasma glucose reduction with gliclazide, within 15 days, you have the fasting glucose reducing in a baseline HbA1c of about 8.5 to 49 milligram per deciliter. And by day 60, it was as much as 87 milligram per deciliter. That is the magic of gliclazide. So gliclazide is, I think we can establish that it's a very, very efficacious molecule. Then let's talk about what we all worry about, and that is safety of a molecule, right? And how safe and durable is gliclazide compared to glimepiride, right? Here I'll counter a lot of points which Dr. Meenal raised. Unfortunately, she told me that it has less hypo and it has less weight gain, and she showed me studies compared with glibenclamide and not with gliclazide, right? I mean, I know that glimepiride has less hypoglycemia and less weight gain compared to glibenclamide. I think that's a very well taken. I think the debate is not between glibenclamide and glimepiride. Any day I would agree that glimepiride is a better drug than glibenclamide. And I'm sure you'll also agree that gliclazide is better than glimepiride, right? That's the point. Okay. So you talk about hypoglycemia. I'll talk about data and I'll talk about theory. So first is the data. And, thank you, Dr. Meenal, for pointing out to the study that is a guide study. And just to tell you, you can see the reference below. Guide study is actually published. So if you want, I can send you the full text of the article, right? It's a published study now, and you can see 50% less reduction of hypoglycemia compared to with gliclazide compared to glimepiride, and 50% is not less, right? You can make all criticisms for the study, but all you can say is that how do you defend 50% less reduction in 50% higher risk of hypoglycemia with glimepiride? right? Even if it's a completely flawed study, even then this data is enormous, to say the least. And let me tell you, this data is not a fallacious data, because we see this in clinical practice, and I'll show you from a practical case scenario why gliclazide is clearly better than glimepiride, in a real life situation. So this is again, and remember, this is blood glucose less than 54, so it's actually severe hypoglycemia episodes compared to just a mild incidental hypoglycemia, and you can clearly see the difference is quite remarkable. So that is again very clear to say. But also, I would really like to point to your this table, where you can see the hypoglycemia across the day, right? It's not just hypoglycemia during a momentary period of time. Hypoglycemia throughout the day is less with glimepiride, with gliclazide compared to glimepiride. And you can see, especially in the afternoon, right? You can see the hypoglycemia. Look at the hypoglycemia risk at 12 a.m. in the night, right? Huge nocturnal hypoglycemia which goes unrecognized. 5 p.m. in the evening, look at the difference, right? So you can clearly see the difference is staggering. 11 a.m. in the morning, so on and so forth. I think there are a lot of things to really show that the hypoglycemia risk is clearly less with gliclazide compared to glimepiride. But there is a reason for it. There are theories for it. There are three theories rather, to say why gliclazide has less hypoglycemia. One is that gliclazide is, especially the MR form, is gradually released compared to glimepiride and glibenclamide. So the peak plasma levels are achieved 6 to 12 hours with gliclazide compared to glimepiride, which is just 2 to 3 hours after the dosing. And you can see from this chart here, I circled the relevant points, right? So you can see glibenclamide, the peak levels after 2 to 4 hours, and glimepiride after 2 to 3 hours, whereas gliclazide, the peak levels are reached after 6 to 12 hours. So it is a gradual onset of action. Hence, everything is not dumped into the system, and hence you have, whereas the duration of action is similar with glibenclamide, glimepiride, and gliclazide, which is all more than 24 hours, right? The second difference is presence of active metabolites, and you have glibenclamide and glimepiride, which has active molecules, whereas gliclazide does not have an active metabolite, and because it doesn't have an active metabolite in circulation, the risk of pertinent hypoglycemia remains. And again, I think somebody told me that the only third generation sulfonylurea is glimepiride. I think I'll just kind of bring to your notice that gliclazide modified release is also a third generation sulfonylurea, right? Just to sort of, and I can clearly see from this table, taking from a very huge review on sulfonylureas published in 2020. So like I said, gliclazide has no active metabolite in the circulation, while glimepiride and glibenclamide both have active metabolites in the circulation. What about another mechanism, and that is using EPAC2, right? Now, interestingly, when a sulfonylurea, it is supposed to bind with SUR1, but a lot of sulfonylureas also bind with another sulfonylurea-like receptor, which is EPAC2, both of which actually continue to stimulate the pancreatic beta cell to produce insulin. Gliclazide is the only sulfonylurea that does not bind with EPAC2, it just binds with SUR1. And because of this reason, gliclazide, if you do develop hypoglycemia, you recover from hypoglycemia much earlier, because the EPAC2 binding is irreversible and remains for a longer period of time. So you would have I've seen a lot of patients in emergency. None of these are my patients, and then of course in future they become my patients because they were given glimepiride and they develop hypoglycemia which remains for 2 to 3 days, right? They have to be admitted. They have to be, they have to remain under a continuous care, especially elderly group of patients, especially those with compromised renal function, and they are given high doses of glimepiride, unusual doses of glimepiride, and patient comes in emergency with hypoglycemia. And I wonder how many of them don't even reach the hospital, right? That's the sad part. I'm so frustrated with the hypoglycemias that we see in emergencies because of glimepiride with inadvertent use of that. And I think that's really wrong. What about weight gain? Advanced trial, right, showed that there was overall negligible weight gain in the trial. Over a period of 5 years, there was just 0.1 kg weight gain, which is, I think, quite remarkable for any drug, to say, not just sulfonylurea. And the guide trial, which you sort of alluded to quite a few times, the body weight change was 83 to 83.1 to 83.6. And in gliclazide group, whereas it was 83.7 to almost 1 kg weight gain in a glimepiride group. So there was, definitely more weight gain. What about durability of action, right? And we all talk about, how long a product will last. And we know German engineering, right? European engineering, things are built to last longer. French engineering, you know this, and this all comes from, all these things comes in benefit here. The data clearly shows in advanced trial, This is remarkable. 4 out of 5 patients on gliclazide attained their HbA1c of less than 7 and maintained that over a period of 5 years. Right? For 5 years, they maintained the same HbA1c, that is the duration of the trial, clearly. And there's a reason for this. This is actually comes from a study. You can read this again. There is free radical scavenging activity of sulfonylureas, and mainly this is seen with gliclazide and not with other SUs. So basically, gliclazide has, as a bioctyl ring, which is antioxidant in nature. And we know that the beta cell depletion that occurs as a progressive result of over a period of time is because of reactive oxygen species, and that is actually curtailed by gliclazide. And again, in clinical practice also, we have seen that gliclazide durability of action remains quite remarkable. So this is about safety. Let's talk about the renal benefits, I think, which Dr. Meenal did not even talk about. The advanced trial actually showed that over a period of time, there was actually reduction in the microalbuminuria and progression to end-stage kidney disease. This is, remember, this comes before you had the recent SGLT2 molecule. So before SGLT2, now we all talk about renal benefits of SGLT2. What we forget that we already had a drug, which is gliclazide, which in a dedicated clinical trial showed that there was reduced cumulative incidence of end-stage kidney disease. And you can see in all parameters, new onset of macroalbuminuria, there was reduction. New onset of microalbuminuria reduction, and there's new onset of nephropathy. Again, there was almost reduction there. So what I can tell you is that, and the number needed to treat is also not bad, 1 in 41, right, which is not bad at all. So what it tells us is that gliclazide is one sulfonylurea which prevents the progression of kidney disease. And on the other hand, when I want to use a drug which is safe in patient with kidney failure, sulfonylureas like glibenclamide and glimepiride have active metabolites. These are all taken from some review article, right? You need to avoid glibenclamide in those patients with GFR less than 60 very clearly. Glimepiride needs a dose reduction, especially when you're going to GFR less than 60 or 30. Glipizide and gliclazide can be used without dose modification between 30 to 60, and GFR less than 30, you can continue to use it with careful monitoring and dose reduction if necessary. So this is overall about renal safety. Let's come to the most important aspect, that is the cardiovascular safety. I mean, I'm very surprised Dr. Meenal does not realize that ADVANCE was actually a CV safety study for gliclazide. There is no dedicated CV safety trial for glimepiride. All the trials you have is retrospective. It is the Carolina trial was done for linagliptin. It was not done for glimepiride, right? It's a comparative between a DPP4 and a sulfonylurea glimepiride. It is not a dedicated trial for glimepiride alone. ADVANCE, on the other hand, is a dedicated clinical trial for a CV safety trial, though it does not say CV safety, it says intensive glycemic lowering, which of course is a CV safety trial. This is what, before the rosiglitazone controversy, this is what it was typically called, right? And remember, ADVANCE in any CV safety, including your SGLT2 inhibitors, there will be use of other agents, right? Other agents are going to be used in both the arms, right? You need to achieve a good glycemic control. You need to achieve a glycemic equipoise, right? In SG, even in your EMPIRIC trials, other agents were used, right? Even in your DEPA-CKD, even in your DEPA-TIMI or whatever study you want, any major leader trial, whatever trial you want, sustained trial, all these trials also use other agents in both the arms, right? That does not mean anything. Ultimately it means that you need to achieve glycemic equipoise in both the groups, right? That's not an argument at all. But I'll give you one very strong argument, right? Textbook, right? And we all read textbooks, we learn from textbooks, right? This is the most respected textbook in cardiology, the Braunwald textbook of cardiovascular medicine. I'll just read out what it says in the last line. Statistically significant increased odds after multivariate analysis were associated with all sulfonylureas analyzed compared to metformin, including pancreatic specific glimepiride, except for gliclazide, which had no associated mortality signal. Boss, Braunwald is saying gliclazide is the only one which does not have a mortality signal. I think this is very, very, alarming to say, we are still continuing to use, this study. And this right, is a recent study published by Zhu et al. In Lancet, respected journal in 2020, right? This is actually a meta-analysis of various sulfonylureas. And I don't want to show you anything. You can just see from this slide, right? The risk of stroke, you can say, is increased in patients with glimepiride. I can clearly understand hypoglycemia is more, 50% more, right? Severe hypoglycemia. The risk of MACE is increased, risk of myocardial infarction is increased with glimepiride, whereas it is reduced with gliclazide. I think this difference is quite very clear. In a meta-analysis of 232, 67 studies, reviewed, and you can clearly see the difference is quite alarming. I think there's no doubt, and anybody you ask, it's very clear that gliclazide is definitely the better drug for cardiovascular safety, and there is a reason for it. Right? Remember, we talked about ischemic preconditioning. The impairment of ischemic preconditioning occurs because the sulfonylurea bind to SUR1, which is there in the pancreas, and it binds to SUR2A, which is there in the heart, and SUR2B, which is there in the smooth muscles. Right? Now, what happens with SUR2A is that when you activate SUR2A in the heart, that impairs the ischemic preconditioning, and that is the ischemic recovery, which is there. And just I want to show you this chart, right? Again, I want to show you this table. The ratio of what you see in the extreme right, the ratio of SUR1 to SUR2A specificity. Just look at it, right? In gliclazide, it is 16,000. So it is SUR1 specific 16,000 over SUR2A. Whereas if you take glibenclamide, it is 6.4 and glimepiride is 1.35. So the specificity of SUR1 to 2A is clearly less. With glimepiride, it is 16,000 less. There is no reason to understand, definitely glimepiride is going to have cardiovascular risk, right? Nobody is going to do a dedicated CV trial with glimepiride alone in this era. But if it is there, I'm sure glimepiride will be out of the market. That 40% market share will clearly go away. There is a signal. There is a risk signal, right? We need to be aware of this, and we need to, consider this when we use it in our day-to-day practice. I'll show you some practical benefits. And before that, I don't know if Dr. Meenal follows cricket, but I think these two twins are very famous, right? This pair of twins is very famous. This is Steve Waugh on the left and Mark Waugh on the right. Why I'm bringing this point? Because, Steve Waugh and Mark Waugh, when they started their career in a very similar way. Both were very talented batsmen, and in fact, all-rounders to say the least. For Australia, in fact, for a lot of time, everybody knew that Mark Waugh, including Steve Waugh, knew that Mark Waugh, his twin brother, was a more talented batsman, right? He was considered in the line of Brian Lara and Sachin Tendulkar at that point of time. However, who had a longer career, who scored more runs in Test and One Day, who is considered a legend in cricket? Steve Waugh and not Mark Waugh. Why? Because Steve Waugh is a better team player, right? And he's a better person to deal with for the team. He plays for the team. He plays for Australia. Whereas Mark Waugh has always been told that he plays for himself, instead of playing for the team. And hence, whose career lasted longer. And, this is what happens with glimepiride. The problem with glimepiride is that when you add glimepiride as a part of a treatment regime, that's why, you yourself showed me that when the HbA1c in a guide study was higher, you had higher hypoglycemia. The reason is because when you add, in such cases, you add a sulfonylurea, you tend to have more hypos and hence tend to have more glycemic variability with glimepiride. That is what happens with glimepiride. Glimepiride is not a very good agent to add as a part of a team, right? Whenever you intensify the treatment on a patient already on glimepiride, you tend to develop hypoglycemia. This has been seen in a lot of CGMs, in our own clinics and elsewhere as well. And the titration of glimepiride is also complicated. Every time you titrate, there are some people who respond more to glimepiride and hence end up with more hypoglycemia. And I'll show you some real life cases of how easy it is to titrate. This is a young patient who presented to us with diabetes. He was on glimepiride 3 milligram with metformin 1.5 gram. His HbA1c, you can see, despite this, he was of course obese and all. His HbA1c was still 8.4. Young patient, 32-year-old. The other parameters also you can clearly see. He was also intolerant to metformin, so this is a thing. And what we did was we started him on gliclazide, SGLT2, and so on and so forth. And what we did was we titrated his gliclazide. So you can see he started with 180, fasting sugar, and then we increased to 1.5. And you can see by end of almost 15-16 days, his fasting sugar went down to 135. After doing this, right, we did something very interesting. Sorry. After doing this, we put a CGM in this patient. And this is this patient CGM after the fasting sugar was fixed with a titrated dose of gliclazide. And you can see 119 is his average sugar, beautiful 96% time in range. This is a patient with HbA1c of 8.4, right? Who comes, and this patient now on follow-up, I'm sure we'll have an HbA1c. Of course, this follow-up 2-3 months has not been completed, but I'm sure his HbA1c will clearly be less than 7 very easily, right? So this is the practical use of it. And most importantly, right, we talked about why it is not there in America. I don't care why a drug is not there in America. There are many drugs which are not there in America. There are many people who are not there in America, right? United States is not a benchmark for anything. If you want a benchmark for safety, follow Europe, not United States, right? United States is always influenced by money. It is less influenced by people's safety, right? But if you talk about guidelines across the country, and you can just check this up on, right? I'm not putting those guidelines there. You can just check this. Every single guideline outside an American guideline, Indian guideline, Canadian guideline, European guideline, British guideline, all of these guidelines have the preferred sulfonylurea as gliclazide because of all these benefits we saw. That is the benefit in terms of cardiovascular risk reduction, which cardiovascular safety, which we clearly saw over glimepiride, less hypoglycemia, 50% less hypoglycemia, less weight gain, better titrability, and better long-term durability. All these factors make gliclazide definitely a better sulfonylurea, and it's, I think, in today's world the only sulfonylurea which is worth continuing to use because of the various benefits it has. And I'll just point out before we go into rebuttal also, Dr. Meenal showed us a lot of studies about atherosclerosis and inflammation. Just look at those papers. All of these are animal studies. All of them are animal studies. And if you want animal studies on gliclazide, I have hundreds of animal studies on gliclazide which prove everything, that it is probably, Jesus resurrected, you would say, in today's world, right? That is the thing, right? So I think end of the day, we have to move out of those animal studies in the labs and move out to clinical practice. And in clinical practice, tell me one study where glimepiride has been shown to reduce cardiovascular risk, right, to the level which gliclazide is probably, there. And so with this, I'll conclude, right, and I'll go on to the next stage.
Wonderful, Dr. Lakani. I too accept with you. I drive a Jeep. I don't say Maruti is better than Jeep because it's not only thing popular things will do, but glycoside has many advantages like renal safety. In many Indians, they don't come for follow-up.
Yeah.
And particularly, they use long-acting sulfonylureas. They land up with renal problems and they don't come for follow-up all the problem. It's an excellent presentation, and Dr. Vijay Shah will give some remarks.
I believe my opinion does not count here because the fight is still on, and I think it is better I allow Dr. Meenal to fight her last stand. The last stand is still not over, and so over to Dr. Meenal. The time for rebuttal is yours, and give a strong fight. Yes.
Thank you, Dr. Vidit sir. And sorry, Ram sir, before the debate is over, the chairpersons are not supposed to take sides. So I'm with you. You said you are in favor of Jeep and the number is less. So the market does not decide, the popularity does not decide. You know that Nano is also pretty less nowadays. So that does not place. Popularity does not decide the benefits of anything. Dr. Om, he began with Mercedes market and he also ended with saying America is a money guided. So Mercedes should be quite popular there. So what do you say now? Mercedes is better or Alto is better? See, it is not market which is guiding us. We are guiding the market. We as physicians are the prescribers and we 40% are the prescribers of glimepiride. So we decided the market, number one. Number second, you said something like it's Mercedes equivalent. So you think glycoside is very pricey, that is why we are not prescribing? No, it's not very pricey. It's a very economical molecule. Thirdly, you said I was comparing it with glibenclamide because the studies with gliclazide are not many, number one. And another thing is they are not even approved as per the protocols. There are very retrospective data available and not actually as per the RCT protocols also. Then you said, quoted again the guide trial and the hypos of the guide. And I already told you the hypos in guide was a comedy of hypos. So going back to the data, they did not even count the hypos which were documented by, not even documented by glucometers. They were self-reported hypos. They were not even included. Nocturnal hypos were not taken into consideration. So guide trial is still not published. It is facing many challenges. Why it is getting a rejection every time? I don't know. Maybe you can explain. Then you said it is a third generation sulfonylurea in a modified form. The term uses modern sulfonylureas. It is not a third generation. That does not make it a third. It is a modern sulfonylurea now. Then another point you said, if a patient coming to you, you are feeling very pity, very panicky about patients not able to reach to you because of hypos on the street. And you yourself use the word because of high doses, unusual doses of glimepiride. So who's giving the unusual and high doses? We, the physicians. Glimepiride is not the molecule who's getting into high doses. We are prescribing high doses. So we are at fault. We have to know how to prescribe a molecule. Then you said a molecule which is pill burden, like it is the benefit of glimepiride is OD dosing, the long acting molecule, and that is what we are looking into. Patients do want a reduction of pill burden because a diabetic patient is already having a long prescription. Another thing we are trying to, why did why did gliclazide go for a makeover? Tell me, why do we have a modified release, sustained release, extended release? Why did we go for a makeover? Because we were trying to make something like glimepiride, long acting. So we are trying to mimic something. We are trying to copy our role model. So glimepiride is the role model for gliclazide, is it? Okay. You quoted Braunwald. Probably you have been studying the chapters. Read from the top. It just quotes a Danish registry. That is just one Danish registry. And Denmark is a very small nation. So we can't go by Danish registries. Then you said something called nephropathy in advanced trial. Yes, there was a reduction. Did gliclazide do it? No. It is the good tight glycemic control. And any tight glycemic control will give me the benefit of nephropathy. So that is since UKPDS we know it. And then you said the CVOT trials. Yes, glimepiride is the comparator molecule. A molecule becomes a standard comparator. Why gliclazide is not the standard comparator in most of the CVOTs? Advance was not a CVOT. It was a retrospective data. It was a clinical based study. It is not a CVOT. Then another, you tried to make the house fused by giving the molecular structure, the receptor affinities. Probably again you confuse the house by hiding the fact that the binding to 140 kilodalton part of the molecule is not there. With glimepiride, it binds to the 65 kilodalton molecule. And with the binding of 65 kilodalton molecule, it gives us the rapid binding, and at the same time, it also gives me a rapid dissociation. So the what you call the hypoglycemia is not there. Weight gain is not there. Then coming to your clinical scenario, you showed us one patient. That patient you removed from glimepiride and you added Jardians. So you did not tell us that the benefit was because of SGLT2I. It was not because of gliclazide. Another thing, you said you controlled fasting by gliclazide. How do you do that? Please teach me. So I think that's all for the day. And Mercedes, again, you said is a biased figure. I have a Honda City, average one. Thank you so much, sir.
Yeah, I think, thrice you said that guide is not published. Here is the published. I don't know if you can see, this is a published version of guide. So guide trial is published. I think, if you want, I can send you the full text of the guide trial. It's a published trial. Secondly, I'll just go to the gross fallacies first. The advanced trial is a prospective randomized control trial, right? It's a prospective trial. And yes, it looks at intensive glycemic control, but the end result was that both the groups had similar glycemic control, right? And in one group, you still, despite having similar glycemic control, you had cardiovascular, you had renal benefits, which was not seen with the other group. And this is the same model which happens in any trial, right? Whether it is a advanced trial or whether it is an empiric trial, the glycemic equipoise is maintained. And then you have say that the only differentiating factor in the two groups was the sulfonylurea. And then you can say that a sulfonylurea is better than the other, or you can say empagliflozin is better than a placebo, right? So the same model has been used in the advanced trial. Coming to the other parameters, hypoglycemia. You are saying that 50% reduction of hypoglycemia is not a factor. What matters, whether the patient, it was certain hypos were calculated, certain hypos. End of the day, if a patient has a self-reported hypoglycemia and it comes to you, especially in India, how many patients are going to continue the same therapy when he has to come to an emergency with a hypoglycemia, right? So, and finally, you talked about 40% use in India, right? What I'd like to also tell you, this is the unfortunate part, right? Our average HbA1c is worse than anywhere in the world, right? our overall glycemic control is worse than anywhere in the world. Our overall, risk of cardiovascular disease, our risk of, renal diabetic related complication is worse compared to anywhere in the world, right? So do you think what we are doing, 40% of our patient, people we are prescribing glimepiride, are we doing the right thing? That's the most important question, right? So even though we may be doing it, we may be doing something wrong. And why should we be proud of doing something, 40% of doing something wrong, right? And finally, you talked about fasting blood sugar reduction. I think, you'd like to see that, as I showed in the trial, that fasting blood sugar reduction is quite remarkable, quite significant with modified release or extended release gliclazide, right? In fact, all the sulfonylureas who are long acting, all of them have good fasting blood sugar reduction, right? This is in fact basic, I think, SU 101. Right, you have good glycemic, good fasting blood sugar reduction with all long acting gliclazide. Yes, I understand that gliclazide has been made long acting because of its initial, right? Now it's a modified release preparation, but that's the preparation we use in practice, right? Why you want to go to an older generation, right? I mean, currently we are all using a modern computer. We are not using Pentium 1 with 4 MB RAM, right? We are using a new, I think I'm using an Apple, which is also not that great. We are all moving to a better, thing, right? So you should compare with what is current and rather than compare with anything which was outdated, right? Finally, I mean, the point about hypoglycemia and, weight gain, you yourself concluded that it was compared with glibenclamide. Now, like I said, I completely agree. I completely agree with you 110% that glimepiride is a better drug than glibenclamide. There is no doubt about it. You don't need to prove it to me. You don't need to prove it to anybody in the audience, right? That is sure. But I'm sure you'll also agree that the similar studies were done with gliclazide and glimepiride, where gliclazide came better, which is the guide study, right? So you have all these data available. And in that sense, I would like to tell you again, in a practical sense, right? We may not always be doing the right thing, as a crowd source. When we look at, what people are doing across the world and whether that's a proof of what the thing is, we are, currently, remember that 40% also includes doctors who are working in periphery, doctors who may not be that well trained in diabetes management. We are really well trained in diabetes management. We understand data, and just because the crowd is doing it, we continue to do that. I think that is wrong. We perhaps need to look beyond it. And yes, talking about money-minded Americans, right? Mercedes-Benz is definitely more popular in United States compared to Indian car like Alto. I don't think it's even available there, right? And because Alto is not available, does it make it an inferior car? Well, I don't know. I think talk to about 80% of Indians who own an Alto. So I think with this, I'd like to end. And thank you so much for the wonderful debate. Thank you.
I think if I wanted to ask two things to both the speakers. So first of all, excellent debate, and I thank Bansi Bhai for having this talk, allowing this talk, because most places we don't have a direct head-on with glimepiride and gliclazide, and a lot of learning comes out of it. So I have a question and a practical question to both Om and Minal, and this is beyond the debate. I think the debate, we understand the debate restrictions. So I wanted to ask a question beyond the debate. There is, see, I trained in England where I had trained in gliclazide. I never used glimepiride. When I started coming to India, gliclazide, one ek do company banata tha. I had to retrain myself in using glimepiride, and I was very lost initially. And then I found my feet. What do we do? So there are two things that is established practice in India, and I want your comments on that. I asked this same question yesterday to Uni as well. We do split doses of glimepiride. It's common practice to prescribe 1 BD or 2 BD or split doses morning and evening. Is that good practice? Something to take home, both the speakers. And second is, if we look at patients who have renal impairment or patients who have unpredictable hyposome, and we want them to give gliclazide because glimepiride is a longer acting version, should we go for a morning version, one dose short acting version, or should we the modified release ones? Some of them, they are not coming as core tablets. We can make it score. So should we be splitting those to actually get a practical tip out of it? So I just want both the speakers' comments on that.
Yeah, I think as far as splitting the dose and giving it at one shot, I think it's a very Indian thing. We see it in many medications. For example, if you take about carbimazole, right? Now you can give carbimazole 30 milligram straight in the morning, right? Instead of giving it 3 times a day. But common practice, including me, 10 milligram 3 times a day. That is what we do, right? I think it's a practical sense. And perhaps I would say, the patient feels that ek saath all medicines have been given. That is one. Some people feel that I have to take all the medicine in the morning. I don't have to take one in the afternoon. There's nothing in the afternoon. There's a slot open in afternoon. Why don't you add a medicine there, right? So that is what people kind of generally believe, and that's the reason. I think that's the only reason why there is no scientific basis to it. And there's a psychological basis to it, that we kind of give it twice a day, or whatever. And so that's the only reason, I would say. As far as the renal failure and glucose is concerned, I still don't I would still suggest using a modified release or extended release form, because that is clearly the absorption is much slower. So the risk of that sudden hypos is much less with gliclazide when even in a renal failure patient, right? So I would continue to use it, and it does not have predominantly renal excretion. So again, the whether CKD impacts the half-life of glimepiride of gliclazide is not there. So you won't have to worry about it. The CKD is not going to influence it. Yes, the endogenous insulin production will have half-life which is longer, which is again a reason for hypos in any of these cases. Even without any drugs, CKD patients do develop hypoglycemia. So that is known to happen. But having said that, if the patient is on a medication and starts, developing progressive renal disease, which generally does not happen with gliclazide, as you saw from advanced trial. But if it does happen, I think, all it requires is dose modification, and, very rightly said, you can score the tablet and you can half it and whatever, you can do that. I would not consider switching to a simple non-modified gliclazide. I'll continue to use an extended release or modified release one, albeit with a lower dose if necessary.
Thank you. Mrinal, anything from your end?
Just to add to what Dr. Om said, like what we are preferably doing is that we are beginning as a BD dosing, because we try to understand by the evening what are the sugar levels and what dose of glimepiride is suiting my particular patient. I may not make my patient land up immediately with a hypo. If there's in case of a hypo, I can skip the evening dose. So that is the idea of splitting the dose of glimepiride initially when we begin any new patient coming to us. But once you are comfortable with the final dose and you are stable and the patient is stable on 4 milligrams or 3 milligrams of glimepiride or whatever, then we can shift the patient to OD dosing of glimepiride. No issues with OD-BD dosing. And as Dr. Om said, yes, there was initially a concept that patient was more comfortable in following the same tablet morning evening, because what we do sometimes, because we are giving our metformin twice, or we are giving voglibos twice or thrice, but we are giving glimepiride once, so we have to split the molecule. Now with the FDCs, it becomes very easy to explain and counsel the patient that same molecule has to be taken twice, morning and evening. So as a feasibility concept, as a clinical practice, splitting is more of to our compliance and to make ensure the compliance ensured from the patient rather than the scientific basis of it. The scientific basis is that he has to learn the exact molecule before we fix up the strength of the molecule for my patient. Then we go for splitting so that we know before he lands up with a hypo and he's already taken a large dose in the morning and he's landing up with a hypo in the evening or late night. So let's first confirm the strength of the molecule that we are prescribing to our patient. So that is one reason why we split. And of course, the second part, as Dr. Om said, to hit the psychology of the patient, that same tablet has to be taken twice. So the counting and choosing which molecule, which drug, which name, which brand, that becomes easy. That same number, the double color wali goli aati hai na, safed or pink. It's a 2-color molecule basically. Whenever there is a glimepiride in combination with the metformin, so the color it's a double-colored molecule, the tablet. So it becomes easy to counsel. So one thing is that. And second part, as you said, with nephropathy, yes, with nephropathy, preferably we do avoid most of the molecules, OHAs. But still, if we want to give, then OD dosing is given, low doses is given, and make extended release, more modified release, like we are hardly using the conventional gliclazides anymore.
So one small question to both again, a brief answer. Is there a marriage between the two? So what is a dose-to-dose conversion? Is there a dose-to-dose conversion?
Exactly. I really don't know the science if there is any, because there's no exactly 1:1 formula, but every patient is individualized, one patient behaving differently. But mostly I would suggest clinically what I have learned is that if the lower doses of glimepiride the patient is taking, the lower doses of gliclazide will also work. And higher doses will convert it into a higher doses. The maximum tolerated 4 milligram of glimepiride might get converted into 320 milligrams of the extended release. But then pill burden, we are still with 60 milligram formulation only. So if I have to go to 120 milligram BD, I'll have to give 2 tablets morning, 2 tablets evening. So the pill burden is definitely there.
Yeah,
Yeah, I think
it's a very excellent debate. I want to say a comment that if the patient is non-compliant, is not coming for follow-up, he is elderly and he has so many problems, I think glyclazide is a better drug. I'm knocking out of the debate. Debate is over now. But I don't know why glyclazide is not marketed, right? But glyclazide is definitely safe and better drug. I feel that. Okay, but glimepiride is marketed, and marketing plays a major role. Like
yeah.
Maruti has many showrooms. Jeep doesn't have many showrooms. Okay, like that. I still like Jeep. Okay, and I want your opinion on Lakani. How far we can go in CAKD? I mean, till what level?
Yeah. So great question, sir. And I'm all for Jeep. I love Jeep. Yes, glyclazide. In when you have, like I said, 30 to 60 GFR, you can go, full dose. In fact, generally in practice, I don't use more than 120 milligram of glyclazide, because I think that any sulfonylurea beyond a point, I think you are just increasing the risk. I would rather use another molecule, because you have so many now, and insulin if necessary, rather than keep increasing glyclazide. And in CKD again, my typical average dose would be around 60 to 90 milligram. That is what I would typically use, extended release one or modified release one. And I generally don't go beyond that, because again, like I said, the endogenous insulin production and the other, less renal gluconeogenesis and all these other factors would impact the patient having hypoglycemia. Remember, some of these patients may be on dialysis, end-stage kidney disease, all these patients. I think SU is not a great choice there. I think you have other molecules and insulin, which might be a better choice. So as you go, deeper into the whole of a CKD, I would really consider using other agents than sulfonylurea in practice. So that's generally my take on this.
Good job by both of you. Dr. Vijay Shah. Sir, unmute yourself, sir. Unmute.
I believe this was the great debate, and we have learned today many things about this two great molecules in the diabetes care. And I congratulate both the contestants, Dr. Meenal Mohit and Dr. Om Lakhani. And I learned many things about cars also. And so, so, so I will consult both of them when I will buy a new car. I think with this, we'll move to the second part of the debate. And
Thank you very much.
again, we have a very interesting debate coming to us, and that is about long-acting insulin. And I'll ask my co-chairperson to introduce the debate and the first contestant. Over to Dr. Ram Kumar.
Yes, sir. Thank you, sir. And can I have the introductory slide, please? Yeah. So we are going to have another interesting debate, like which long-acting or ultra-long-acting insulin is better. And for this, we have Dr. Piyush Desai. He is going to talk about the insulin, which is he had passed MBBS and MD from Government Medical College, Surat. He did postgrad diploma in endocrinology from University of South Wales, UK. Recipient of Award for Excellence Diabetes Care by RSSOA in 2019. Is a member of American Association of Clinical Endocrinologists. Also part of Committee for Diabetes, Obesity, Thyroid Disease at ACE. Has presented papers in various national and international conferences. Presently working as a diabetologist and endocrinologist at Desai Diabetes and Endocrine Clinic, Advanced Diabetes Surat, and conducting many phase 3 to 4 clinical trials that is interested in clinical research in the field of diabetes and endocrinology. Dr. Piyush Desai, you are welcome.
Thank you, sir. And I think the first debater set the contest, and they have already suggested why glimepiride is used, even though glyclazide is a better molecule, because we follow American guideline, we follow whatever US FDA or ADA suggest. And that's why when I'm going to speak on the content where we are comparing two longer acting molecules, I am going to start with comparing these two molecules with our two recently fought president, that Donald Trump and Biden. So just to start with, we have two basal insulin, which are insulin analog. We have standard molecule that is glargine U100, but now we have U300 and insulin degludec. So I will speak about the basic thing, the initial comparison. Then we have few head-to-head comparison also. And comparing all these things, we have even recent evidences in along with these two new basal insulin. So first start with two molecules, how they are. Insulin glargine 300 is nothing but the same glargine insulin in a concentrated formula so that it becomes longer acting. pH is same, it is acidic, and when it turns into subcutaneous tissue, it becomes precipitated, and that's why because of that concentration, the same injection is becoming longer acting. While in IDEC expert, IDEC that is actually binds strongly with albumin, that is very important point, and it made a chain, and after making chain, it becomes prolonged acting because of the protein binding. So when we have comparison of these two molecules, out of which one is already been used and one is slightly newer agent, we have two studies. That is begin study for this insulin glargine 300 comparing with glargine 100, and we have addition study where we have degludec, begin study for degludec comparing glargine 100, and we have addition study where glargine 300 is compared to glargine 100. If you see the whole data of addition 1, 2, 3 and all, and if you see the overall reading, actually glargine 300 having lower rate of any time as well as nocturnal hypoglycemia in comparison to glargine 100. While in IDEC, in begin study, you can see the lower rate of nocturnal hypoglycemia was there in comparison to glargine 100, but anytime hypoglycemia was not changed. Why? Because of this beautiful slide, which is explaining the day-to-day variability of this PKPD data, where glargine 300 was found to have 20% lesser within day variability in comparison to IDEC 100. And that is very important because it is significantly, statistically significantly 20% lower. And if you the real world evidences, we have real world evidences are also there where
itu ખબર છે મને
reduction of
આપડા હાઈ સ્કૂલમાં હતું ને
please mute other people, it is disturbing.
કેમ કોઈ બોલે છે ને આપણે પૂછ્યું હતું કે
Dr. Akash, please mute yourself.
Yes.
Reduction of HbA1c was comparable. Achievement of HbA1c goal without hypoglycemia is quite similar. It was not at all different. So real world evidences suggest that overall impact, because we want this designer insulin, we want newer generation insulin just because of two things. It is not increasing the potency. HbA1c reduction is going to be same. But how many patients achieve HbA1c less than 7 without hypoglycemia? That is the crux of using newer insulin. And you can see that deliver naive patient where real evidences suggest that overall hypoglycemia, in-patient related hypoglycemia was quite comparable with glargine and degludec, but in-patient hypoglycemia, slightly U300 was favorable. So if you see the basic pharmacology, there is definite 20% less variability as far as glargine is concerned, glargine 300 is concerned in comparison to IDEC 100. I am not talking about 200. So please don't compare 300 with 200 where the data are slightly different because we are using IDEC 100, not 200. The trial level meta-analysis suggests that begin trial was found only superior as far as nocturnal hypoglycemia is concerned, while addition trial found even day-to-day diurnal and nocturnal hypoglycemia was lesser with U300. And real world evidence with deliver study, it was found comparable and it was not having much difference as far as HbA1c reduction and overall hypoglycemia is concerned. So now we, for final verdict, we need head-to-head clinical study. So we have two study, that is BRIGHT study for glargine 300 versus IDEC 100, and we have conclude study with 200 degludec. This is the BRIGHT study where glargine 300 was started with 0.2 unit per kg and IDEC was started with 10 unit per as per the labeling information, and they were studied for another 24 weeks, and there was a 7 days of post-treatment period where glargine 300 was found non-inferior to IDEC 100 as far as A1C reduction is concerned. But if you go in detail, during the titration period, so first initial 12 weeks when the titration happened, 13 to 24 weeks, that was a maintenance period. During titration period, the confirmed hypoglycemia less than 70 as well as less than 54, glargine 300 fared better in comparison to degludec 100. And even nocturnal hypoglycemia, they were quite similar as far as incidence rate is concerned. Event rate was slightly better with insulin glargine 300. So incidence of any time confirmed hypoglycemia either less than 70 or 54, it was 26 and 37% less respectively. Event rate of any time of confirmed hypoglycemia less than 70 and 54 was 23 and 43% less. And event rate of nocturnal confirmed hypoglycemia was even 35% less. So in this particular study, glargine U300 fared definitely better than degludec U100. Now we have another study which is head-to-head study, but it is with degludec 200, where there was a titration period of 16 weeks. Maintenance period was going on up to 36 weeks, and the last 2 weeks was the proper maintenance period. But during this time, there was defective blood glucose meter in initial titration period. Even in the maintenance period, there was a variable rate of changing defective glucometer to a functioning glucometer. So actually, the US FDA allowed only the last maintenance period result for calculation of events and giving result. So during this 36-week maintenance period, actually there was hardly much difference except the severe hypoglycemia, but overall symptomatic hypoglycemia was not significant. And the primary endpoint here was to have lesser hypoglycemia superiority study in comparison to U300, which was not found. So this trial, the basis, the facts, and the acceptance was very poor with this Now, we have a few recent advances also. As Donald Trump is saying, he mocked a man with a disability, just mocking, while Biden helped a boy with disability. And that is the difference between these two molecules. We have number of patients with CLD and CKD who are having hypoalbuminemia. And we have clear-cut evidence with insulin glargine 300 in comparison to IDEC that because it is not bounding much like IDEC, as far as albumin and protein is concerned, variability and the hypoglycemia risk was statistically significantly reduced with U300 in comparison to degludec. And you can see the time in range, which is quite similar with very less nocturnal and severe hypoglycemia in patient with type 2 diabetes, where U300 and IDEC was given with CGMS for 5 days on each insulin treatment. This is again a good real world study by Kawaguchi. Now this suggests not only patients with hypoalbuminemia, with type 2 diabetic patient, we have studies. This is, you can see the Yambe study where significantly lower nocturnal hypoglycemia was found with glargine 300 on CGM. So this is very important. We have clear-cut evidence is available. And I think with this, Biden has knocked out Trump. And over and above, over the top of this, we have one care data which was presented in ESD 2020. This is the recent data that effectiveness and safety of glargine 300 in comparison to degludec 100 for continuous glucose monitoring profile in adult with type 1 diabetes who are most insulin sensitive in comparison to type 2. And you can see that patients who were on previous insulin, which were shifted to either glargine 300 or degludec, and the primary endpoint was to see how many percent of the patient were having TIR, time in range between 70 to 180, 180, and secondary endpoint was to see the percentage of TAR, that is time above range, and percentage of time below range, that is TBR, as well as overall safety. And result suggests that similar TIR, TAR, and TBR profile was found in both the insulin. The difference is of nighttime period was favoring insulin glargine 300 for TIR as well as TR. So it is not always about hypoglycemia. It is about keeping period of time in range and not going to time above range was also better with insulin glargine 300. And I think after all these points, Biden is clear cut winning. So verdict that newer insulins have better safety profile in comparison to older generation basal insulin, that is U100, definitely yes. But by PKPD profile, by BRIGHT study, by OneCare study, we have superior basal insulin, that is insulin glargine 300. And recent study has even showed better evidences with patients with hypoalbuminuria also. So with this, I would like to end. Thank you.
Thank you, Dr. Piyush. Your speech is sweet as your name. And Dr. Vijusha, do you want to make a comment? And
I think Piyush has opened the match very well, and it is interesting to see uh, how the other participant bets against this in this speech. And uh, I would like to introduce Dr. Will you please project the slide of introduction? So to counter Piyush, we have Dr. Sunil Kumar Kota, who is a consultant endocrinologist from Behrampur, Odisha, and he has huge uh, work to his credit. He is the best letter to editor trophy for SECON, and he is receiver of many awards, and he has done some good uh, national and international uh, research work, and he has received RSSDI 2020 award for the best innovation in the diabetes care during challenges in the times of COVID-19. And Dr. Sunil Kumar Kota will pitch the other molecule against uh, glargine U300. Over to Dr. Sunil Kumar Kota.
Thank you so much, sir, for this very kind words of introduction. First of all, very good morning to the respected chairpersons, to the august audience, and at the outset, thanks to the organizers for having me here and asking me to talk in favor of the molecule degludec after that wonderful deliberation in favor of glargine 300 by Dr. Piyush, sir. So I would rather like to put it across this way. This is a debate between the delightful and depthful degludec versus the so-called and the self-projected gorgeous glargine. So what I think, it is a debate between something which is a redefined molecule versus a refurbished molecule. At the outset, I would like to also make it very clear that don't expect any slandering business between us, because we all are in favor of science. हम science के तरफ से हैं, as per this famous scene in the movie Three Idiots. But it doesn't stop me from going back to the age-old classic by William Shakespeare about this classic movie, which is the Much Ado About Nothing. We all understand the mechanism of protraction, which has already been alluded to by Dr. Piyush sir. The degludec forms stable multi-hexamers. Then glargine U300 is a up concentration of insulin glargine, giving rise to larger precipitates and thereby translating into slower rate of absorption. Supposedly you are on a journey and you get a bumpy ride at the outset itself. Are you going to proceed with the journey? At least I am not. And let me take you back to 2015, where glargine 300 is compared with that of its predecessor unit U100. This is the steady state pharmacodynamic properties in type 1 diabetic patients. And surprisingly, the 24-hour glucose lowering effect of glargine U300 was 27% lower compared to unit 100. Now we are, of course, indulging into a basal debate, and let us look at some of the points when we talk about when we try to distinguish rather between two molecules. First of all, what is its efficacy in terms of A1C reduction? What are the additional benefits in terms of hypoglycemia reduction, addressing the glycemic variability, and what about its usage in special population, especially patients having renal impairment, and what about its usage in different set of population where insulin is used naively or used on top of another insulin, and also whether it can be given in form of co-formulation, whether it can act as a team member. So this is the again the study, the glycemic variability study done by the Novo Nordisk team in the 2017, a double-blind crossover randomized study, 1:1, 60 patients of type 1 diabetes. Initial period 0.4 unit per kg degludec versus U300 was given. Then with a 7 to 12 days of washout period where the NPH was used, again at 12 days, there was, you can see there was a switch from degludec to glargine and glargine to degludec. And very importantly, at the bottom, please have a look at the number of clamps used during the study period. It was 3 clamps during both these study periods. And the primary endpoint was to look at the day-to-day variability, which was 4 times lower in favor of I-degludec, that is the day-to-day variability. And if you look at the day-to-day variability during 2-hour dosing interval, bearing initial 2, that is 0 to 2, and the last 2 hours, that is between 22 to 24 hours, during rest all hours, the degludec is significantly scoring better in terms of reduction of glycemic variability. And if we talk about within day variability also, the degludec is 37% having 37% lesser chances of within day variability. And when we talk about the potency, which is largely missed out from my predecessor's talk, the glargine U300 had a 30% lower potency compared with degludec. And another secondary endpoint, the distribution of glucose lowering effect in 6-hour intervals. You can see the glucose lowering effect was evenly distributed in patients receiving degludec. It was somewhere between 24 to 26%, but in patients receiving glargine 300, it was wide flung between 17 to 35%. So they go on to conclude that degludec had a 4 times lower day-to-day variability and 37% lower within-day variability compared with glargine. Degludec had a more stable and even distribution of glucose lowering than glargine 300, and glargine 300 had an estimated 30% lower potency compared with degludec. Of course, it is going to face a retort by the competitor. This is the Sanofi study, which Sir was rightly alluding to in 2018. 0.4 unit per kg per day at this particular dose, glargine 300 provided 20% less fluctuation, that is accepted. But the entire study period used only 1 clamp, wherein Novo used 3 clamps during the study period. Surprisingly, when the dose scaled up to 0.6 unit per kg per day, the difference was not statistically significant. Now let's have a tabular differentiation between these two studies. The day-to-day variability was 4 times low with Novo Nordisk, which was not studied by Sanofi. There was no switching between the molecules in Sanofi, wherein in the Novo Nordisk study, you can see there was a switch and 86% patients showed improvement when switched from glargine to degludec, and it started worsening when they were shifted from degludec to glargine, which was not happening with Sanofi study. Only parameter studied was within day variability, that was 37% lower with IDEG in Novo Nordisk study and 20% lower with this Sanofi study. You look at the p-value, which appears more significant. P is less than 0.001 over here, that is P is 0.047. And the confidence interval is 95%, that is used to look at the ambit of this study, which is only 90% in the Sanofi study. And as I already talked about, Novo study has used 3 clamps during the study period, whereas Sanofi has used 2 single clamp. And both these studies have shown there is a lesser potency of glargine. It is 30% in Novo Nordisk study. It is 14 to 20% in the Sanofi study. And yes, sir has rightly alluded to the trial level meta-analysis published in 2018. But the basic demerits are that there were important differences in the methodology employed between the begin and edition. So they cannot be compared head on. In fact, it would have been a better meta-analysis had there been patient level data incorporation, but only this study was taking into account trial result level meta-analysis. So it cannot be a source of definitive comparison of glargine 300 versus idegludec. And look at the DEVOTE trial. At least the degludec had guts to do a CVOT comparing itself with ideg versus glargine 100, which also analyzed severe hypoglycemia, and it was significantly lesser in favor of degludec, having 7,637 patients. But we do not have similar clinical trial comparing glargine 300 versus its own predecessor glargine 100 in terms of large sample size and duration. And renal impairment, of course, studies have stated that whenever the albumin level goes down 3.8 grams per deciliter, probably degludec is not a good choice to go ahead. But there are studies on the contrary as well. This is a clinical pharmacologic kinetic study in 2014. It says that the ultra long pharmacokinetic properties of insulin degludec were preserved in subjects with renal impairment. In fact, even in patients having ESRD with or without hemodialysis, the parameters studied were absorption or clearance, total exposure, and steady state PK profiles, which were very similar. So they go on to conclude that patients having impaired renal function, they do not require degludec dose alteration. This is very recent, in April 2020. In fact, it has tried to switch from the existing form of basal insulins, glargine 100, detamir, and the glargine 300 to degludec. And post switch, there were 3 benefits: better reduction of basal glycemia, better reduction in daily insulin basal dose, and better reduction in hypoglycemia. On top of that, renal function remained stable with a decrease in albuminuria in both the groups. So degludec was found to be effective, efficient, and safe in renal patients with type 2 diabetic and macroalbuminuria. This was a poster presented in June 2016, ADA 2020, Indian group, having Devamalya Sanyal sir as well from Kolkata. A single center retrospective observational study for 24 weeks. 3A, 3B, and 4 CKD were included, and it was found that in the sickest of patients, the insulin degludec had lower rate of hypoglycemia in patients having type 2 diabetic and advanced renal failure. But of course, patients having 3A, the degludec group had higher hypoglycemia attributed to higher concomitant usage of sulfonylurea. So if you talk about more advanced stages also, it is absolutely safe. Yes, I understand that there is a lot of hype and hoopla about this BRIGHT study. They say, yes, we have done some dates. Let's try to take them head on. As we all understand, Piyush sir is a daredevil and risk-taking physician. We all know him. But I failed to find the same in the BRIGHT trial. This study has taken only insulin naive patients. Why not patients who are already on insulin? Because in our Indian setup, these being costly insulins, most of the times what we see is that this insulin is added on to a patient who is already on insulin. That again is not a very uncommon scenario, but that is missing over here. And they have taken the design as a non-inferiority trial comparison to degludec in terms of A1C change. So why sudden the daredevil approach is all of a sudden gone? We all know the results. Sir has rightly told us. But in terms of glycemic control, A1C reduction was similar. Proportion of patients reaching the goal of A1C less than 7 was similar. Overall SMPG was similar. But again, overall hypoglycemia, severe hypoglycemia, nocturnal hypoglycemia was similar, but the titration phase, as sir rightly said, the nocturnal and the severe hypoglycemia was lesser with glargine 300. But I have some questions. You have taken only insulin naive patients. Why don't you try it with patients who are already on insulin? Why do you want to play safe? And are you scared to take on degludec head on in terms of better A1C reduction? You are just trying to prove non-inferiority. And if you are not talking about additional A1C reduction, are we not talking about only something not more than distilled water? But again, for glargine 300, sir has already told us that degludec has its conclude study, but I am going to add one more study, that is the CONFORM study. So we have the CONFORM study, which has tried degludec in insulin naive patients, and conclude study, which has tried to study insulin on insulin using patients. So if I'm whenever the proponents of glargine 300 are asked about quoting studies having better A1C reduction, sometimes the answer is like the one which is showed in the picture. The CONFORM says it is the study done on type 2 diabetic patients who are insulin naive degludec versus glargine was studied. Primary endpoint was to look at the change in mean A1C, and secondary endpoints were the hypoglycemia and the insulin discontinuation rates. You can see overall there was a significant greater reduction of A1C in favor of degludec compared to glargine U300. 30% lower rate of hypoglycemia in favor of degludec versus glargine, and again there was a 36% lesser chance of proportion of patients experiencing more than one episodes of hypoglycemia. And on top of that, let me tell you very clearly that the discontinuation rate was significantly higher with glargine 300 versus degludec. So another knockout punch, I'm going to tell you, that is the conclude trial. Again, sir has already told us, yes, there were some initial hiccups following which it was completed, and that was the degludec U200, which is not currently available in India, but that does not preclude talking about its science because we may have it anytime soon. So maintenance period, overall symptomatic was not different, but the nocturnal symptomatic and severe was significantly better with degludec. Total treatment period, all the three parameters, the overall, the nocturnal and the severe, was better with degludec 200. And in the titration phase, wherein the bright study says the glargine 300 is always better, here we have a study which says that overall symptomatic is significantly reduced in favor of degludec, but nocturnal symptomatic and severe hypoglycemia both are almost having non-significant differences. So there is a 37% lower overall hypoglycemia in the titration phase. So the summary of conclude says the primary endpoint was to look at the overall overall hypoglycemia in the maintenance phase, which was not different. But then in the other two parameters, the severe hypoglycemia and the nocturnal hypoglycemia was significantly lesser with degludec U200. Very significantly, conclude showed there was a 12% lower dose of degludec U200 required. In fact, the bright study, I forgot to tell you one thing, that there was a 20% of less doses required for U200 versus glargine 300. Again, the post hoc analysis concludes says there was lower A1C levels in favor of degludec, but glargine had less weight gain in favor of glargine U300. Something missing is the cost effective analysis study. This is a study of cost effectiveness of insulin degludec versus glargine in type 1 diabetes. In both type 1 and type 2 diabetic, degludec is likely to be associated with cost effective and is associated with incremental cost effective ratio, which is below the acceptable threshold. In type 1 diabetes, the lower cost is predominantly driven by lower insulin cost because of lower daily dose that is required. In type 2 diabetes, the lower cost is driven by lower costs of severe hypoglycemic events due to significant reduction in number of events with degludec. And they are talking about TIR. Yes, we do appreciate the 1K study, but this is a study in type 2 diabetic patients, which says there is a comparable efficacy and the mean percentage of time within the range for both these molecules are similar. So what about approval for type 1 diabetes in India? This is the information that I could gather. The esteemed chairperson or my opponent can always correct me if I'm wrong. DCGI has given approval for degludec, which can be safely given in age 1 year onwards, but the package insert in glargine 300 in India says it is not approved below 18 years of age, though it is US FDA approved. But we all understand that glargine has no role in premixes because of its acidic pH and high zinc content. But there is a multinational consensus statement led by Sanjay Kalrasar, which has guided us about the pragmatic use of degludec and insulin aspart co-formulation. So after presenting all these facts, if my opponent, with due respect, Dr. Piyush sir, still vouches for glargine 300, I think he is trying to just fool us. But again, the chairpersons and the esteemed audience are not here to be fooled. The bright versus conclude. The bright is a non-inferiority trial. Conclude was more daredevilish. It was a superiority trial. But again, the bright was trying to look at only change in A1C. It was trying to point non-inferiority trial, and it was taken only insulin naive patients. But the conclude has taken insulin experienced patients, and we have another study that is the confirm, which has also taken insulin naive patients having type 2 diabetes. So this basically takes to the summary slide. The bright says yes, similar HbA1c and SMPG, but significant lower fasting glucose with degludec. Conclude says lower HbA1c and fasting plasma glucose with degludec. Both bright and conclude say that bright says 20% lesser dose is required for the degludec, Conclude says 12% less doses of degludec is required to get to the goal. Hypoglycemia, Bright says in the initial titration phase, all the parameters are in favor of glargine 300. The Conclude says the titration phase overall hypoglycemia was lesser with degludec 200, but other two parameters, the nocturnal symptomatic and the severe, it was significantly lower with degludec. And of course, the weight gain parameter is in fact in favor of glargine. Yes, we like Sachin Tendulkar predominantly because of his batting. We also like when he does some good bowling, and also like when he does some good fielding on the act. But when he does only good fielding, but he doesn't do the primary action of good batting or A1C reduction, we do not like him. Should be useful at and of benefit of at all stages. By saying that, I mean to say that the glargine 300 has studies in only in insulin naive patients. It does not have many studies wherein it is used in insulin experiencing type 2 diabetic patients. And the glargine doesn't have a team spirit, it seems, and because it doesn't set in with the other analogs to give us a good premix formulation. So thank you all for that patient listening. Over to you, chairpersons.
Sunil, it was very innovative in convincing everyone. And I request Dr. Vidyusha.
I believe the fight is still on, and the fight is fierce. And there were very good points made by Dr. Kota, and now it is Dr. Piyush's turn for the rebuttal. And let's look how Piyush rebuts the ideas put forward by Dr. Kota. Over to Dr. Piyush.
Yes. Am I audible?
Yes, you are audible.
Yeah. So nicely quoted by Dr. Kota. But one thing I would like to say in my rebuttal, first of all, that many times it was written insulin degludec when it was compared to U300. But many times we are missing that what exactly happened, because Trump is always behind Biden, that mail-in voting may lead to fraud. And we all know what exactly happened at last. That this is the study by Hans that insulin degludec 200 produced. I am not understanding that if insulin degludec U100 is so beautiful molecule, then why in this superiority study like Conclude and a day-to-day variability study by Hans, it was IDEC 200, which was compared to 300. That is first answer I want to know. If U100, because in India we are using U100. Though, yes, I am okay if they are introducing U200, but why U200 of degludec was compared to glargine 300 when 100 is available, and as described by Dr. Kota, it's a beautiful molecule in comparison to U300. While we have what study I have quoted is a study with insulin glargine 300 with insulin degludec 100, and that is consisted a real result of 23% less variability. As far as different studies are concerned, yes, we have one ongoing study, that is in-range study, which will give us answer. But till then, number of study, Bailey, Hens, Kawaguchi, Yambe, OneCare, Lucidi, in-range study, out of that in-range is still awaited. Otherwise, except Hens study, it is everywhere the PKPD data are suggestive that U300 is better. So now Biden is scoring all over that. So they come up with confirmed study. Why they come up with confirmed study? Do we use insulin just only for HbA1c benefit? Yes, we do, but that is done by NPH also, that is done by Actrapid also, that is done by many other insulin also. We want designer basal insulin for reduction in glycemic variability. That is exactly we are looking for. They come up with very good result that in a patient where degludec was given in comparison to U300, there was lesser hypoglycemia, but as described by Dr. Kota. But this is the difference between two approach. No one in my family will have an office in the White House, Biden says, and Trump says, because we won't leave. The caveats in this confirmed study that it is retrospective data and not an RCT. The only evidences of prescribed basal insulin available, but exactly how much, when, where they have used like RCTs, there is no protocol was followed because it was more of a retrospective analysis. And there is no details about titration and maintenance period. No baseline data for hypoglycemia, the pre and post values. And very importantly, the dose difference out of these 4,056 patients analyzed, the dose difference, a total of 894 was compared to 376, reason not known. Maybe just because it was retrospective data and we were not having enough data to compare, that's why they have used very small number of patients. For HbA1c change, what Dr. Kota has described us that we need insulin for HbA1c control, then why out of 4,000 only 671 degludec patients were compared to 749 U300 patients? And is this the small number data we are going to believe? And U100 and U200 both were used in this study, but it was not segregated. There is no segregation that this much patient were on U100 and this much patient were on U200. And for change of weight, we are talking today about KG-A1C concept. We are using GLP-1, we are using SGLT2 inhibitor because they improve HbA1c with weight loss. So anything which is causing more weight gain, how we can say that it is going to be a very important or fruitful. And if you see the confirmed data, actually prior to initiation of insulin, glargine U300 and degludec were having different rate of hypoglycemia. Post initiation at 180 days of follow-up, there is no difference. So basically what happens that if after and before and after insulin initiation, insulin does not make sense as the hypos during pre-initiation period has nothing to do with insulin. My opponent was talking about it was used in glargine was mainly used the insulin naive patient, but having hypoglycemia has anything to do with insulin if patient was using before or not when we are comparing to different insulin head to head with a similar kind of population. So this is very important that pre-initiation in hypoglycemia has nothing to do. So if you correct, actually even in conclude study, the difference was not that great. And insulin dose definitely 12% lower with IDEC in comparison to insulin glargine 300. But on the sake of weight gain of 1.1 kg more than basal insulin, then using lesser insulin is going to be helpful. I'm having question for that, and I am not accepting this. As far as bright and conclude studies are concerned, if you compare, yes, that was bright study was non-inferiority study and conclude was superiority study. But what does it matter? The matter is if we can use this insulin in our routine practice. See how many of the patients are on sulfonylurea. And in India, patients who are on insulin, I think more than 50% of the patients are on sulfonylurea. While in bright study, even with patient on sulfonylurea, we are seeing for hypoglycemic rate. And that is exactly happening in our day-to-day study, day-to-day life to our patient, because patients are taking pioglitazone, patients are taking SGLT2, DPP4, and so as sulfonylurea is. So which study correlates more? And I have already shown that conclude study were having defective blood glucose meter for initial titration period. How we can rely on that study? So if you consider all this point, I think even after all this debate, even after Trump has points out that my insulin is better, I think Biden, that is U300, is winning after all, and it is correlating with our Indian day-to-day life patient. That is going to change our clinical scenario. Thank you.
Now for Dr. Sunil to.
Yeah, so I'm not going to use any slides. Okay, so first of all, the first point is why U200 was used when we are using degludec 100. The same question goes back to him because it gets boomerang to him also. Why glargine 300 when you have glargine U100? Yes, they are trying to newer look, they're trying to look at newer formulation. So that itself is, but again, as you have rightly said, it is not available in India, but that does not stop us from learning what we should be having things in future. Second point is, yes, A1C reduction is definitely is an issue, because if you get a newer molecule, primarily it is an anti-diabetic molecule. So that means A1C reduction is definitely of primary importance. If you are getting a molecule which is, by most of the studies are equivocal, or some of the studies are showing lesser A1C reduction, you are not doing any good. In terms of hypoglycemia benefit, you can see the Novo sponsored studies are showing better results with degludec, and the Sanofi sponsored studies are showing better results with glargine. In terms of glycemic variability also, I have shown you the Novo Nordisk study where it has used 3 clamps versus 1 clamp in the study done by Sanofi. So basically it is a company driven study, what we as a neutral physician should try to take it. So molecule having unequivocal equivocal benefits in terms of glycemic variability reduction, equivocal reduction in hypoglycemia, but then with a lesser potency and lesser A1C reduction, then I think I'm going to go with the one molecule which is there with us, that is degludec 100.
Thank you, Dr. Sunil. Dr. Vijisha, your concluding remarks.
I believe both the participants have done extremely well, and these are all. This is the new science developing, and that we are having very long acting basals, and as time will go by, we'll learn about their characteristics and which one to use in which particular clinical situation. And I believe the last word has not been written, but definitely U300 has come up as a wild card. We never believed that our old U100, by just increasing the concentration, will do such better job. And degludec is of course a designer molecule, and I believe that both the molecules have a chance in our clinical practice, and I will I will look very with interest when more head-on trials will come, and that will clear the picture. And in future, I believe both the molecules will stay in our practice, and we'll know more about their characteristics. But in end, I will congratulate Dr. Piyush and Dr. Kota, who have done so well and cleared the characteristic of both the molecules and literature related to them. Kudos to both the participants.
I congratulate both of you, and we didn't leave cars in this also, because Kota showed refurbished and new models, and cars are going to be with us. And as Dr. Vijisha has told us, we'll wait for some more time, and we are expecting 200 also. Then we will
Yes.
have, and our ultimate aim should be the patient safety and his glucose control, affordability, other factors. And we have to choose. And Dr. Professor Sam G.P. Moses always says that we have to tailor make the insulins for the patient's convenience. I congratulate both of you, and I thank the organizers for giving me this opportunity. Thank you very much.
Can
I
I ask?
also thank organizers.
Thank you. Can I ask 2 questions and a comment? On a lighter note, Sunil won't mind me pulling his leg, but Piyush has given him a lot of hair by comparing him with Trump and a lot of money. So that's a great sign of that would be nice. 2 things I wanted to ask, and on the trials and everything. And on a, since the debate is over, I could ask this question. So both of them are more expensive. We have cheaper basal insulins in the market, and is it pragmatic, or would we, for a country like India, that we go down the normal basal insulins, and if hypoglycemia is a problem, then we go down the designer route, because not everybody can have design clothes by designers. We wear normal clothes that we get on the street. And then if pocket allows, and if that cloth is getting worn out, we go for designer models if we're going for bigger parties. So it's a off the debate question, but I think perhaps with the advent of glargine also becoming off patent, the land is open up for better insulination and more insulinization. Yeah, the fight between the two molecules can be, we can get on and we can keep on. And I don't think Piyush Bhai, Sanofi likes the word concentrated. They like the word compact. They keep on saying concentrated nahi bolne ka, compact bolne ka. And also the confidence of the two molecules is, you can see that the debate was not sponsored by either of the two companies. So both of them are fearful if they go on a head as to what will come out. This is what I would say. But your comments on the cheaper, on the basal insulinization, and what should be the actual niche area for these designers and more expensive basal insulin.
Yes. Mithun bhai, for your first comment that cost effectiveness, definitely in India, we are looking everything on the basis of cost effectiveness. And even today, for civil hospital patient where I am attached as an honorary endocrinologist, I am using NPH insulin a lot because that is the only insulin available, and still patients are faring better. But in my routine clinical practice, the standard of care is insulin glargine U100 now. So I think this is the time, because now younger and younger patients are in need of insulin therapy. They need more flexibility. They need less glycemic variability because their day-to-day life is not as good as 55-year-old retired people who were used to be on insulin therapy. So now we need this design in insulin not only for the benefit of hypoglycemia, I will say for a better life, better quality of life, as well as flexibility, which this insulin offers. And when insulin glargine came, 200. At that time, it was also far costlier than NPH insulin. So I think on the more and more usage, this is going to become cost effective. But yes, I will still say the gold standard today is U100. And now I am shifting towards U300 or degludec for the sake of patient benefit whenever it is needed.
Yeah, to second that, actually, Mithun is really on ground on all these fora. But when you see him on the social media, he is totally on designer dresses. I think all of
You haven't seen my. I'll send you the ones which are completely normal.
Well, you need to open up more. Yes, as Piyush sir said, actually, the recent article in Diabetology 2018, I do not correctly remember the exact date or the year. It says basically, in fact, the human insulins, if taken or prescribed carefully, the potency and the hypoglycemia would be as good as the basal insulins or the insulin analogs. So as Mithun has rightly stated, if cost is a concern, and it is going to be a concern throughout our life, again, we have to be very pragmatic in selecting us. But as rightly Mithun has said, if glargine is going off patent, then things are going to change a lot. We are going to take more of glargine 100 into consideration, though we are doing it very often right now. And again, I would agree with Dr. Piyush sir that yes, as we go on using it, probably the cost effectiveness on a long run would also be known to all of us of these two new designer insulin.
And I think what is also happening, Sunil Bhai, is even Novorapid is becoming off patent. So I think we will have more, patient friendly, better, good analogs also available. Like Basaglar has come, which is also good, and there is some price reduction. So, for the patients, there will be a better quality also available with price reduction.
And another advantage is mixing, premix is possible with the degludec. And I feel that if patient can afford, Rhizodec is a good combination because we are solving the problem once a day. You heard about this one injection or something like that. So if you give one injection with a meal, and some people, I'm not saying everyone, because diabetes is variable, it may be beneficial because it's better than 2 injections. Giving glargine and another one injection with a major meal. In that case, Rhizodec is advantageous for few patients, which may be useful.
Yeah, actually, in the backdrop of the RSSD ASI guideline, which has mainly centered on and around the premix formulation. That again is very true. Yes.
And then it's a good, I think Rhizodec is a very well commentative because the skeletal is a good basal. Otherwise, most of them is not a pure basal on which that has happened. So
absolutely,
definitely, I think it has helped.
And I just wanted to have some clarification because I was just going through the net about its approval in type 1 diabetes. DCGI has its notification that degludec is from 1 year onwards, but glargine only I had to rely on the prescriber's information. PI, it says that only after 18 years of age. Any updation from that?
So I think as far as I know, the DCGI was also very recently approved, and off patent people were using it, like Lentus people are using it off patent. In terms of U300, even in the insert of Tresiba, the insert is also not updated. The paper insert is also not updated. वो पुराना छपा हुआ उन लोग भी चला रहे हैं कहीं.
चलो मिथुन नया पिक्चर भेज देना पर्सनल में.
Is Lantus approved in pregnancy? It's not yet approved, right?
No, not yet.
The endocrine society says if someone is on Lantus, continue using it, but don't start it afresh for GDM cases.
Yeah, I think I would agree with that. Somebody who's on any insulin, even Tresiba or anybody who is on it, they don't want to, if it's well controlled, the risks are far outweigh trying to get them uncontrolled and put them on a insulatard or anything.
And I want to ask the panelists, it's out of debate, and we use a lot pre-mixed insulins, okay, mixed or other things. Are these projected sayings that it causes hypos, weight gain? Is it a bit exaggerated or is it true?
Again, a debate, sir, actually.
I think a short answer, Ram sir, would that be, you see, every country has, every company, when they come with a newer product, and they know that the older product is becoming off patent, and a lot of people will be having that product. So I think that is how the story of, I remember when I was in UK, Simon Heller, at that time, the Tresiba had been launched. And Tresima was initially launched as somewhere halfway house between, before pump, because flexibility is there, this and that. Then they came with data that there's no stacking effect and other things. So I think the whole idea of this was, coming up with something to preserve their market. Same with U300, I would say. The whole idea is to preserve their own market rather than anything else. But yeah, I think Mixtard, I remember in England, they had taken away Mixtard one fine day. Suddenly Novo came and said, "Abhi Mixtard available nahi hoga." Flat. There was a huge outcry that happened.
My dear friend, now I think it's time to wrap up this session. We are already 20 minutes late.
No, sir, we are in time. We are on time. 11:26.
4 minutes or hai, 4 minutes or hai, Bansi bhai. But
we are excellent team, Bansi.
Bansi sir को जल्दी घर जाना है लगता है actually.
नहीं,
we are in time.
No, 11 o'clock. Yes, 11:30.
Yes, 11:30. Okay. But we can wrap it up because
no issue. I mean, I'm okay.
Bansi ji, please send us coffee.
Sorry, yes, sure.
So I think that was there, but I think we can wrap up if all of us agree, Rohit.
Absolutely.
I think the speakers have come for the next session. And thank you. I learned a lot from both of you. So, and I will send Sunil Bhai something completely off patent.
Okay, see you all. Thank you. Wish you all happy New Year. Thank you. Bye-bye.
Thank you.
Thank you, Bansi ji. Bye.
Rohit, would request you to start the next session and introduce the chairpersons.
Yeah. So moving on to the next section, we have a very interesting session coming up on the endocrine symposium. And I invite the chairpersons, Dr. Umesh Gedia and Dr. Ramkesh Singh Parmar. So I invite them over to the stage to take up the next session. Yeah, thank you. Dr. Umesh is from Surendranagar and Dr. Ramkesh is from Jaipur. So kindly take over the session, sir, so that we can start with the next session on the endocrine symposium.
So have the two chairpersons joined?
I can't see them.
Yeah, okay. Do you want to introduce the first speaker if they've not joined? I think Rohit.
Yeah.
Hello. Ramkesh is joined.
Yes, sir.
Dr.
Good morning.
Yeah.
Yes, sir. Good morning, sir. How are you, sir?
Please proceed, doctor. We can hear you. Hello.
Hello.
Yeah, please
sir,
proceed, Dr. Ramkesh. Yeah, we can hear you. Please proceed, Dr. Ramkesh.
Please, sir, share the screen of the speaker of today, this endocrine symposium. Uh, Good morning, everybody. Today, this endocrine symposium, our first speaker, Dr. Suresh Damodaran, and he's MBBS, MRCP, UK, CCST in medicine from the London, and he's endocrinologist from London, and consultant diabetes and endocrinology from the Sri Ramakrishna Hospital, Coimbatore. He is honorary consultant in the Delhi Ford Hospital, uh, Plymouth. He has done basic and postgraduate specialty and super specialty training in the England. His special interests are complication type diabetes, diabetic foot diseases, gestational diabetes, insulin pumps, pituitary, thyroid, infertility, endocrine discussion diseases, and endocrine hormone related issue relating to the sexual function. He conduct annual international and national conference DCON and Paradicon every year. He was awarded the Donald D. Ed Biller International Scholar Award presented by the International Diabetes Center, Minneapolis and Minnesota from the USA. Currently an elected executive counseling member of Endocrine Society of India. Currently the vice president of Tamil Nadu Endocrine Society. He was awarded by the International Symposium on Diabetes with India Academy of Diabetes Award for the Outstanding Contribution to Diabetic Education Award on January 2019 from Mumbai. He has presented and published many abstracts and papers in international and national meeting and journals. He is in the mainly advanced glycated end products and arterial stiffness in type 2 diabetes. So please welcome, sir, Dr. Suresh.
Good morning, everyone. Can you hear me?
Yes, sir. This is up to you.
Yes, sir.
Can you see me properly?
Yes.
Yeah, thank you very much for the wonderful opportunity, Dr. Bansi, and thanks for the elaborate introduction. Just next 20 minutes or so, I want to run through a concept of how diabetes is affecting the reproductive function. So if I can, if you look at it, the main thing is sexuality is an important aspect, and normal sexual function, however, it's mainly the interaction, multiple components. There are quite a lot of psychological factors, but however, the chronic medical conditions like diabetes have got an important role to play. So if you look at the type 1 diabetes, almost like 40% of women is affected. The reproductive period is mainly between puberty to menopause. And we are talking about early onset of type 2 diabetes in a woman of childbearing age. So in a male, it can affect causing spermatogenesis affection. So if you look at the fecundity, what it is a natural potential to reproductive and give birth to a life offspring. But fertility, on the other hand, it is a reproductive fitness in terms of offspring born to the per couple. So again, as I said, it's from menarche to menopause, but it is diabetes can affect, that's a late menarche to early menopause. It can affect from anything from that. I'll come through that in a detailed way. It's mainly the high infertility rates is affecting the couples. This is the basic mechanism. If you look at a type 1 diabetes, in the other side, insulin deficiencies, their leptin will be less, kisspeptin, which is happens in the hypothalamus, GnRH, and then LHFSH secretion will be less. So this side, if you look at the hyperglycemia aspect, that will come to abnormal ovarian folliculogenesis and follicular apoptosis and early menopause. It comes to almost like a PCOS morphology. So what is the complex interaction of type 2 diabetes and reproductive function? If you look at type 2 causes hyperinsulinemia, again, as I mentioned, abnormal folliculogenesis, hyperandrogenism, and it goes into the PCOS area. This side, it comes to more of insulin resistance and glucotoxicity on the other side, which will again lead to the same complications as I mentioned. So men, how do you approach? I will give an endocrine flavor to it. If you look at the 41, this is a case scenario, 41-year-old type 2, A1C not under control, hypertensive, diabetic dyslipidemia, BMI is 31, statin, patient is on metformin and Lantus and antidepressant. So before you want to ask quite a few details, but he's saying that hesitantly, normally as in our clinic, people don't talk about the sex, but he was just in saying that sexually is not active. But if you, the further questioning that he's got a ED, which is for past 6 months, and then after his pharmacotherapy workup, he's given a prescription of PDE5 inhibitors. Whether this is appropriate, I want to ask you whether any other possible etiology. These are the questions that I want to ask you. But I think if you look at the mechanism very quickly, the testosterone acts. It's normally bound to albumin and sex hormone binding globulin. It's in the blood from the testosterone 5-alpha reductase, and it acts in the way of dihydroxy testosterone, which is active form. So so androgen deficiency is the main thing, and testosterone is the androgen, and it causes diabetes causes androgen deficiency, causes low testosterone level. I'll come to the mechanism. This is the mechanism. So again, insulin resistance you got in type 2 diabetes that goes to inflammation. And main thing, I want you to remember this, a slide out of my talk, if I can, then there will be leptin production affected, and LHFSH secretion release will be it causes hypogonadotrophic hypogonadism. So the pituitary will be affected because of the fat content, the leptin goes up, and then spermatogenesis is affected, hypogonadism. So it is like a hypogonadism and insulin resistance, both is like hand in hand. Hypogonadal patient will be insulin resistant patient can become hypogonadal. So this is the slide I want you to take in terms of diabetes and reproductive function. So this same chap, we were asking the question whether any other laboratory test and everything. So he is had a testosterone level done, and the testosterone level is 143. But he was given, as you know, PDE5 inhibitors like tadalafil. But on the other hand, he needed something called testosterone, which is the hormone which will stabilize his condition, which is the main etiology. So type 2 causing hypogonadism treated with sustanon. Again, so 3 months later, his symptoms completely got better, and he is much better because his etiology is being treated. So this is one of the learning points from the talk from today's talk. So basically, diabetes can lead to hypogonadism that will lead to other complications. So you have to identify, diagnose properly to go into treating properly. But on the other hand, so controlling diabetes and weight management is also very, very important. And testosterone replacement you can do according to the blood results and also the symptoms what he's got. So mainly men wise, I mentioned for reproductive function, ED is one thing which discussed in many forums. I'll touch base on that. And I've touched base on androgen deficiency, about the mechanism, and but a low libido and balanitis is one of the commonest thing patients present with to urologist and other department, and they just come to you, get referred with HbA1c of 12 or 13, something like that. So ED, very briefly, it is one of the commonest cause, and it progressive. More than 50% of diabetics of men will be affected in 10 years. It's very, very common because of the vascular involvement, and it produces a return of erectile dysfunction. So it is like a microangiopathy, you might be knowing it, and it's a good predictor is just checking the retinopathy and also the kidneys. So age duration is all very, very important in diabetes to check for ED, and normally around 40 to 70 years. For men younger than 40 years, you have to think about other causes as well. And alcohol and antihypertensive medicines are all can contribute to it. So this is the picture that shows about the penis and flaccid penis and erect penis. So this is the mechanism, how it works. Hypertension, dyslipidemia, and diabetes is the main thing, and that will lead to endothelial dysfunction, impaired vasodilatation, and arterial stenosis. Therefore, ED occurs. So by reducing penile flow, how I think the ED has got oral therapy, and it's quite effective. If you look at the studies, almost 268 patients, erections were improved in 57% of patients with the PDE5 inhibitors. So PDE5 inhibitors are great drugs of past 20 years or so. And other treatments are available as a vacuum device or intraurethral prostatin and intracavernosus injections are all available. So these are the things. I won't go into the details, but it is something that you should offer your patients when the drugs are not working. So vacuum devices, on the other hand, few centers does it, and people will be very grateful to you. It is a time tedious process, but still it worth it because they will boost their confidence. So the third aspect is the low libido in men. Low libido is it's like lack of sexual interest. It's mainly possibly caused by low testosterone, and psychological is one of the things. So if you improve the blood sugar, there are cases that you can improve the libido as well. Balanitis, as I mentioned, is very, very common. After urinating, some urine get trapped in the foreskin and you get really itching all over. Antibiotics and antifungal drugs will be very, very helpful. On washing the penis and inside the foreskin with the soap and warm water might help. So especially for patients or our patients on SGLT2 inhibitors, we should advise them to do it. I'm sure that is one of the main advices that we give along with the water intake for SGLT2 inhibitors. So I've just touched based on male. Now, just for a woman, because this is almost like a neglected area. So reproductive function as a whole, it's a broader topic. So if you look at it, early conception wise, delayed puberty, infertility, and PCOS and menstrual disturbance, and during pregnancy, GDM and adverse pregnancy outcome, which is very, very distressing. And then the late complications is early menopause. So for a woman, it can go through from menarche to menopause in a big way. So food classification disorders in women, it can cause hypoactive sexual desire disorder, sexual aversion disorder, orgasmic disorder, and sexual pain disorders, and dyspareunia and vaginismus, obviously, because of less of secretion. Other sexual pain disorders, it all happens. And the mechanisms behind it is mostly autonomic neuropathy, and hypoglycemia can happen in a type 1 diabetic, and low sexual drive and dyspareunia. But the autonomic neuropathy wise, it's a common complication of type 2 diabetes. And what we do is the gustatory sweating, we check for the postural hypotension, ED in a men. But for women, I think it can lead to a poor bladder control and poor vaginal lubrication. So that ends up in really a bad dyspareunia, and poor bladder control affects the nerves. And the woman, normally the treatment is just advise the woman to have a urination before and after the intercourse. But it's well said and done, but it is very, very challenging when the diabetes control is very poor and autonomic dysfunction happens to a woman, and that can affect them very, very much psychologically. So again, as I mentioned, poor vaginal lubrication is one of the main things. If neuropathy affects the nerve fiber that stimulate the genitalia, so that arousal may not occur for making intercourse. It causes very, very painful dyspareunia. The only way to do is KY jelly. You can offer a local anesthetic jelly or a lubrication jelly, and that can be possible. The second condition is the low sexual drive for a woman. Because of psychological factors, endogenous depression is present in type 2 diabetics. The medicines that can affect low sex drive, especially the tranquilizers and antidepressant and high blood pressure ones, beta blockers can affect. So we need to discuss with the patient, and poor sleep also can affect the sexual drive as well. So we spoke about dyspareunia, and superficial pain and deeper pain both are possible, but this could be overcome by lubrication. Again, for a menstrual dysfunction wise, type 1, type 2, if you classify it, 20 to 80% prevalent. Type 2, almost they're all acanthosis, pumpy and everything. So they get into a real trouble with oligomenorrhea, and also endometrial thickening also happens with type 2 diabetics. But I think for a type 1 diabetic, the important point is if A1C increases, the menstrual cycle gets slightly prolonged. And they also get catamenial when the periods were there, the blood sugar can go all around the place. So that can happen with the type 1 diabetes as well. So poor glycemic control, we need to control it properly. Pre-insulin era, it was not happening. There's quite a lot of complication happened, but we had a wonderful discussion earlier with after the new modern insulins and everything, it should be taken care. and blood sugar control should be the mainstay of treatment. So PCOS wise, I very quickly touched base on that, as I showed you in the second or third of my slide, how PCOS happen. It can affect both fertility and fecundity. 1 in 3 patients have it. It is like, I normally say to the patients, it's like a pre-diabetic state, so be careful about it. So if they come for a PCOS checkup, I normally say that. And diagnosis is ovulatory hyperandrogenism and PCOS on ultrasound. That keeps on changing. The recent guidelines is out. So PCOS, again, as I showed you earlier, this is like another cartoon which explains how the anovulatory periods happens. The pituitary gets LHFSH secretion is affected. Therefore, the whole lot of signaling goes into the ovary. Instead of estrogen, more of androgen is produced. So again, the management is quite complicated. Metformin and lifestyle is going to be the key. Along with that, letrozole, clomiphene, and gonadotropins all can be given. And gynec team has got multiple drilling and other few other things that can be part of a management for PCOS. This is a very important thing that get neglected. Hypoglycemia can affect a sexual function, because it uses up large of amount of energy. I think when they do an intercourse, the whole joke of being saying that it is like running about 4 minutes a mile when you perform sex. So, but women should also be aware of hypo during the sex, and they can get the lack of concentration. So this is a very important thing which gets almost neglected. So how do you manage it? I'm sure you all aware of how to manage a hypo, but tight control, tight BP control, stop antidepressant, lose weight. But I think gynecologists as a team, if you work on that, women's sexual function will improve better, in a better way. So make an effort to control the blood pressure and overweight. Commit to this is what you advise to patients: commit to diabetes care regime, and vaginal dryness is a problem. Make use of lubricants and reduce likely of incontinence. So if you advise all this, and hopefully they should follow, and then it will be very easy for the this thing. So I have in the last 20 minutes or so, what I've done is initially, it is a huge topic by itself for diabetes and reproductive issues. For a male, how it affects, it is mainly the erectile dysfunction, which is the commonest thing, which is the vascular phenomenon, atherosclerosis, microvascular disease, and then end up in ED. Very good treatments are available with oral PDE5 inhibitors. And then you can go into vacuum devices and other things, penile implants and other things, if oral treatment is not working. And second thing, very, very importantly, I mentioned a concept of fat cells increasing leptin, and therefore the gonadotropin secretions are affected, and then that will lead to less androgen production and causes androgen deficiency. So it causes diabetes, causes hypogonadotrophic hypogonadism, and therefore the testosterone production is less, and that is one of the main other reproductive issues in a male. And then balanitis and a few other things which comes in a routine practice that we should be taken into account. So I covered that. And when it comes to female, it can be from anywhere to menopause to anywhere from menarche to menopause, anywhere it can be affected. And in female, it gets normally neglected, but poor diabetes control is one of the main reasons. So if we control that, and hopefully that thing should improve. Because of vaginal dryness, they get into a lot of trouble with dyspareunia and loss of interest and other things. And I've also touched based upon hypoglycemia. So these are the very important issues that we should address. Improvement of diabetes is going to be the key. Pregnancy, GDM is a whole talk of its own, but the risk factors controlling is very, very important. But as I say in all the meetings, I think lifestyle is going to be the key, even for the reproductive issues. It is going to be the key that will change the whole lot of vasculature and also hormones that will improve. But people pretend and they don't ask for it. But I think we should ask for sexual history as an important part of our history taking. But I think patient also can, sometimes they don't cooperate and then they will do in their own way. With that, I stop and ready to take any further questions. Thank you.
Thank you, Suresh. Suresh, one quick question.
Yeah.
Total testosterone or free testosterone?
Free testosterone. But the challenge is in India, not only India, anywhere in the world for that matter, getting testosterone assay is a very big challenge. But I think maximum amount of testosterone is bound to albumin and globulin. So we need to do a free testosterone assay to get real values, and we can act on that. And there is actually there is a Google, if you just Google it straight away, there is way that you can do a free testosterone assay. You can put an albumin, you put the testosterone, and you can get a free testosterone levels.
I have a quick question, Dr. Suresh. So, in routine practice, a significant proportion of patients are actually obese with a higher BMI. And if you do a testosterone check in them, there is high probability that a lot of them will have low normal levels of the testosterone. So, in those scenarios, what is the cost effectiveness? Because actually, the reflex, what we tend to do is, if a patient complains of ED, first thing, can we try a trial of PD5 inhibitors? So how cost effective is it to actually screen for patients for low testosterone in the current scenario, because it's an expensive test, and in the current limitations that we have in the practice, do you follow a benchmark as to when do you actually test for low testosterone? How is it?
That's a very good question. How practically you can talk science, but how practical is for India? That's what I think your question is. But I would look at this way, that is that the people who are coming and asking you that you won't screen everyone, definitely not. The people who are coming with a sexual dysfunction and the questionnaire, if they start asking it, instead of blindly doing PD trial, you might want to do gonadotropin and testosterone assay just as a part of screening. It is a one-off values. We are not going to do routinely every checkup or anything. He came up with the symptoms of erectile dysfunction. So like a 30 or 40-year-old or 50-year-old, you won't go for elderly people, but because replacement of androgen in that age group will be very, very tricky. So about 20 to 30 years of age group, like 30 to 50, what I mean is 30 to 50, if you really find they are symptomatic with other symptoms of androgen deficiencies there, along with that, I think if they got sexual dysfunction, by all means do the, it won't take that much cost just for doing once.
Suresh, a question in the chat box, Aquaviron capsule. Should all diabetics get Aquaviron capsules?
Oh, the main testosterone capsule?
Yeah.
I won't use, I have never used it. And the simple reason is it's got its own trouble with the liver. It can, with the studies, I think it showed liver dysfunction. So I don't use it. It's 100 rupees is testosterone injection, 140 rupees. So why do you want to go for oral tablets?
So Rohit, just an addition to what Suresh has said, I think predominantly it's important we ask people a sexual history, because that is cost effective. There is no cost involved. It's one liner as we ask for other things. Food kaisa hai, ye kaisa hai, cholesterol kaisa hai, blood pressure kaisa hai. That is something, if we start in practice, a lot can be started. I'm sure Suresh will agree with that.
No, that is the conclusion I did. I think careful history taking would help a lot in this sexual testing, because people won't open up in the clinic. And if you ask, you will open up a Pandora box. I think they will be, well, at least majority of them will be happy that you brought up the issue.
Yeah, the reason I asked is how, even if you find low normal testosterone levels, how would you actually go with testosterone injections? Would you actually, because that's again a therapy which the patient needs to invest in, right? So do we actually go with, it's okay, low normal is fine? So so do you have a cutoff for that, or when you decide the patient needs to be on testosterone?
Well, I think it has to go with the symptoms along with that. And and what the preliminary screening, what I normally do is a PSA and hemoglobin. just as a prostate specific antigen and hemoglobin. If they are in trouble, if they got urinary symptom, they got a bad sleep apnea, they are really had a lot of trouble, then definitely not for the treatment. On the other hand, they got any history of cancer and other things like breast cancer or prostate cancer history in the family, you don't go for it. But on the other hand, if they are coming with the symptoms and you do find it along with one testosterone assay, and you've done a free testosterone level through whatever method you got, and patient is symptomatic, by all means, it's not expensive drug at all. Monthly once you give 100 rupees, 150. It's not.
I would, so I've done an RCT. If you look at Rohit Blast trial in UK, but what I would suggest rather than Sustanon, the longer acting testosterone preparation is a better, because the variability intraday Sernos is
Right.
much better. So if you want to use that, I think in the event of time, should we move on, Rohit?
Excuse me.
Yeah.
So what is the take-home message? What is the take-home message for the physician? Which subset of patient they will require the testosterone?
What sort of patients? It's mainly, as we discussed, Mithun and Rohit was talking about, it's mainly the patients who are symptomatic, and if you take a careful history, if they are got any signs of androgen deficiency or sign or symptom, along with this definite sexual dysfunction, by all means do a testosterone assay.
Thank you, sir. Let's move on to the second lecture.
Thank you.
Second lecture is of diabetes and thyroid disorder, which is delivered by none other than the Dr. Rakesh Chahai. He does not require any introduction, but he is a professor and head department of endocrinology, Osmania Medical College Hospital, consultant endocrinologist, Sahai's Endocrine and Diabetes Center, Amarpet. He is a vice president Endocrine Society of India and vice president South Asia Federation of Endocrine Societies. Former Secretary Endocrine Society of India, founder secretary South Asian Federation of Endocrine Societies, former chairman of AP chapter of RSSDA and Hyderabad chapter of API, associate editor of Indian Journal of Endocrinology and Metabolism. He is also get the fellowship of American College of Endocrinology in 2009, fellowship of RSSDA 2015, fellowship of Indian College of Physician in 2006, fellowship of Indian Academy of Clinical Medicine 2008, Hatst senior lectureship oration of Association of Physicians of India in 2008. Publications, over 130 publications in various national and international journals, authored chapters in various textbooks and monogram on diabetes and endocrinology. Take over to the Dr. Rakesh Chahai.
Thank you very much, sir, for the kind words of introduction. And I would like to thank Dr. Bansi Sabu and the entire Diacon team for the excellent conference that they're holding. Thank you for inviting me to be here, part of this conference. And I would like to go on with my presentation. My presentation is on thyroid disorders and diabetes. How do they do? What is the link between the thyroid disorders and diabetes? So what I would like to do in the next 20 minutes or so is that, is my screen visible?
Yes.
So what I will do is that what we see is that thyroid disorders are very common. Just like diabetes, we are all aware about diabetes. We all know that we have got 77 million people with diabetes today. We have a significant burden of diabetes. We have been discussing all about diabetes in the last 2 days. But if you look at thyroid disorders, they are also equally common or little less common. I mean, if you compare it to diabetes, maybe a little less than diabetes, but there are 42 million people with diabetes, with thyroid disorders in the country. And so it's a very common disorder. And if you look at all the thyroid disorders, hypothyroidism is probably one of the most commonest, and there's at least a prevalence of 10% found in our own study which we did across 8 cities of the country. We found that the prevalence of thyroid disorders was 10%. And if you compare this with other countries like UK and US, they have a much lower prevalence of hypothyroidism. So we have a significant burden of thyroid disorders. Apart from this, we have a much lower prevalence of hyperthyroidism, thyroid nodules. All these are other issues, are other common problems that are there with the thyroid. So they are common conditions. They may coexist and they may have an effect on each other. So what I'm going to discuss today is discuss about hypothyroidism and diabetes. This is a very common coexistence. Do they just coexist, or do they influence each other? Do they have an influence on hypothyroid? Does it have influence on the manifestations of diabetes? Does it alter the natural history and complications? Does treatment of thyroid dysfunction make a difference in terms of the diabetes outcomes? And how do we then screen and manage this problem? So I'll try to answer these questions regarding the coexistence of hypothyroidism and diabetes. And similarly, in hyperthyroidism diabetes, hyperthyroidism is much less prevalent. It's maybe about 1/10 or 1/15 of the prevalence of hypothyroidism. So here again, I would like to look at 2 or 3 important questions. How does it manifest in people with diabetes? Does it have an effect on diabetes and its complications? And how do we treat it? Is the treatment any different, or how important is it to screen for these problems? So these are the things that we'll try to discuss today. And if coming to the issue about hypothyroidism and diabetes, if you look at, as we said, that these are common conditions. Both are common conditions, so they can just coexist. They could be, are they existing mutually, just coexisting, or do they have an effect on each other? So this is something which you're going to look at. And prevalence of thyroid dysfunction with diabetes is more than that in the general population. So this is the question that we were trying to understand, that if you look at patients with diabetes, the prevalence of hypothyroidism is probably a little more than what is there in general population. So overall prevalence, whereas in the general population is about 10% of thyroid disorders, particularly in the urban areas, rural areas may be little lesser. So whereas when you look at diabetes among diabetics, it is higher, 13.4%. And in different subsets of diabetes, again, it becomes more. So I'll come to that a little later. So what we are saying is that yes, there is a little higher prevalence of thyroid disorders amongst patients with diabetes. And if you look at the prevalence in type 1 diabetes, as I said, type 1 diabetes, if you look at it, then it becomes 31.4%. So type 1 diabetes becomes much higher. And Hashimoto's thyroiditis may be associated with 10% of patients with diabetes. So there could be other forms of hypothyroidism also. Approximately 1/4 of female type 1 diabetes, women with type 1 diabetes develop postpartum thyroiditis. So they are at a very high risk of developing postpartum thyroiditis also. And if you look at different studies like the Colorado study and the enhanced database, they have been reporting prevalence of hypothyroidism to the tune of about 9.5% amongst the diabetic patients, as against the lower prevalence in general population. Again, here, as you said, 4.6% in patients with diabetes. And hyperthyroidism is 2.2% and 1.3%. So this is much higher than what you've seen in general population. General population maybe about 0.1% or a little lower than that. So here this becomes a little higher. A 3.5-fold increased risk of autoimmune thyroid disease was noted in GAD antibody positive patients with diabetes. So those patients with diabetes who have got GAD antibody positivity, they have a much higher prevalence of autoimmune thyroiditis. And positive TPO, similarly positive TPO antibodies being present in diabetic individuals, and they predict the development of clinical or subclinical thyroid disease. So this is again a cross-sectional data from India, which is looking at the prevalence of hypothyroidism amongst patients with type 2 diabetes. What we see is that adult patients with established or newly diagnosed type 2 diabetes, 504 of them, and those with diabetes and hypertension, another 500 of them, were screened for thyroid disorders. Amongst new hypothyroid patients, subclinical hypothyroidism was more prevalent than overt hypothyroidism. Amongst the new patients with diabetes, you can see that 24.8% prevalence of hypothyroidism, and amongst the diabetic and hypertensive group, it was 28% prevalence. So it is much higher than the general population. As we said, 10 to 11% in general population. Here it is 24 and 28%. Then when you look at another data set from India again, this is Vikram BVK and their group. They have looked at thyroid dysfunction in patients with type 2 diabetes at a tertiary care center. And what they reported was that patients with diabetes tend to have a higher higher TSH level. The average TSH level was higher in patients with diabetes, and the T3 and T4 levels were slightly lower amongst patients with diabetes as compared to non-diabetic counterparts. And then this is another recent data from the group at Trivandrum, Dr. R.V. Jayakumar and Dr. Jabbar's group. Abhilash Nair was the first author. They retrospectively evaluated the patients with type 2 diabetes for presence of hypothyroidism and the clinical factors associated with it. They included about 1,100 odd patients in their study, and they found a prevalence of overt hypothyroidism of 9.83% and subclinical hypothyroidism being 5.9%. So if you put it together, it becomes again 14 or 15%. And again, from the same article, if you look at the prevalence, the factors predicting the presence of hypothyroidism in amongst patients with diabetes, what we see is that these factors could be the presence of hypertension, presence of dyslipidemia, and presence of anemia. These are all again significantly correlating with the higher prevalence of hypothyroidism in this group. That is amongst diabetics. If they have hypertension coexisting, they have dyslipidemia and anemia, then they are more likely to have hypothyroidism. So these are people who should be screened for hypothyroidism also. So amongst patients who are insulin treated, that is type 2 diabetics who are insulin treated, it was found that 27.3% of these patients had thyroid disorders. And amongst women who were insulin treated, that is type 2 diabetic women who needed insulin for their management, had 62.2% prevalence of hypothyroidism. Again, see, when you're looking at people who are insulin treated, that means that they have very low endogenous insulin secretion, which could be because of different forms of damage to the beta cell. And if you look at such individuals, they tend to have much higher prevalence of hypothyroidism. So again, this is an interesting observation which has to be kept in mind. So the age at diabetes onset correlated with the insulin-free period. So lower the age of onset, the higher the insulin-free period, the lower the insulin-free period. And now if you look at another study which has looked at the risk factors for thyroid dysfunction among type 2 diabetic patients in a highly diabetes prevalent society, that is in a society which has high prevalence of diabetes in the Middle East, they've looked at the various risk factors for thyroid dysfunction, and they've categorized them as family history of thyroid disease, female gender, and duration of diabetes more than 10 years. So these are the three important factors that they've identified that amongst diabetics, if they have a family history of thyroid disease, if they are females and they have been having diabetes for more than 10 years, you should screen them for thyroid dysfunction, because this could be having a high prevalence in such groups, and you could pick them up early and treat them. Now let us look at the influence of having looked at the prevalence and the coexistence of these conditions. Let us look at the effect of hypo or hyperthyroidism on glucose metabolism. So what happens in thyroid disease? So if you look at, so to make it convenient, I'm putting both of them together, because again we'll be discussing about hyperthyroidism later in the course of the lecture. So if you look at hypothyroidism, what it does is that it has an effect on the liver glucose output. It reduces the liver glucose output, reduces the ratio of insulin synthesis, and decreases the glucose disposal. And because of this, there is decreased peripheral glucose utilization and insulin resistance. And there is slowed absorption of glucose from the gastrointestinal tract and retardation of glucose assimilation peripherally. So there is decreased glucose absorption, there is decreased glucose disposal also, and glucose output from the liver is also decreased. So there could be, because what we are seeing is that although we are putting all these together here, there could be one of these components may be prominent in one particular individual. It's not necessary that all of them will be affected to the same extent. They could be effect on the liver glucose output may be significantly affected in one individual, whereas some other individual would have more of effect of glucose disposal. So this individual is more likely to be prone to develop hypoglycemias, and this individual will probably not have that sort of presentation. So there is a significant effect on all these parameters, and there could be differential effects in different individuals. Now let us look at what hyperthyroidism does. So it again increases the glucose turnover and glucose gastrointestinal absorption of glucose, increases the hepatic glucose output, increases the post-absorptive plasma glucose and insulin and proinsulin levels, and increases the peripheral glucose uptake and utilization. So what we're seeing is that and the increases the free fatty acid levels also. Breakdown of free fatty acids increase. So because of various components here, what we are saying is that in people with hyperthyroidism, they are more prone to develop hyperglycemia. These individuals, again, because of various mechanisms playing here, they are more prone to developing hypoglycemias. So hypothyroid individuals generally are more prone to develop hypoglycemias, and hyperthyroid individuals tend to have generally a little higher glucose levels and difficult to manage diabetes. So if you look at what happens in hypothyroidism, there is increase in TNF alpha, IL-6, and these are some of the major adipokines which contribute to insulin resistance, and they reduce the glucose disposal, and they cause marked increase in free fatty acids. Circulating ghrelin levels are inversely related to T3, independent of fasting and other forms of stimulation. Ghrelin modulates the insulin sensitivity and has a profound effect on the islet cell proliferation and survival. Thyroid hormones are positively associated with insulin resistance, and not only in clinically diagnosed DM, but also in subjects with normal glucose tolerance also. So we are clearly seeing that there is influence on the insulin resistance, insulin sensitivity, the way different mechanisms are coming into play will alter the glucose levels. So thyroid hormones have a significant impact on the insulin secretion. In hypothyroid individuals, glucose-induced insulin secretion by the beta cells is reduced. So as I mentioned, that there are effects on different components. So somebody who has got a significant effect on insulin resistance, significant effect on the glucose output from the liver being affected, they may present with episodes of hypoglycemia. There could be others who have a significant effect on the beta cell insulin secretion, and there they may present with hyperglycemia. In the same, in the same spectrum, we find that different individuals with hypothyroidism can have different manifestations. Another interesting study has looked at the plasma nesfatin levels, and they found that decreased levels of this nesfatin are related to thyroid dysfunction in patients with type 2 diabetes. So those who have got lower nesfatin levels, they probably have a higher risk of having thyroid dysfunction and amongst the diabetes. So this is something which has been identified. How it has clinical significance, something which is not clearly understood as of now, but we may have better understanding over a period of time, and we may understand more and more about these problems. Now, if you look at the impact of hypothyroidism on the various complications of diabetes, you can see that there is an increased risk of nephropathy was shown in patients with type 2 diabetes with subclinical hypothyroidism, which could be explained by a decrease in the cardiac output and increase in the peripheral vascular resistance in patients with hypothyroidism, and this results in decrease in renal blood flow and decrease in GFR. So as we know that these things can lead to progression of nephropathy. Treating hypothyroidism in that study improved the renal function in patients with diabetes. And diabetic patients with subclinical hypothyroidism also have been shown to have more severe retinopathy than euthyroid patients with diabetes. And frequent hypoglycemic episodes have also been noted in patients who have got either subclinical hypothyroidism or overt hypothyroidism. So effect on various complications like the nephropathy and retinopathy. So this is a systematic review and meta-analysis of subclinical thyroid disease or subclinical hypothyroidism present in patients with diabetes. So when they looked at different studies, meta-analysis of several different studies which have looked at the impact of hypothyroidism on diabetic nephropathy, what they found was that there was an increase in the risk for nephropathy, as we have seen, and a meta-analysis of all that says that there is a 74% increase in the risk for development of nephropathy amongst patients who are hypothyroid, and treatment of that also has been shown to improve the outcomes. Now, study by Professor Sarita Bajaj from Allahabad has shown that the prevalence of hypothyroidism she has looked at the prevalence of hypothyroidism in patients with diabetic kidney disease and what is the effect of thyroid hormone replacement on the eGFR. So what they found was that they looked at 41 adult diabetic kidney disease patients and they screened them for hypothyroidism. They found that hypothyroidism was found in 34% of these, and subclinical hypothyroidism in another 29%. And what they found was that the total is 34%. out of which 29% is subclinical and 4% is overt hypothyroidism. And what they found was that the prevalence of hypothyroidism increased with increasing severity of DKD. And thyroid hormone replacement significantly improved the renal functions in patients with DKD. After 3 to 6 months of therapy, you could see some improvements in the EGFR, and the EGFR was noted. So clearly, you're seeing that there is effect. And if you look at the CVD risk amongst patients with hypothyroidism, what we see is that hypothyroidism can magnify the risk of the CVD risk through effects on dyslipidemia and also on the effect on hypertension. Dyslipidemia, which is caused by hypothyroidism, is partly reversible with thyroxine treatment in patients with coexisting diabetes. Several studies have reported interdependent associations between thyroid status, dyslipidemia, and insulin resistance. In euthyroid persons, low normal thyroid hormone levels were associated with hyperlipidemia and insulin resistance. So what we have seen is that clearly that there is a effect on the macrovascular disease also. And TSH levels within the reference range have a linear and positive association with cardiovascular disease, but not with AF and all-cause mortality. So they have an effect on the cardiovascular events. Now let us look at subclinical hypothyroidism and diabetes. Subclinical hypothyroidism was associated with the greater prevalence of diabetic nephropathy, odds ratio being 3.15. Risk of cardiovascular events also is increased in patients who have got subclinical hypothyroidism. Again, the hazards ratio is 2.93%, indicating that there's a significant impact on cardiovascular disease and nephropathy. And low normal T4 levels were associated with increased insulin resistance. And the progression rate to overt hyperthyroidism in these patients with subclinical was found to be 5% per annum in diabetic patients with positive thyroid microsomal antibodies. So this is pretty much as we see in non-diabetic patients also. Do therapies complement each other? Treatment with thyroxine reduces HbA1c levels in patients with type 2 diabetes with coexisting subclinical hypothyroidism. And treatment with metformin plus thyroxine reduces the TSH levels more significantly more than metformin alone in patients with type 2 diabetes. So addition of thyroxine does have an effect on reducing the TSH levels, and metformin also has some influence on the TSH levels, as we've seen. And if you look at the effect of thyroid status on glycated hemoglobin in non-diabetic individuals and its effect on the effects on treatment effects of treatment of with thyroxine on the HbA1c level, if you see in non-diabetic patients, you can see that there is a decrease in HbA1c levels within the normal range. This is within the normal range. Within the non-diabetic range also, you find that there is some improvement or reduction in HbA1c levels with therapy with thyroxine. So significant reductions in patients of hypothyroidism post-treatment have been noted, even in non-diabetic individuals. And if you look at diabetic individuals also, you find that there is an effect of TSH on lowering the metformin, and treatment with thyroxine has an effect on the HbA1c also. So as we said, there's a bidirectional association, and there is a clear association seen between these two agents. And now, having looked at all that, let us now move on to quickly I spent a few minutes on hyperthyroidism and diabetes. If you look at this, what we see is that hyperthyroidism has been associated with insulin resistance, and this leads to increased glucose turnover, increased intestinal glucose absorption, increased hepatic glucose output, increased free fatty acid concentrations, and the fasting and postprandial insulin and proinsulin levels are also increased. So there is so basically this leads to a worsening of diabetes, as you can say, and hyperthyroidism and type 2 diabetes are manifesting with severe hyperglycemia, and they may mask life-threatening thyroid storm also can be masked in the presence of diabetes in patients who have got hyperthyroidism. Uncontrolled hyperthyroidism may be a cause of poor glycemic control on the other hand, and it can be a cause of recurrent decay also. So both hyperthyroidism and diabetes exhibit similar features related to cardiovascular risk and may increase the cardiovascular morbidity and mortality. So what we see is that if you look at the effect of excess thyroid hormone on various organ systems, it affects the liver, increasing the hepatic glucose output, increases the peripheral glucose used in the muscle, and this can all decrease the peripheral glucose utilization in the muscle, and this can lead to hyperglycemia, and the hyperglycemia can precipitate diabetic ketoacidosis. Thyroid storm can be sort of missed out in patients who have got this sort of a significant hyperglycemia, and increase in proinsulin, increase insulin clearance leads to insulinopenia. So all these are mechanisms by which hyperthyroidism affects the glucose metabolism, leads to hyperglycemia, and can also precipitate decay. Circulating ghrelin levels are related to insulin resistance, and hyperthyroidism is associated with insulin resistance, and hyperinsulinemia suppresses the ghrelin levels in patients with hyperthyroidism. And the treatment of hyperthyroidism with anti-thyroid drugs does not affect the glycemic control apart from possible iatrogenic hypothyroidism. Corticosteroids used for treatment of Graves' ophthalmopathy in those who have got significant ophthalmopathy that can lead to worsening of glycemic control and induce diabetes. Adjustment of insulin treatment should be considered in patients with diabetes after the occurrence of hyperthyroidism. And similarly, hyperglycemia should be re-evaluated in hyperthyroid subjects after the control of thyroid dysfunction. So clearly, thyroid function hyperthyroidism has impact on the glucose levels, and it can precipitate various problems. Now, let us look at what the guidelines have been recommending about screening for thyroid dysfunction amongst patients with diabetes. So, if you look at our own Indian consensus statement, which came out in 2016, Dr. Vijay Kumar was the lead author of that. Patients with diabetes require more frequent screening for thyroid disorders as compared to general population. Patients with type 1 diabetes should have a check every year, and patients with type 2 diabetes should have the thyroid function checked at diagnosis, but routine annual checking is not recommended. So this is what even many other guidelines are suggesting, that they are looking at type 1 diabetes having a check every year, type 2 diabetes at onset of diabetes, and specifically when they have problems at onset of diabetes, you should check for thyroid dysfunction. Always clinically look for thyroid palpability, and that is what all of the guidelines are clearly saying. So the take-home messages are that thyroid dysfunction is more common in patients with type 2 diabetes than in the general population. It can frequently be asymptomatic. It can have an influence. Screening for thyroid dysfunction and then undetected thyroid disorders can compromise the metabolic control and amplify the risk of cardiovascular events and also renal events in patients with diabetes. Screening of thyroid dysfunction could prevent the high cardiovascular complications of type 2 diabetes. And subclinical hypothyroidism is associated with increased risk of microvascular complications. And treatment with thyroxine may normalize fasting hyperinsulinemia and significantly improve the insulin sensitivity in patients with overt and subclinical hypothyroidism and have a favorable effect on the insulin resistance. So thank you all for the patient hearing. I would be happy to answer any questions. Thank you. Over to the chairpersons.
Hello, sir. Suppose if the patient has diabetes with having T3, T4, TSH normal, but anti-TPO antibodies is more than 1,000, should we start thyroxine tablet or?
No, certainly not. Certainly not. We should not. These patients may be at a higher risk of developing subclinical thyroid disease or clinical thyroid hypothyroidism. But at this point of time, there is no clear evidence to say that treating them is going to be of any benefit.
Should we investigate every yearly TSH or every 6 monthly in such a high level of?
Yeah, such patients we should have a high index of suspicion and screen them for thyroid disease. Maybe every 6 months we can screen them for a TSH. Just a screening test with TSH can be helpful at least annually, or even 6 months may be good enough when they have very high TSH anti-TPO antibodies.
Okay. Is there any question?
Dr. Ramakesh is saying something, but we are not able to hear you. You're muted. You're still muted.
Dr. Ramkesh, please unmute yourself.
Hello. Good afternoon, sir.
Yeah. Yes.
Hello.
Yes, we can hear you now.
Is I audible, sir?
Yeah, we can hear you.
Okay, sir. One question regarding diabetes and hyperthyroidism, sir. Diabetes and hyperthyroidism, what is the incidence in this type of patients, and is the role of anti-TPO antibody for type 1 diabetic patients. Patient is a type 1 diabetic and hyperthyroidism, and what role of anti-TPO antibody, and what is the duration for the repeating the TSH test in these type of patients?
Yeah, as I was mentioning that patients with type 1 diabetes, because they have a higher prevalence of autoimmune diseases, other autoimmune diseases also are higher, and autoimmune thyroid diseases are particularly very common. Amongst them, hypothyroidism is the most commonest presentation, but they can be at high risk of having hyperthyroidism also. And you said what is the significance of measuring the anti-TPO antibodies? I think measuring anti-TPO antibodies maybe for a specific purpose if you're doing it, but otherwise for clinically managing them, I think looking at the thyroid hormone levels, the TSH and the TSH particularly and T4 is going to be more helpful in monitoring their situation and monitoring the treatment that they may require.
Okay. Thank you, sir. Thank you.
Should we conclude?
Yeah, I don't see any questions on the chat box.
Dr. Parmar, can we conclude now? Hello. As there is no question, we can conclude and we can have a next lecture.
Yeah, Dr. Sambit is also here. Thank you to all the organizers for the wonderful conference going on, and thanks for inviting me.
Now, next lecture is of secondary diabetes. I would like to introduce Dr. Sambit Das. He is a endocrinologist, Endeavor Clinics and Apollo Sugar Clinics, Bhubaneswar. Publication in International National Journals 34, Abstract 18, book chapters 14.
आपके डायबिटीज खत्म कर दोगे? एक पेशेंट कम कराओगे मेरा? डायबिटीज फ्री हो रहे हो आप? बिल्कुल एक इंटरव्यू करना पड़ेगा, वो डायबिटीज फ्री किया है इनको.
I think Dr. Ram needs.
Hello. Hello.
Yes, sir, you are audible.
Yes. I would like to introduce Dr. Sambit Das. He is Senior Consultant Endocrinologist, Endeavor Clinic and Apollo Sugar Clinics. Publication in International National Journals 34, Abstract 18, Book Chapter 14. Phase 3 Clinical Trial 7. He is the Secretary Endocrine Society of Odisha. He is having Secretary, Scientific Secretary ASICON 2018. Secretary AARO Odisha chapter. He is a member of Endocrine Society of India, AEC, ESO, ITS. I would request Dr. Sambit Das to start his lecture in secondary diabetes.
आप उसमें तारीख लिखिए ना, पहली वाली देखो.
Thank you, sir. Kind introduction. I'll request Dr. Ram to kindly mute because. Hello. Yes.
Lecture match accept karu tamne.
Sir, so hope I am visible and audible.
Yes, sir, you are audible.
Yeah. So the topic which has been assigned to me is secondary diabetes, and it's actually, we should not forget about the ADA 2021 classification, where it has been shown that there are 4 types of diabetes grossly, and that has endorsed that thing also. It is type 1 diabetes, type 2 diabetes, gestational diabetes, and the third point is specific types of diabetes due to other causes. And in the next 15 to 20 minutes, I'll be discussing only those things, that is the number 3, specific types of diabetes due to other causes. So if we see that, if we elaborate that specific types of disease due to other causes, we have 6 or 7 types of diabetes. One is genetic defects in beta cell function. Second is genetic defects of insulin action. Third is secondary diabetes due to exocrine pancreatic insufficiency. Fourth is secondary diabetes due to endocrinopathies. Fifth is drug and chemical induced diabetes that lead to secondary diabetes, various infections that can lead to diabetes, uncommon forms of immunomediated diabetes, and other genetic syndromes sometimes associated with diabetes. So let us go one by one regarding this secondary diabetes. So coming to the first one, that is genetic defects in beta cell function, and grossly we can clump them as monogenic diabetes, and they can occur at very young age, which is known as the neonatal diabetes, or they may occur at younger age, less than 25 years of age group, that is known as the maturity onset diabetes in young. And both of these things, or the monogenic diabetes, represent only a small fraction of diabetes, that is less than 5%. Coming to neonatal diabetes, diabetes occurring under 6 months of age is termed as neonatal or congenital diabetes. 80 to 85% of the cases can be found to have an underlying monogenic cause, that is a single gene defect. Neonatal diabetes occur much less often after 6 months of age. So whenever a diabetes occurs less than 6 months of age, we can term it as neonatal diabetes, and after 6 months usually it doesn't occur. Similarly, type 1 diabetes never occur in children who are less than 6 months of age. It's mostly neonatal diabetes. This neonatal diabetes can be either permanent or transient. Transient neonatal diabetes is most often due to overexpression of genes on chromosome 6q24, is recurrent in about half of the cases and may be treatable with medication other than insulin. Permanent neonatal diabetes is most commonly due to autosomal dominant mutation of the genes encoding KIR6.2 or KCNJ11 and SUR subunit of the beta cell potassium ATP channel. So whenever these genetic defects of the potassium ATP channel is the culprit for neonatal diabetes, these are the children, even if they are less than 6 months of age, they can respond better to sulfonylurea rather than insulin. And the other type of genetic defect that can occur as a permanent neonatal diabetes is insulin gene mutation that requires insulin therapy even less than 6 months of age. So these are the number of genes that can lead to neonatal diabetes. We have discussed about KCNJ11, which is an autosomal dominant, usually permanent diabetes, but it may present with delay in development or seizures and usually responsive to sulfonylurea. Insulin receptor gene, permanent, it's IGR and insulin requiring. The other treatable or transient neonatal diabetes is GQ24 overexpression, and it is usually transient. The patient may present with macroglossia umbilical hernia, and paternal duplication of maternal methylation defect can be the cause, and that is usually transient. After some time it usually recovers. The other genetic defects are GATA6 or FOXP3 or EIF2A-K3 mutations. Now, if the monogenic diabetes occur at a little later age and less than 25 years of age, we call it as maturity onset diabetes of the young, or MODY. Monogenic forms of diabetes associated mutation of the single gene, and the diagnostic criteria of MODY has been many, but I'll just highlight the simpler diagnostic criteria, that is by Tattersall and Fajans. The Tattersall-Fajans diagnostic criteria for MODY is that the patient should be diabetic and is less than 25 years of age. Autosomal dominant mode of transmission, that means we can see 3 generations having autosomal dominant mode of inheritance. Absence of ketosis at any time, and controlled with insulin in at least an early stages of disease. It can be controlled without insulin. Clinical criteria are no longer valid, and genetic analysis is needed to confirm the diagnosis. So whenever we suspect a MODY, we must do a genetic analysis for that patient, because it has got many implications later on. Some of the MODY which I have shown it here is the glucokinase deficiency, or the GCK MODY. It's stable, non-progressive, elevated fasting plasma glucose only, and they do not require any therapy throughout their life course. HNF1 alpha, 4 alpha, and 1 beta are important because they are very common MODY category. HNF1 MODY is progressive insulin secretory defect with presentation in adolescence or early adulthood, lower renal threshold for glycosuria, and sensitive to sulfonylurea. HNF4 alpha is progressive insulin secretory defect with presentation in adolescence and have large birth weight and transient neonatal hypoglycemia. They are also sensitive to sulfonylurea. So HNF1 alpha, 4 alpha are sensitive to sulfonylurea, whereas glucokinase deficiency doesn't require any therapy. So diagnosis of monogenic diabetes, why it is important? Because the HNF1 alpha, 4 alpha can be treated with sulfonylurea. GCK MODI doesn't require any therapy. Additionally, diagnosis can lead to identification of other affected family members, and we can do a thorough genetic counseling for that family too. The clinical features of MODI are patients usually are non-obese, do not need insulin initially, later may become insulin requiring, and diabetes due to HNF1 alpha, 4 alpha defects and MODI 1 and MODI 3. Isolated mild fasting hyperglycemia we can find in MODI 2, which is glucokinase deficiency. MODI 5 is actually a diabetes with renal cyst and renal agenesis, which is not a very good MODI. And renal cyst and diabetes syndrome defects in HNF1 beta, which is known as the MODI 5. They usually resemble type 2 diabetes, but it is very important to differentiate type 2 diabetes versus monogenic diabetes, because monogenic diabetes are usually non-obese, type 2 diabetes are obese or overweight. Acanthosis nigricans, which are signs of insulin resistance, are absent in monogenic diabetes or MODI, but they are quite common in type 2 diabetes. 3 generations of transmissions are there with monogenic diabetes, but in type 2 diabetes, there is no autosomal dominant like transmission. And monogenic diabetes only insulin secretory defect, but type 2 diabetes it's mostly insulin resistance and insulin deficiency. Monogenic diabetes can be seen in all population, but type 2 diabetes usually population with high prevalence of type 2 diabetes. Monogenic diabetes responds better to sulfonylurea. Type 2 diabetes, the first choice of therapy is usually metformin. So we must know the difference. Apart from the genetic defects in insulin secretion, we have genetic defects in insulin action. And there are various types of insulin resistance that are genetically and monogenic also. The metabolic abnormality is associated with mutation of the insulin receptor, or the post-insulin receptor pathway can lead to severe insulin resistance and a different genetic kind of insulin resistance. We have type 1 type A insulin resistance. Individual with this mutation may have severe acanthosis nigricans. Women may be virilized and have enlarged cystic ovaries. Leprosonism and Rapson-Mendelian syndrome are some of the examples of very severe insulin resistance due to mutation and subsequent alteration in insulin receptor function and extreme insulin resistance. Lipoatrophic diabetes lesions reside in the post-receptor signal transduction pathway. So these are some of the causes of genetic defects in insulin resistance. Now, another chunk of the secondary diabetes comes from defect in the exocrine pancreas. Exocrine pancreas deficiency may occur because of pancreatitis, because of trauma, because of neoplasia, because of cystic fibrosis, hemochromatosis, and FCPD. So this is a very common type of diabetes, and pancreatic diabetes include both structural and functional defect in the beta cell associated with exocrine deficiency of the pancreas. Other names of this pancreatic diabetes are type 3C diabetes and also pancreoprevic diabetes. So they are otherwise known as this. The distinguishing features from other types of type 1 or type 2 diabetes is that concurrent pancreatic exocrine insufficiency would be there. So clinically the patient will have fatty stools, and if we do the test, we can find fecal esterase 1 test and direct function test of pancreatic exocrine insufficiency will be positive. Pathological pancreatic imaging can be there. You can get abnormal finding on the CT, MRI, ultrasound or endoscopic ultrasound. Absence of type A diabetes related immunity. So if you're not finding GAD65 and other islet antibodies, then probably we can suspect a pancreatic diabetes. There is loss of both insulin and glucagon secretion and of higher than expected insulin requirement in this group of population. Fibrocalculous pancreatic disease is one of the pancreatogenic diabetes, and this has been also included in the secondary diabetes. Uncommon form of pancreatic diabetes found in certain parts of the world. Mostly it has been found from India and southern India and also in the eastern part of the India. Patients should be from a tropical country. Diabetes should be present. Evidence of chronic pancreatitis is there, like abnormal pancreatic morphology on ultrasound and CT scan. Recurrent abdominal pain since childhood would be there. Steatorrhea, abnormal pancreatic function would be there. Absence of other causes of chronic pancreatitis like alcoholism or hepatobiliary syndrome should be there. And if we see the clinical features, they are usually lean and thin people, history of oily motion and recurrent pain abdomen, absence of ketosis even if the sugars are high, severe diabetes, and they have very brittle diabetes. It fluctuates a lot. And if you do a simple plain X-ray, you can find the small stippled calcification in the pancreatic parenchyma. USG shows duct dilatation, most commonly found in Kerala and Tamil Nadu, and etiology is not known. Maybe the cassava intake has been implicated, and it increases significantly the pancreatic carcinoma incidences. Other causes of pancreatogenic diabetes is cystic fibrosis related diabetes, though in India it is less common, but in comparison to the Western population, but still cystic fibrosis is an important disorder. And the comorbidities in people with CFT are occurring in about 20% of adolescents diabetes and 40 to 50% of adults with diabetes. It is associated with worse nutritional status, more severe inflammatory lung disease, and greater mortality. Insulin insufficiency is the primary defect of CFRD. OGTT is the recommended screening test. Annual screening for cystic fibrosis related disease with an oral glucose tolerance test should be done after 10 years of age in all patients with cystic fibrosis. And A1C is not recommended, and glucose tolerance test is the primary modality of diagnosis. Patient with cystic fibrosis related diabetes should be treated with insulin to attain individualized glycemic goals. Endocrinopathies and other syndrome can also present with secondary diabetes. The most common endocrinopathies are acromegaly, Cushing syndrome, glucagonoma, pheochromocytoma, hyperthyroidism, somatostatinoma, aldosteronoma, and others. And remember that many times we miss them unless we specifically see this category of diabetes. Other genetic syndromes are also associated with diabetes, like Down's, KFS, Turner syndrome, Wolfram syndrome, Fredrickson ataxia, Huntington's chorea, Lawrence Boone Bardet Biddle syndrome. And unless we are very keen on finding these secondary causes, we may miss them. And I'll just show a few of the examples how we have diagnosed secondary diabetes. Now, this lady has actually come to our OPD with uncontrolled blood glucose. For the last 2 years, she is requiring very high doses of insulin, not controlled on OID, even if the diabetes is of 2 to 3 years duration. But when we closely observed her, we could see the prognathism of this lady, the widening of the incisors teeth. And if we see the hands and the feet, they are quite stubby, and acral enlargements were there. So this is a case of acromegaly, and when we did the growth hormone assay, it was quite high. And when we did then MRI imaging, you can see the large pituitary macroadenoma in this patient. So anyone could have missed this patient as only a type 2 diabetes and would have continued treatment, but it's in fact a secondary diabetes because of acromegaly. Now, this patient is another lady of 40 years age who is presented with recent history of diabetes, with very uncontrolled diabetes requiring almost 95 units of insulin. Still, the sugars were running 200, 300. But when we closely observed, there was mooning of the face, and when we asked the previous photograph, she has changed in the recent time with more weight gain and mooning of the face, and there was pigmentation. And when we did the cortisol assay, the cortisol was high. The overnight dexamethasone, the low dose dexamethasone were non-suppressible, ACTH was higher. And when we did an MRI, we could find a pituitary microadenoma. So these are real cases where a Cushing syndrome has been missed as type 2 diabetes. So one has to be very, very keen. And this patient has just come 1 month back wearing a face mask because of the COVID, and he entered into the room, and he presented again with high blood glucose only. Previously, he has been diagnosed with type 2 diabetes only on OID. Sugar is not under control. Just on removal of the mask, you can see the mooning of the face. And when we ask the patient to just show his belly, you can see the white purple stripe typical of Cushing. So this is also a Cushing syndrome, which was diagnosed as type 2 diabetes. Now, these were few examples where we should suspect type 2 diabetes and we should diagnose it. Now, there are various drugs that can also lead to secondary diabetes. Few of the name are mostly glucocorticoids, nicotinic acid, factor, pentamidine. Thyroid hormone can also lead to it. Digoxide, beta agonist, thiazides, dilantin, alpha, gamma interferon, and others. Certain toxins such as Backer and intravenous pentamidine can actually permanently damage the beta cell and can lead to diabetes. Nicotinic acid and glucocorticoids mostly produce insulin resistance and severe diabetes. Interferon associated with islet cell antibodies and in certain instances severe insulin deficiency. There are infections that can cause diabetes, and we know the previous infections like congenital rubella, cytomegalovirus, and others can actually produce type 1 diabetes like features. And now COVID-19 infection has actually opened another Pandora's box, where we find many new onset diabetes are coming after COVID-19. And one of the reason is that COVID-19 also affects the pancreatic beta cell because, through the receptor, ACE receptor. Post-transplant diabetes mellitus, it's also a type of secondary diabetes. Immediate post-transplant hyperglycemia can happen 0 to 1 week. Early post-transplant hyperglycemia can occur between 1 to 6 weeks, but 90% of the kidney allografts who have hyperglycemia in the immediate or early post-transplant hyperglycemia usually resolves in due course of time, and they don't require any insulin at the time of discharge. PTDM is post-transplant diabetes. It's a different entity altogether. When the diabetes occurs after 6 weeks of post-transplantation, and the patient should be screened after any organ transplantation for diabetes with a formal diagnosis of post-transplantation diabetes being best made once the patient is on stable immunosuppressive therapy and in the absence of acute infection, preferably after 6 weeks of transplantation. The OGTT is the preferred test to make the diagnosis of PTDM. So I think I have covered most of the secondary causes of diabetes, and I have gone through in detail. So summarizing, secondary diabetes is an important part of the formal classification of diabetes. We should not only tell that there are type 1 diabetes, type 2 diabetes, and gestational diabetes. We have another important component which is known as secondary diabetes. A high index and suspicion is necessary for diagnosing and classifying secondary diabetes. It has got significant therapeutic implication, as we have shown in MODI and also in various drug-induced or various secondary diabetes. So with that, I'll end. Thank you for the patient hearing. I think there is no question.
Is there any question? I think there is no question.
I think the chat box is also empty.
Doctor, I just have a question in terms of these monogenic diabetes. So in a routine practice, when we see patients where with some of those cases, which is not very typical type 2, the age group is around 30, 34. So in those instances where you suspect a MODI, is there a particular protocol that you follow to? I mean, we don't routinely do all those. We don't look for those monogenic mutations on a routine clinical practice, right? So in those scenarios, would you, thinking that this patient might be a MODI based on the history, the family history, and the presentation, would you just directly start the patient on sulfonylureas, or would you actually want to work up the patient further to confirm what is the actual thing and then proceed? What is the clinical course that you tend to usually take in your practice, daily
I think
practice?
that's a very, very important practical question. And patient who are less than 25 years of age and who present with diabetes, our first aim is to control the blood glucose definitely, because during the workup, we should not be pushing the patient for hyperglycemia and other complications. So whatever happens, we need to treat the patient first. And in the same time, we need to find out the family tree and how the transmission of a particular disease is. And MODI workup, definitely, as you have told, genetic workup is important and that is recommended. But unfortunately, it's not available very commonly. I think it's only in CMC Vellore, Dr. Mohan's, or in some very specific labs, the MODI evaluation is available. But in the meantime, we can actually start therapy, see the response. If the sugar is very high, we must proceed as in other diabetic status. We can start with insulin. If the sugars are less, we can start with metformin or sulfonylurea. Like that, we can keep the patient with a good glycemic control. And in the meantime, we can start evaluating the patient. And if possible, we can do a genetic analysis also.
Okay. I mean, just to get a figure, how commonly do you do a genetic analysis in your such a patient who comes up which is little not very clear in the clinical presentation? So how often do you actually send the patients for a genetic
Practice
workup?
less. We mostly ask the clinical profile and we diagnose it as MODI, and we treat accordingly. Like for MODI 1, there are only MODI 2, there is only mild hyperglycemia which doesn't require any treatment. For MODI 1 and 3, they respond very well to sulfonylurea. So accordingly, we can go, and we need to find out that this patient is exactly not type 1 diabetes. I think excluding type 1 diabetes is the most important part in this group of patients. And once we have excluded that with GAD65 and with C-peptide and other things, then we are in the safe hand. We can treat it as type 2 diabetes also, and we can go ahead. And if the patient insists, we send for genetic analysis. So excluding type 1 diabetes is the most important step actually.
Sir, you're on mute, sir. So you'll have to unmute. Yeah. You're on mute again.
Yes, sir, you are audible now.
FCPD cases we see less in our region. So what is the management of FCPD? Does it same with the type 2 diabetes or is there any change?
No, FCPD actually, the management, FCPD is relatively common in my place. We live in Odisha, and in fact, Professor B.B. Tripathi is the first person to diagnose FCPD, and he has written a book on FCPD. So FCPD is relatively common in Odisha also, and also in South Tamil Nadu and Kerala. So basically, once we diagnose with FCPD, the treatment is more of like type 1 diabetes, because we need to start on insulin, preferably on basal bolus therapy, and they have a very high fluctuating blood glucose. But the best part is that they usually don't land up in diabetic ketoacidosis like type 1 diabetes.
Okay. Thank you, sir.
Thank you.
Should we conclude now if there is no question? Because all the lectures has finished.
Yes, sir.
At the last, I am thankful to the Dr. Bansi Sabu that he has given me the opportunity for the chairperson, and I congratulate Dr. Bansi Sabu and his team for having a wonderful scientific list and lectures with good speakers and good topics, which is related to the especially physician as a general practitioner. Thank you so much.
Thank you. Thank you all. Thank you all for the opportunity. Thank you so much.
Thank you, Chairperson, and thank you, speakers. Now we conclude our session over here, and now we move on in Dr. Suman Shah Hall for a Diacare Gold Medal oration. So I request to switch over in the Dr. Suman Shah Hall.
in 24 hours, but there's money. See.
Dr. Raghu Satyanarayana, I think we can start this session. Dr. Rajesh is also there. Dr. Rajesh Damare. So you please invite. Maybe Dr. Sudhir Bhandari may join little later.
Okay,
If we
sir.
have Dr. Parag Shah, he can start with the talk. Hello,
Okay, sir.
Gliptin. He is already joined. So
Okay,
you
sir.
can invite because Dr. Sudhir Bhandari is stuck up with some emergency.
Okay, sir.
And Mithun is there. So
Yes.
Mithun, please take over. And Dr. Mithun Bhartiya is there. Dr. Rajesh is there. And Dr. Raghu Satyanarayana join. I don't know. Myra is not joined. So you please start the session because otherwise
I'm
we'll be
there.
late. Okay, Myra. So please start the session.
Yes, sir.
Sure.
Yes.
Thank you.
Uh, Good
So,
afternoon,
Sudhir.
everyone. Good afternoon, everyone, and I invite you to this session of Pills That Thrills. And I take this opportunity to invite our chairpersons for this session, that is Dr. Raghu Satyanarayan from Ahmedabad and Dr. Rajesh Deshmane from Kolhapur. Sir, over to you.
Yeah, good afternoon, everyone. After on a Sunday afternoon, after a heavy lunch, we are here to again learn from our esteemed speakers. It's a real privilege and a pride to join this conference as a chairperson. I would first of all sincerely thank Dr. Bansi Sabu for giving me this opportunity today in the afternoon. Going on to our first talk, actually one of my dear friend and IPS officer friend had asked me once, what keeps you going in practice? I said it is thrills in diagnosis, thrills in diagnosis. So here we are today to learn what these pills can cause these thrills in patients. So the first speaker for this session is Dr. Parag Shah, and he's a dear friend of mine. He's a director at the Gujarat Endocrine Center, Ahmedabad, for the past 23 years. He's been awarded one of the most inspiring endocrinologists of India by Economic Times in 2020. He was the organizing secretary at the ESICON 2015, where I was also one of the faculties. He has been a very close and a dear friend of mine, and we were together at the IDF conference in Paris. We have very good and close associations and memories. Over to Parag Shah, please, for your talk on allogliptin.
Can I share my screen, please? Good afternoon, everyone. Thank you, Dr. Raghu, for nice words. Thank you, Dr. Bansi, for this excellent scientific extravaganza. What I will be discussing is, again, one more gliptin, but I feel that this is the least discussed gliptin among all the gliptins, which is available in India, which is CVOT safe. It is the only CVOT trial proven gliptin available at a generic rate in India, that is allogliptin. We all know that the number of diabetic patients globally and specifically in the Asian subcontinent is significantly increasing. Unfortunately, we are going to have more than 134 million patients within next 1.5 decades or so. And we all know DPP-4 inhibitors very well. We can use this as a monotherapy, as a add-on therapy. And most of the DPP-4 inhibitors which are studied for CVOT has been found to be cardiac neutral, except SEXA had a doubt about the worsening of the heart failure. And Indian patients, there is enough data in our own experience also showing that probably we are responding better to gliptins compared to Caucasian populations, probably because of the high carbohydrate ingestion, which is stimulating the GLP-1 better in us. So we got a 4 patented gliptin with a cardiovascular outcome data available with us, like sitagliptin, sexa, lina, and alogliptin. Alogliptin was the last one to get approved in 2013, and India it got approved in August 2014. Alogliptin is patented by Takeda Japan, which was approved in USA 2013. It is a very selective inhibitor of DPP4 enzymes, and there is a single dose administration can lead to peak within 2 to 3 hours post dose, and it exhibited more than 14,000 fold DPP4 selectivity over DPP8 or DPP9. So it is one of the most selective DPP4 inhibitor available with us. US FDA is approved as a single drug, as a standalone, in a combination with metformin, and interestingly in a combination with pioglitazone also, because pioglitazone also was patented by Takeda globally. This is the pharmacokinetics. It's orally available 100%, and half-life is quite long, so it's ideal drug to be given once a day. And if you see the selectivity of Vilda, Sita, Sexa, and Alo is more than 14,000 more selective for DPP4 compared to DPP8 or DPP9 enzyme. So it is more selective. And if you see the side effect profile, we all know that all gliptins are usually very well tolerated. We hardly have to discontinue the gliptin because of intolerability or significant adverse effects. The most common is the nasopharyngitis, URTA, and the headache, which is almost comparable, slightly less, though this is not a head-to-head comparison comparative study, but probably it is one of the safe gliptins available with us. What about the inhibition after 24 hours? You need at least 70% inhibitions to have the proper 24 hours inhibitory actions of the gliptins to be effective. Allogliptin maximum inhibition is 90%, and after the first dose and after 24 hours, there is more than 75% inhibition of the DPP4 activity. So it's truly once a day gliptin available with us. And if you see the A1C drop is almost comparable, almost 0.6 to 0.8% reduction in the HbA1c is seen with almost all the gliptins. Higher the A1C, more drop would be there of A1C up to 1 to 1.2%. And Indian patients or Asian patients probably has a 0.2 to 0.3% more A1C drop compared to the Caucasian counterparts. What I would be focusing more is the landmark CVOT trial of the allogliptin on a very high risk patients pool. We have to understand this is the first CVOT trial, that is an examine trial. And why it was done? We all know that diabetic patients has 2 to 4 times more chance to getting the cardiovascular events compared to non-diabetic populations. And we all know that US FDA had mandated 2008 to have the cardiovascular safety trials, and that is how all these CVOT trials were designed. So objective of examine trial is to determine whether allogliptin is non-inferior to placebo with respect to major cardiovascular event in patient with type 2 diabetes at very high cardiovascular risk. And this is the only cardiovascular long-term outcome trial where the patients enrolled were very high-risk patients with a recent acute coronary syndrome patients were excluded. We will see how actually the trial was designed. And if you see the representation of Indian patient, 20% of this global trial data are from the India. So we got a more than 400 patients cardiovascular outcome trial data available with us in this examine trial. So here patients were given allogliptin versus placebo with standard of care, and patients were follow up. And this is again a, like all CVOT trials, this is a event driven trials. But most important thing we have to remember is that apart from type 2 diabetic patients who are not on gliptin or the GLP-1 analog therapy, patients should have acute coronary syndrome within 15 to 90 days before randomization. So these are the recent onset acute coronary syndrome patients with a glycosylated hemoglobin ranging from 6.5 to 11%, and exclusion criteria are all standard except unstable cardiac disorder patients like NYHA class 4, refractory angina, uncontrolled arrhythmias, critical valvular heart disease, severe uncontrolled hypertension. Most of the trials would exclude unstable patients in any CVOT trials and dialysis within 14 days before the screening. So out of around 5,400 patients, around 20% discontinued either because of the adverse reactions, both in the both the arms, placebo as well as the allogliptin arm. These are standard. Usually 15 to 20% patients don't complete the study because of the various reasons, including meeting the unfortunate criteria of death. So primary endpoint was death from the cardiovascular causes, non-fatal myocardial infarction, non-fatal stroke. That is the primary endpoints. The secondary safety endpoint, apart from these three, there was a data analysis planned to for the addition of urgent revascularization due to unstable angina within 24 hours after hospital admissions. Exploratory endpoints, which is a surrogate endpoints, I would say, included death from the cardiovascular cause or death from any other cause, and any other safety concerns, specifically hypoglycemia, angioedema, pancreatic cancers, and any other lab abnormality which is of clinical significance. So if you see the allogliptin versus standard care arm, the primary MACE endpoint is similar. Cardiovascular death also is similar. Non-fatal MI, non-fatal stroke, and if you include the need of urgent revascularization, then also allo versus standard care did not show any significant difference. You can see the hazard ratio is quite neutral. A1C reduction is slightly better with the allogliptin compared to standard care arm, and the fasting blood sugar reduction also was slightly better, but it was not a primary aim of the study. This is the cardiovascular outcome trial. And if you see, if you capture all the events, which is more than 3% of adverse reactions in allogliptin versus the placebo group, here again, there is no signals except cardiac failure congestive is slightly more. We'll discuss about it later on. Cardiac failure alone is not difference, and rest all the cardiac events or other safety signals did not differ much. So statistically, there was not much difference as far as the adverse reaction is concerned. So it met the endpoint of cardiovascular safety or non-inferiority to the standard care arm, composite of CV death, non-fatal MI, non-fatal stroke, unstable angina, or revascularization. You can see the hazard ratio is 0.98. If you see the cardiovascular hospitalization for any reason, again it is neutral, and need of coronary revascularization also is neutral, allogliptin versus the standard care arm. So it proved it cardiovascular safety or neutrality compared to standard of care treatment for diabetes. So in a background of the patient who had a recent acute coronary syndrome. So in a relatively high risk population also, it found to be cardiovascular safe or the neutral. And if you compare the Savertimi, Examine, TICOS, and Carmelina study, all studies are gliptin-based CVOT trials, and Examine study is the only trial where they took the patient within 15 to 19 days prior to randomizations, must be having acute coronary syndrome, and all showed a primary endpoints which is showing cardiovascular neutrality. Hospitalization for heart failure was significantly more with Savertimi, and we'll discuss about the Examine and what is the real understanding or the interpretation of the hospitalized for heart failure and the risk of allogliptin is there or not. So we reevaluate the Examine for hospitalization for heart failure. Actually, it was not a primary or secondary endpoint to see the hospitalization for heart failure. You can see the study design was not there, but because the Savertimi showed a signal for in-hospital heart failure rate is more with the SEXA compared to standard care. So this patient's data in allogliptin CVOT trial, that is Examine trial, also was extrapolatory extended MACE endpoint was seen in 433 patients assigned to allogliptin versus placebo. So 16% versus 16.5%. If you see the hospital admission for heart failure, which was the first event in 3.1% patient taking allogliptin compared to 2.9% taking the placebo with hazard ratio of 1.07. So it did not show any significant increase in hospitalization as a first event for allogliptin versus the placebo. So in a patient with type 2 diabetes and recent acute coronary syndrome, allogliptin did not increase the risk of heart failure outcomes. And if you see the further analysis of the Examine study and heart failure, In addition, alogliptin show no effect on the post-hoc composite of cardiovascular death and hospital for heart failure. This is the usual endpoint in all SGLT2 trials where they composite the CV deaths and hospital for heart failure. And if you see, there is no difference between if you combine both together and if you have the CV death alone, then it's 3.5% for the LO versus 4.5, and hospital for heart failure 3.9 versus 3.3. So slightly more in for the alogliptin compared to standard care. But if you see the sub-analysis more carefully, cardiovascular outcome inclusive of hospital for heart failure, but not increase with alogliptin compared with the placebo, including if you take the patient with a history of heart failure and or with elevated NT-proBNP. So if you take the sub-analysis of the sub-analysis of pre-existing heart failure with elevated NT-proBNP, that also it did not show any significant increase in the BNP and use of diuretics, which is again the patients were followed up subsequently, and if the heart failure is worsening because of the alogliptin, the need of diuretics would be increased in the alogliptin arm, or NT-proBNP would not be decreasing, rather it would be increasing. So reduction in NT-proBNP was similar compared to placebo, and use of diuretics also was similar. So again showing that it did not really increase even in the patients with acute coronary syndrome with a background of high NT-proBNP and history of heart failure to start with. So this is the 2021 ADA professional practice guidelines, again showing that if somebody has no ASCVD or ASCVD, you have to decide, and among the ASCVD, SGLT2 inhibitor GLP-1 is the preferred, but if the target is not achieved, then you have to take the cardiovascular safe drug. If the patient has a ASCVD on SGLT2 or GLP-1 not able to achieve the target, then the cardiovascular safe studied drugs like gliptins can be started. Or if somebody has no ASCVD or heart failure or renal insufficiency, then you have lots of options, and gliptins is one of the good options available with us. So alogliptin showed a cardiovascular safety. So alogliptin is the US FDA approved highly selective cardiosafe gliptin, now available in India at affordable price with a OD convenience. So if you compare alogliptin,
sir, request you to wrap up, sir.
Yes, it will take 2 minutes. Yes. If you compare the alogliptin with other gliptins, in the mild, moderate, and severe renal insufficiency or hepatic insufficiency, it is found to be safe, cardiovascular safe, and low cost, once a day dosage. What about the renal insufficiency and alogliptin? Up to eGFR of 60, you give the full dose of 25 mg, 30 to 60, 12.5 mg, 15 to 30, 6.25 mg, and it is approved with eGFR of less than 15, or even on the patient on a dialysis up to 6.25 mg. So even with the severe renal insufficiency, you can give with a reduced dose of alogliptin. There is no black box warning for alogliptin for heart failure. So pregnancy, geriatrics, and lactation, it is not to be used. And we got a brand name in India, which is found to be bioequivalence to the innovator brand. So summarizing my talk of alogliptin, highly specific, optimum A1C reduction, no risk of hypoglycemia, cardiovascular safe, safe in mild, moderate, and even severe renal insufficiency patient, including patients on dialysis, mild to moderate hepatic impaired patients, affordable, and FDA guidelines, ADA guidelines also 2020 mentioned, except saxagliptin, it can be considered in patient with history of heart failure. Thank you very much for your patience hearing.
Thank you, Dr. Paraksha, for your brilliant exposition. Actually, I think the message should be it is an affordable gliptin for Indian patients with CV safety, renal safety, and hepatic safety. Affordable gliptin for India is the need of the hour. So wonderfully said, sir. Any questions? I think next speaker, we'll go on to the next speaker, sir. Dr. Sudhir Bhandari is our next speaker.
Good afternoon.
Yeah, good afternoon. Good afternoon, sir.
Such a pleasure talking to all of you. Profuse thanks to Dr. Bansi Sabu.
Sir, I'll introduce you first, sir.
Yeah.
Can I? Dr. Sudhir Bhandari is a senior diabetologist from Jaipur. He's a triple gold medalist with Professional of Excellence in Social Work with Humanitarian Services. He has published 80 articles in prestigious medical journals and in various textbooks also. And Professor Bhandari is also a unique distinction of being an honorary physician to the His Excellency Governors of Rajasthan and all the chief ministers in the last 20 years. It's a great thing, sir. And I would invite Dr. Sudhir Bhandari to speak on Tadalafil.
Good afternoon. At the onset, I would extend my profuse thanks to Dr. Bansi Sabu and the team of DiCareCon for having invited me. It's been a pleasure talking to you. Will you be playing my slides or you want me to play my slides?
So you have to play your slide.
Okay, slides usko bulao. Just one second. I'll be playing my slide. I just give me 1 minute to go for my slides. Slides.
Sure, sir.
Yeah. No, not this. No, दूसरा ये नहीं है. हाँ, डाइकॉन. डाइकॉन की यही बताई थी. नहीं है. ये देखिए. ये देखो. हाँ, ये वाले डाइकॉन. हाँ. शेयर करनी होगी अपने शेयर स्क्रीन और फाइल शेयर करना है बस. Yeah, good afternoon. Can you see my slides now?
Yes, sir.
Yeah, good afternoon. Thank you very much. Sorry for this little technical hassle. At the onset, I would extend my profuse thanks to Dr. Bansi Sabu, and it's a wonderful to always be on the platform of DiCare. I am going to talk about a very interesting topic, that is endothelial dysfunction, which comes with erection disorder, or it is going hand in hand with multi-cardio macrovascular complications, and how the endothelial dysfunction is important, which is very important, which I'm going to talk about. Yeah. If you look at the root cause of endothelial dysfunction, is it can happen in case of hypertension, it can happen in diabetes, it can happen as a part of dyslipidemia, and this endothelial dysfunction goes hand in hand with atherosclerosis. In case of hypertension, there could be increased blood pressure that leads to the increased pressure in the lumen, which leads to the damage to the luminal aspect of the artery, ultimately resulting in endothelial dysfunction. In diabetes, there's a hyperglycemia, which leads to the reduced production of the oxides, and endothelial dysfunction can happen as a part of glucotoxicity. Now, one of the classical clinical feature of endothelial dysfunction is atherosclerosis, and the clinical diagnostic test for atherosclerosis, carotid intima media thickness. Now, we know that this atherosclerosis, which goes hand in hand with the endothelial dysfunction, affects all kind of arteries in the body. There's a starting point of this endothelial dysfunction, which could start from the cardiac complication or the metabolic complications. And obviously, whenever there is a atherosclerosis as a result of endothelial dysfunction, it hits the smallest artery first. Later, it affects the bigger arteries. Now, a very interesting slide. One of the studies you must have seen 7 to 8 years before came that loss of sexual function, loss of erectile functions, known as ED, goes hand in hand with the occult ischemic heart disease. The endothelium is the same throughout the arterial tree. It follows that there is a problem at one part of the circulation, and there could be problem elsewhere which need to be synchronized and which need to be considered together. If you look at the diameter of the penile arteries, which is 1 to 2 millimeters, coronaries which are bigger than penile arteries, carotid which are still bigger, 5 to 7 millimeter, and femoral is the biggest in diameter, 6 to 8 millimeter. Now, if you have the loss of penile functions, that is erection dysfunctions, then it means the 1 to 2 millimeter arteries have been blocked, which definitely has a generalized effect, and everywhere in the body these arteries can be blocked by the atherosclerosis. Because of the smaller size and the greater surface area, the same level of plaque burden as a result of endothelial dysfunction has a greater effect on blood flow through the penile arterioles, coronary arteries, carotid, and femorals. Therefore, the clinical manifestation of penile endothelial dysfunction may be the beginning or the harbinger of the future coronary or the cerebral or the peripheral vascular disease, and one need to be very careful about it. By the time the lumen of larger arteries becomes significantly obstructed, when we talk about significant obstruction, it means more than 50%, the flow may already have decreased considerably in the smaller arteries. Endothelial dysfunction is more frequent in diabetic patient with silent CAD than without or non-diabetic patient. Endothelial dysfunction not only predicted the CAD. Now here I can use the ED, which is a hallmark of endothelial dysfunction, that is erectile dysfunction, could also predict the future CAD independently of other risk factor, but also was a predictor of silent CAD in many of the studies. One of the classical example is type 2 diabetes, which is hand in hand coupled up with there's a tremendous oxidative stress which brings about the inflammation, which increases the ADMA, which brings about the endothelial dysfunction, and testosterone deficiency, which also is going hand in hand in the type 2 diabetic patient, which resulting in endothelial dysfunction. Ultimately, all this leads to the erectile dysfunction and what we call in short term as a ED. So erectile dysfunction goes hand in hand with the endothelial dysfunction or vice versa, and which is one of the best markers of the extensive atherosclerosis in the body, which brings about the multiple complications. I'll be throwing some light on now endothelial dysfunctions coupling up with the erectile dysfunction, and penis is the lightest thing on the earth. It can even be raised by mere thought. Look at this, the beautiful quote by Leonardo da Vinci: the penis doesn't obey the order of his master who tries shrink at will. Instead, it erects freely while its person is asleep. It must be said to have its own mind by any of its imagination. So this is a very interesting aspect of erectile dysfunction. The term impotence and erectile dysfunction had been used interchangeably. The NIH conference advocated the label erectile dysfunction instead of impotence. So I'm going to talk about the endothelial dysfunction, which is the root cause of bringing the ED and which goes hand in hand with the generalized atherosclerosis with extensive vascular disease, especially cardiovascular disease. ED is defined as having difficulty in achieving the full-fledged erection, consistent or recurrent inability of good performance, and recurrent inability as 3 months or greater in duration. So which is very important and we need to study, which is a part of endothelial dysfunction.
So Sudhir, please unmute yourself.
Yeah. Slides नहीं आ रही. Yeah. Now, if you look at age-wise, over the age of 70, there is 95% likelihood of facing difficulties with ED. and 5% in 40 years of age, and almost 95% 70 years plus people have this ED. There's an important psychogenic component in erectile dysfunction, and it can be caused by emotional stress or psychiatric diseases. 10 to 15% of all the cases, there's an important psychogenic component. And it has also the neurologic, vascular, and endocrine component in 50 to 80% of some cases. If you look at this pathophysiological flow chart of erectile dysfunction, there could be vasculogenic erectile dysfunction, there could be endocrine erectile dysfunction, neurogenic endocrine dysfunction, and all ultimately results in this is leading to the endothelial dysfunction. If you look at the vasculogenic erectile dysfunction, endothelial cells damage leads to increase in smaller vessel disease, and ultimately there's a associated decrease in nitrous oxide components. If you look at the endocrine erectile dysfunction, there's a hypogonadism, hyperprolactinemia, hyperthyroidism, alcoholism, or iatrogenic it could be. Decreased circulatory free testosterone goes hand in hand in the endocrine cause. If you look at the neurogenic erectile dysfunction, there's a central cerebral or spinal cord, peripheral, efferent or sensory neuropathy, or efferent autonomic neuropathy leads to the decreased parasympathetic nerve firing, and there's a decreased nitrous oxide release. All ultimately lead to a common cause of erectile dysfunction which can happen. They are associated a lot of medical issues which could be coupled up with the endothelial dysfunction, leading ultimately to the erectile dysfunction. These are diabetes, hypertension, stress, anxiety, depression, unhealthy diet, increased BMI, physical inactivity, smoking, and alcohol intake, which could all lead to this. And here, as I already talked about, drug-induced autonomic disorder, the hormonal disorder, peripheral disorder, the vascular causes, all can land up in erectile dysfunction. There are certain group of drugs which are known to cause erectile dysfunction by reducing the nitrous oxide concentration, bringing about the endothelial dysfunction. These are antihypertensive, beta blockers, and diuretic, tricyclic antidepressant drugs, antipsychotic, phenothiazines and risperidone, phenytoin and carbamazepine, antihistaminic, H2 agonists like cimetidine, ranitidine, and obviously tobacco and alcohol leads the list. Normally, before we talk about what brings about the ED, one need to understand the physiology of erection. When the brain sends signals to nerve cells by NANC mediator, nerve cells in the penis, corpora cavernosa start producing nitrous oxide. This nitrous oxide stimulates an enzyme called glutenyl cyclase in nearby cells, and this glutenyl cyclase convert GTP into cyclic GMP. Cyclic GMP causes relaxation of arteries. This relaxation increases blood flow, and phosphodiesterase is decomposing this cyclic GMP and turning it back into GTP. So this cyclic GMP is one of the most important component of good erection and good erectile function. If you block the phosphodiesterase esterase enzyme, which converts GMP back into GTP, we can have the prolonged persistence of cyclic GMP, which brings about the good erectile function. Cyclic GMP is produced as long as the brain is sending messages down the nerve fiber in artery, which generate nitric oxide and keep the cycle going on. So it is an excessive cyclic GMP which brings about the lot of nitrous oxide, which is prerequisite for good erectile function. GTP getting converted into cyclic GMP is blocked by phosphodiesterase enzyme. And if we can block this PDE5 enzyme, I think there could be excessive concentration of cyclic GMP, which is prerequisite for good erectile function. Now, if we look at this, what is the role of PDE5, that is phosphodiesterase type 5, break down the chemical that causes muscles to relax and allowing the muscles in penis to constrict and open the venules. This allows the penis to return to soft flaccid state. Now, these phosphodiesterase 5 enzymes are present in plenty in the penile tissue. There are different phosphodiesterase enzyme, that is 3, 4, 9, 11, but PDE5 is a specific in converting into cyclic GMP, and it need to be addressed too. So look at this figure. This GTP, cyclic GMP, is converted back into GTP by phosphodiesterase 5 enzyme. Block this, so there's a persistent of cyclic GMP, which brings about more and more nitric oxide secretion, and it maintains the good erectile function. Otherwise, it gets into the original flaccid position. Diabetes is closely associated with erectile dysfunction. Erectile dysfunction is a common problem among men who have diabetes, and 35 to 75% of male with diabetes have this issue. British Journal of Diabetes noted that 75% of men suffering from diabetes will experience this some degree of ED sometime in their lifetime. Men who have diabetes are thought to develop erectile dysfunction between 10 to 20 years earlier than men who do not suffer from disease, because again, it is a diabetes is acting through the endothelial dysfunction, which brings about decrease in production of the cyclic GMP, decrease in production of the nitric oxide, and decrease in the erectile function. Pathology
Sir,
of that.
sorry to
I'll
interrupt.
just finish.
Time, sir.
Yeah, I'll just finish. So there is a tremendous relationship between erectile dysfunction and CAD. This goes hand in hand, and erectile dysfunction is an indicator of endothelial dysfunction, which is manifesting all over the body, irrespective of size of arteries, in the form of atherosclerosis, and hence one need to be very careful about. Now, there are different ways of managing erectile dysfunction by using PDE5 inhibitors, tadalafil, sildenafil, or vardenafil. Since time is short, I'll just finish on this slide only. Tadalafil has a long half-life of 17.5 hours. Sildenafil and vardenafil has a short half-life of 4 hours. Now, the advantage of tadalafil is that it is a long-acting, and there is a PDE6 enzyme in the retina, which causes the altered vision for the blue and green and some haziness if you use these inhibitors. So sildenafil and vardenafil can have eye side effects, which tadalafil doesn't have. Secondly, there's a normally little fall of blood pressure with sildenafil, with vardenafil, which is not there with tadalafil. So tadalafil has a long acting, has no side effect on the retina. It has no effect on the blood pressure, but only mark of caution is that because tadalafil is a long-acting drug, one need to abstain from nitrates, if at all, to be given for 36 to 48 hours, because they might interact, while need to avoid nitrates for only 24 hours with sildenafil or vardenafil. So I'll quickly go through advantage of tadalafil, and then I'll close my slide. That one of the important factor of ED, that is erectile dysfunction, is an endothelial dysfunction, which can be corrected by 5 PDE5 inhibitors, and tadalafil scores over sildenafil and vardenafil because is more acceptable than sildenafil. More improvement in sexual confidence. Minimum dose requires 2.5 milligram. Don't need to plan for sexual activity because it is effective for almost 17.5 hours. Onset of action is faster than sildenafil, and tadalafil benefits other than ED. It has a good advantage in bringing about pulmonary artery hypertension in many of the cases. Little side effects which are common to the class of the drugs, and it can be given 10 to 20 milligram per day depending upon the need of the patient. And it has a very useful effect, as proven by many of the studies, that tadalafil scores over sildenafil is the pharmacological advantage as well as lesser side effect. So our life is balanced by 4 pillars: love, the happiness, health, and health. For first pillar, we need to have a good ED, and tadalafil could be a better drug to have the first pillar strong. And long-term use of tadalafil is safe, which is a strong message what I can give you to take care of endothelial dysfunction.
Thank you, Dr. Sudhir sir, for your nice presentation on erectile dysfunction and particularly tadalafil. So, Dr. Boraskar sir, you want some? Sir, you are muted. You are muted, sir. Boraskar sir, you are muted. Yes.
Yeah, I think it's an excellent presentation, Sudhir.
Yes.
It was almost like an oration, and so many finer aspects of ED you have taken out in the minds of the people, particularly when now you talk about ED. 90% people think about enforcement directorate, and people have forgotten the real meaning of the word ED.
Yeah, very correct,
And
sir. Very correct.
unfortunately, what happens, people like us who are 40 years senior, uh, you see, very little attention is paid to this major symptom many times. We are more concerned about retinopathy, gangrene, and cardiac. But I think a very good clue that you give us that it is a marker of what is going to happen to your coronaries after some time. So
Beautiful.
I think
Very correct.
a detailed history of erectile dysfunction is mandatory to decide whether this fellow will eventually need angiography or not.
Yes, very correct.
Very good point you brought it, and I think it's very nice.
Thank you very much, sir. Thank you. Thank you very much, sir.
Thank you, Dr. Sudhir sir. So we'll go move ahead to our next presentation. So first of all, I sincerely thank Dr. Banshi sir for inviting me here. So next speaker is Dr. Raju Koil, who is great friend of me. So yes, so he's a consulting diabetologist and medical director of Govil's Diabetes Care Center. He has also associated with Nanavati Hospital, SL Raheja Hospital, Arugyanidhi Hospital. He has invited our faculty or for various conferences. He's also faculty for diabetic fellowship program at DY Patil Medical College, Mumbai. So over to you, Dr. Raju, for this particular. Raju, you are muted.
So thank you, Rajesh, for those kind words, and thank you, Dr. Bansi Sabu and the entire DICARE team for having me here. So we had Dr. Sudhir Bhandari thrilling us, and we're going to have Dr. Boraskar thrilling you all also after my talk. But importantly, I'm going to focus on repaglinide and the combination of repaglinide plus repaglinide plus voglibose, and this is my the whole roadmap of how we are going to condense this into a 12-minute talk. We all know that there are multiple pathophysiological defect, and now we are treating the pathophysiology, but it's important to realize that the patient becomes a diabetic only when his beta cell is deficient, and most Asian Indians have beta cell deficiency, and we are looking at a huge amount of diabetics. Every third, fourth Indian is going to become a diabetic. And today, when we control blood sugar, it's just not the blood sugar. We are looking at glycemic variability, and we're also looking at important parameters like postprandial hypoglycemia prevention and glycemic variability. So it's important that the first phase of insulin secretion, which actually primes the peripheral tissues for the uptake of glucose, is actually lost in patients with type 2 diabetes. And the second phase is much impaired as compared to patients without diabetes as such. And if you look at it, majority of us remain in the post-absorptive state. Last year at DICARE conference, we all were having so much of fafda and jalebi that our postprandial blood sugars would have been higher for at least 48 hours. But if you look at it, 16 hours, almost most people remain in a post-absorptive state. And that's the problem, that postprandial state just doesn't mean the 2 hours postprandial. And if you look at the contribution of fasting and PP to HbA1c, this is data from Monier. When the HbA1c is higher, the fasting contributes 70%. As the HbA1c gets closer to goal, the postprandial contributes 70 to 75%, which means in Caucasian people, if you have to get the patient from 10 to probably around 8.5, you need to fix the fasting. But if you have to get him closer to goal, you have to take care of postprandial. This similar data from Wang and all suggested that at every HbA1c, East Asians, including Indians, contribute higher in postprandial. So whether the HbA1c is higher or lower, Indians should target postprandial for better HbA1c. Again, we all know that how postprandial is associated with increased endothelial stress, and it's like an endothelial tsunami which occurs. And a lot of studies have looked at postprandial, and the Honolulu Paris prospective study, and so many decode, which looked at various quartiles of postprandial, and as the postprandial goes up, cardiovascular death and cardiovascular mortality increases. The value for postprandial differs a little bit. RSSDI and the IDF looks at 160, ADA looks at 180, ACE looks at 140. It's important that it's measured with a capillary blood glucose or with a plasma glucose. Again, from the start of the meal, not from the end of the meal, because there can be people who end up eating for an hour also. And if you look at the available pharmacotherapy we have over the years, now we know that alpha glucosidase, metformin, and DPP4 or incretin-based therapy, which target the paradoxical high glucagon, have very, very good effects on postprandial, including short-acting insulin. So these are the various drugs that we have to actually manage postprandial hyperglycemia. Ukpedias gave us a very good example that 50% of our functioning beta cells are lost, and 6% every year, which means that majority of patients with 5 to 7 years of diabetes are completely beta cell deficient. This is Del Practo's study, which looked at whether we should go by conceptual approach or whether we should be more proactive. Most of the algorithms actually look at it's an algorithm to fail, because they want us to add another drug after a particular drug fails. Del Prato actually told us almost a decade and a half back that submaximal dosage of multiple agents targeting multiple pathophysiological defect is the need of the hour. It is saying polytherapy is in, polygamy is not in. That's how we should be actually be treating patients with diabetes. We come to our the main topic of the day, repaglinide. Most importantly, repaglinide is an insulinotropic drug. It works at a different receptor, not the SU receptor. Majority people who are listening think that repaglinide is a short-acting SU. Repaglinide comes from meglitinides. It's a benzoic acid derivative. It works in a different receptor as compared to SU. It again has a very short action on the ATP sensitive potassium channels. It is very insulinotropic. There is data comparing repaglinide versus glyburide in rodent cells, which tells us that the action of repaglinide is not there when the glucose level is low. That means the potassium channel actually closes, or sorry, doesn't open when the glucose is low. That makes it very insulinotropic. Secondly, benzoic acid derivatives like repaglinide do not enter the cell. That's why the prolonged depolarization which occurs when the calcium channels open, which is seen with SUs, and the prolonged hypoglycemia is not there. That is the reason that repaglinide has a feature which is very different from SU. It is very short action, short duration of action, and again, that makes it a feather in the cap. So I always make a statement that patients who do not use benzoic acid derivatives and intermediate acting SUs like glyclazide do not understand diabetes physiology, because for every particular patient, glimepiride is not the choice. Again, as I said, elicited rapid release taken with meals, reduce risk of long-lasting hypoglycemia, because it's faster association and faster dissociation. It improves beta cell function. Efficacy is very similar to SU, but again, as I said, the potency may be higher as compared to something like glyburide, because it enters the cell and there's prolonged depolarization which occurs, and that's the reason. And secondly, because of its shorter action, it's very, very good to use in patients with chronic kidney disease. As the same things which I was telling you in the previous slide. Again, insulinotropic action, distinct binding, greater insulinotropic effect than glibenclamide, rapid onset of action, glucose dependent is extremely important. Tested now, because it's an off-patent drug, you will not have a lot of insulinotropic studies, but tested in rodents with glyburide as an active comparator, restores early phase of insulin, rapid onset of action. If you look at it, a lot of people believe that it is a lower potent drug, but it is not. When you compare it to glimepiride, the potency of postprandial control is better with repaglinide, and fasting similar as compared to glimepiride. It takes around 3 to 4 weeks for the action to set in. It also reduces a lot of postprandial risk factors which are related to the heart, which may be lipoprotein small a, plasminogen activated inhibitor, and homocysteine. So postprandial hyperglycemia goes along with it. also a lot of postprandial lipemia and a lot of inflammatory risk markers, and that's what reduction in postprandial hyperglycemia will cause. This is one study which compared the addition of repaglinide versus an insulin secretagogue like glimepiride and on patients with gliptin, and it shows that repaglinide did get better HbA1c reduction. This is a registry and an analysis of almost 9 years from the Danish patients and almost 100,000 patients here, where metformin is used as the baseline study drug or the reference point drug, and the cardiovascular effects of all the secretagogues have been compared with metformin. And as you can see, glimepiride, glibenclamide, and tolbutamide have increased hazard ratio towards cardiovascular death, all kinds of 3-point MACE, whether in patients with previous myocardial infarction or without myocardial infarction. But it's only repaglinide and glyclazide actually which has a a reduction in cardiovascular death and in 3-point MACE. So this particular test, so you are not going to have a comparator study in terms of cardiovascular outcome trial with SUs, but this kind of a study which has almost 100,000 patients, where you had close to almost 15,000 patients with previous MI, shows us the cardiovascular safety of molecules like this. Again, it's very, very important that we need to use two molecules which have synergy in them. Voglibose plus repaglinide have a huge synergy. I look at them as a power couple, actually, like Anushka and Virat Kohli. They are a power couple. They're going to give rise to Virishka, and these two people gave rise to Urepa V. So alpha glucosidase inhibitors, we all know, are competitive inhibitors of enzyme needed to digest carbohydrates. They inhibit the reabsorption of carbohydrates from the system, from the intestine. They have a Voglibose has a very high inhibitory activity of maltose and sucrose, reduces oxidative stress, lowers glycemic excursion. We all have used alpha glucosidase for reducing glycemic excursion. But one very important indication for alpha glucosidase is also to reduce reactive hypoglycemia. So where the insulin peaks and then later there's a later postprandial peak, all kinds of alpha glucosidase work. That is where the effect of repaglinide plus voglibose becomes synergy as such. So most importantly, what voglibose does is delay the distal intestinal absorption of carbohydrates. So there is no peak or there's no glycemic peak which occurs, but there is a delayed absorption, because of which the hypoglycemia is lesser. And that is why there is going to be a lot of synergy when you use a shorter acting secretagogue with voglibose, which actually blunts the rise of glucose as well. So there's a reduced postprandial glucose excursion, with which there's also, because you have distal entry of carbohydrates or nutrients into the system or into the small intestine, you have increased GLP-1. Now, why use repaglinide plus voglibose? Again, it maintains therapeutic parsimony, which basically means the FDC makes our pockets much reliable to use. It overcomes a high failure rate, will be effective in controlling postprandial, is very rapid and short acting. Both of them are pretty short acting, as you can see. Better efficacy compared with monotherapy. AGI modifies rapid insulin release. If you look at it, the synergy of both of them, they are metabolized very similar. Indications are type 2 diabetics as an adjunct to exercise, and again, most of the patients where we want to use a shorter acting SU, or patients who have hypoglycemia to SUs, patients whom we actually want, or elderlies with CKD are the indications to be on this particular drug. Renal impairment, hepatic impairment, it is also safe. Actually, it's also safe about 12 years of age. Geriatric use, we can be using it. There is this phase 3 study which actually gave them the indication and approval in India. It's a 24-week phase 3 study, which is an open label study, multicentric study, which looked at 4 dosing of repaglinide plus voglibose versus only repaglinide. And what it showed is that after 24 weeks, patients who were on repaglinide plus voglibose as compared to repaglinide had a better HbA1c reduction, and also had much better durability in the long term as such. So as you can see, the HbA1c reduction at the end of the phase 3 trial was much superior to plain repaglinide, and the fixed dose of repaglinide plus voglibose resulted in significant reduction in HbA1c as compared to repaglinide therapy. Again, if you look at postprandial, excellent reduction in postprandial because both are postprandial regulators. If you look at PPG over time, you see a good reduction in postprandial with this FDC of repaglinide plus voglibose. Again, as I told you, that the benefit is that you got more hypoglycemia with repaglinide rather than repaglinide plus voglibose. This is what the advantage is, because we are using alpha glucosidase for reactive hypoglycemia. It blunts the acute rise of glucose by making the carbohydrate spill over into the later part of the intestine or the large intestine, and that's the reason the hypoglycemia in this phase 3 study with repaglinide plus voglibose was lower as compared to repaglinide alone. So in terms of safety, there's no serious adverse drug reaction safety profile of the FDC was compared to repaglinide. In conclusion, a good reduction in HbA1c with the FDC as compared to monotherapy, weight neutrality, insulinotropic. So again, weight neutrality, no adverse drug reaction, insulinotropic. It is very much similar to a DPP-4 inhibitor. So what are the situations? Elderlies whom hypoglycemia is a concern, that is where I would really push it. Patients with kidney failure, patients who actually have hypoglycemia to low dose SUs, patients with irregular meal patterns. So it came with a tagline of no meal, no dose. So if you're not having a meal, don't take a dose. If you're delaying a meal, take the dose. So there's a lot of variability or flexibility we can give with this kind of a product as such. So in summary, I would summarize that the fixed dose combination of a benzoic acid derivative like repaglinide and an alpha glucosidase inhibitor like voglibose will provide better efficacy. Both of them have different mechanism of action. Both of them have reduced chances of hypoglycemia. Repaglinide is insulinotropic. Voglibose doesn't cause, acts on the gut. So again, there is no hypoglycemia which occurs and no evidence of any kind of clinically significant pharmacokinetic interaction between repaglinide and voglibose. Thank you so much. They had weight neutral and fewer hypoglycemic events as compared to monotherapy. Thank you so much. Over to you, Rajesh.
Thank you, Raju, for nice presentation and very lucid deliberate talk regarding repaglinide as well as the combination of repaglinide voglibose. And we know that in our practice, the uses of glinides are not that much. If you consider, if you compare the uses of all anti-diabetic, oral anti-diabetic medication, then the miglitinide are on the very lower side. So, and this is very important and nice molecule whenever there is postprandial hyperglycemia. And any comments from our senior colleagues? Dr. Raghu, sir? Sir, you are muted. Dr. Raghu, sir, you are muted.
Dr. Raghu, you are on mute.
Yeah, I am unmuted, yeah. You brilliantly said, and as the punchline was, no meal, no dose. That should be the right way, and very nicely presented, brilliantly presented. I think we should use in more and more number of patients. More and more number of patients, as he rightly said, that we are just, people are very fond of using long-acting glimepirides. Anywhere and everywhere they use glimepirides. And as rightly mentioned, low-dose glimepirides still having hypos. I think this should be the best combination which is available in the market. Shorter acting, very brilliantly said. Thank you. Wonderfully said.
Important thing is glucose-dependent action. That is very important. And so hypoglycemia evidence are very much on lower side as compared to standard sulfonylurea.
Yeah.
Sir, any comments, sir, from Boroskar, sir?
No, I think, Raju is my boy. He almost, because of short of time, he almost said the whole thing like a puthi during the puja, when the Pandit comes and he finishes 6 paged stump in 2 lines. It was very unfair that for a topic like this, Raju was given only 12 minutes. But I think what message he conveyed in the 12 minutes is a really mind opener, and particularly the mule-headed diabetologists like me who don't change very easily. We were quite convinced with this combination. So full marks to Raju.
Thank you, sir.
Good show.
Now the big guns are coming, Dr. Sharma and Boraskar. So enjoy the show.
Thank you, Raju. And
Thank you so
now
much,
I would like to welcome Dr. Kamal Sharma for his presentation. He is delivering lecture on particularly Vaimada. So just a small introduction for Dr. Kamal Sharma. He is a senior interventional cardiologist with vast experience in coronary angioplasty, stenting, valvuloplasty, pacemaker. He has a rare combination of DNB degrees in both medicine as well as cardiology. He's also DM cardiology. So he has awarded almost 22 gold medals for his academic excellence during his medical career. So almost 200 publications and 6,000 citations. So very good. Definitely we will listen about Vaimada. So over to Dr. Kamal Sharma.
Good afternoon, everyone. Thank you. Thank you, Dr. Bansi, Diacare, for inviting me, giving this opportunity to me. I'm talking about Vaimada, and people would wonder what is this doing in a diabetology conference. So I'm going to touch upon this ARNI concept and diabetology, how this has worked very differently. I'll just touch upon heart failure also to some extent, and then I'll focus upon how ARNIs actually do wonders sometimes in even diabetes. Of course, any heart failure, we'll have to first talk about the grades and the stages of heart failure. And we know that anybody whose diabetes is actually stage A, even if he does not have any structural disease. So all diabetics are practically ACCH or AHA stage A heart failure. We know that they are at risk 5 times in women and twice in men. If they are diabetic, 25% of them would actually present with chronic heart failure, 40% with acute heart failure. And this is the various pathophysiological mechanism, which is beyond the concept. And I'm going to just touch upon how the drug works, how this pathophysiology is going to get altered when we touch upon therapies like ARNI. Diabetes, of course, this has been talked about in all the previous talks as to how diabetes capital we have been mislabeled or dislabeled or disabled by this pandemic that is ensuing in diabetes and ensuing heart failure. So basically, not only it's the inflammation that we talk about causing ischemic cardiomyopathy that we know in diabetics, but more importantly, it's the RAS and the calcium abnormal handling, apart from autonomic dysregulation, which apart from hypertrophy, all lead to cardiac myocyte disarray and leads to worsening of heart failure. In heart failure in adult diabetic patients, the risk factors would include longer duration insulin usage, poor glycemic control, higher BMI, presence of microalbuminuria, low eGFR, presence of ischemic heart disease, and presence of peripheral vascular disease. If any of these risk factors are present, they all multiplicatively increase the risk of development of heart failure. And there is in type 2 diabetes, 18 milligram % increase in baseline fasting is associated with modest increase in the risk of hospitalization, and 1% in type 1 is associated with 30% increased risk of heart failure hospitalization. So this increase in incremental and multiple risk factors that I've talked about, including dysautonomia and mitochondrial disarray, lipochlorotoxicity, metabolites of the fatty acid metabolism, all of they actually contribute to the same. If we look at the presence of diabetes and heart failure, whether you talk of paradigm HF or you even talk of the CRT therapy, almost 35 to 40% of patients would constitute diabetic population. And it's the lowest was in enalapril study in SOLVE, which was 15%, but that was probably not actually a selection bias rather than the low prevalence per se of diabetes. Even if you look in the other therapy designs, even there, the prevalence of heart failure therapies have ranged in diabetics range from 10 to 30%. And these are strong impact of clinical management of the prognosis in heart failure, whether we are talking about especially in the reduced ejection fraction, it's an independent predictor of fatal and non-fatal outcome with worsening of CV mortality as well. In all the trials, when you look diabetic versus non-diabetics, whether you talk of SHIFT trial, ECO trial, ECO-CRT trial, Seniors trial, MERIT-HF, CHARM, beta blocker trials, diabetes is associated with increased all-cause and CV mortality in heart failure, from ranging as from 50% to 5% in various studies. So it's a strong predictor not only for worse outcomes with incremental risk ranging from 1.2 to 1.9 fold. And the impact of diabetes on clinical outcome at 1 year itself has 7% increase in the risk of CV death, with 27% increase in risk of heart failure hospitalization. And if you look at the long-term mortality rate, 50% amongst heart failure patients would be with diabetes. So heart failure is frequent forgotten complication of diabetes, and that's why an ARNI has to find its place. And I'll touch upon two other aspects that ARNI alter in managing or improves upon in managing heart diabetes in patients who are put on this therapy. So unmasking heart failure early in patients with diabetes is imperative, because 50% individuals with LV dysfunction remain undiagnosed and untreated. And moreover, clinicians should not overlook diabetes patients with stable CAD who may present with atypical symptoms just like dyspnea or discomfort, no angina actually. And early diagnosis can help to prevent worsening, including heart failure, hospitalization, or debilitation. Now, we know that before all the trials I touch upon the ARNI, I want to go and take you on to background of the therapies that we exist before the paradigm actually happened, which included the ACE and ARNI, of course, now coming as the centerpiece, the therapy. Beta blockers, diuretics have good been in the place, but the inotropic therapy, enoxaparin, milrinone, etc., have disappointed. Even nesretide, which was a recombinant BNP, actually failed. And there are some more recent, which I'll, if time permits, will touch upon to some extent. Now, we know that management of heart failure in diabetics should be focusing around not only the diabetes control, but also look at the heart failure remodeling. And that would, apart from an SGLT2 and the other beta blocker therapy, you would always look at the ARNIs because of their neurohormonal activation, apart from nelpresin activation, which can be blocked by this dual pathway. And apart from the GLP-1 analogs also playing in some role in inhibiting inflammation, the therapy in a heart failure would hence be focused from a diabetologist perspective around SGLT2, GLP-1 analogs, to some extent ARNIs as well, apart from metformin. So we know that trials have shown in diabetics also. I've looked into the various therapies and diabetic population kind of analysis here. So in diabetics, ACE inhibitors, ARB, beta blockers, MRN, ivabradine, in all their important trials like SOLVE, SAVE, renal on target, emphasis at heart failure shift trial, all actually showed that the impact was irrespective whether patients were diabetic or not. So this is the common donkey analogy that we talk in heart failure. This is either you reduce the number of sacks on the wagon, the heart is a tired donkey taking the increased load on its wagon, and you can unload it by the dilators, the diuretics and ACE, and now, of course, the ARNI, or you can put a carrot to the donkey and make him flog, which is going to be harmful in the long run, the digitalis compound-like therapies. But if you limit and make the donkey accept that the donkey is going to run slow, probably you can be able to take it more longer. But very important, you put skates to the donkey, and then you can actually roll the donkey pretty fast, which is the resynchronization therapy. So neither the R, apart from the recent advances, not only would be several anti-diabetic drugs have been implicated in worsening, like the glitazones, but very importantly, now we know, of course, SGLT2 therapies, which actually form a cornerstone in managing diabetes if there is heart failure. Off top of that, we have ivabradine, ARNIs, the IV iron therapies in form of confirm HF trial, epigenetics, and you now have new devices like vagal nerve stimulation device. Now, let me focus on Vimeda, which is the therapy today that we are supposed to be talking. It's the pharmacological biotarget. Basically, nelpresin is actually the pathway which modulates and metabolizes the bradykinin. Now, bradykinin is the one that we always blame for cough, but remember that this also is a potent vasodilator through the bradykinin 2 receptor. And it not only reduces the blood pressure, increases nitric oxide, and increases natriuresis, but may have important effects in the remodeling and further improvement in reduction in the preload. So BNP itself, though being an important parameter, which is responsible for, that's why people actually evaluated nesretide, but it failed. But we know that probably bradykinin and BNP both may have benefits on the preload aspect, apart from the afterload reduction that ARNIs, valsartan would give, that the therapy may have additional benefits which you can get out of this therapy. And hence the neuroendocrine balance, which was to balance between the ANP and others versus catecholamine ROS on the other side, which we are taking care of with valsartan and beta blocker. You would wish that you could balance the sacubitril mediated inhibition to balance out the vasodilators with the vasoconstrictor neutralizing effects of the other therapies. And that's how the equilibrium would finally achieve with the RNA therapies. And we know very much now from this trial, which actually Paradigm HF showed that there was a 20% reduction in primary composite endpoint, including CV death and all-cause mortality by 16%, apart from heart failure hospitalization. But when you talk of diabetes, this is something additional that we are talking about. We are talking about sacubitril valsartan mediated AT1 receptor blockade, apart increasing insulin sensitivity, increasing GLP-1, increasing bradykinin, increasing natriuretic peptide, increasing cyclic GMP in the skeletal muscle, and also decreasing DPP4 activity and hence facilitating beta cell function. And these are the various postulated mechanisms that have been hypothesized how it would probably be facilitating diabetes per se through its various pathways. Now, if you look at two important subgroup analysis of the paradigm with regards to diabetes per se, the first one is comparing the same with enalapril in terms of glycemic control. And second is the effect from time to first initiation for injectable insulin or oral anti-hyperglycemic agent in patients who were diabetic. So when you look at the all-cause outcome, of course, there is 20% reduction in the death, but this is very important that it works pretty much well even in pre-diabetics actually. So diabetes, of course, there is benefit, but also there is difference is present across the spectrum of normoglycemic to diabetes, all being statistically significant. If you look at heart failure hospitalization, again, the same across the group, it reduces the same. If you look at quality of life questionnaire, and that also at 8 months was significantly improved, even in pre-diabetics, undiagnosed diabetics, or even diabetics per se, with 17% improvement in quality of life. So even if we look at the change in the A1C, this is something very interesting, that probably ARNIs actually have some amount of anti-diabetic action. They actually end up reducing A1C over a period of 1, 2, and 3 years in the range of almost 0.5. So as the time goes by, probably worsening of the heart failure as it is prevented, maybe the sympathetic and the adrenotoxicity that worsens the glycemic control may also be one of the postulated mechanism, but there might be some other responsible mechanisms as I had elucidated earlier. Even when you look, they all move to a lower A1C category, with 11% more patients move to a lower A1C and 14% less likely to have moved to higher A1C. You can look at the 29% reduction in the requirement of insulin and the safety, of course, glycemic, it provides better tolerability than enalapril for renal safety. SGLT2 is something that I need to not talk about here. Cupid trial or some other therapy, which I can easily skip. But device therapies have now also looked at the vagal therapies, which people are talking about. And vagal nerve stimulation device actually probably mediate a lot of action through autonomic regulation, which again is RNA talking about. And this is our own publication published in Journal of American College of Cardiology about Anthem study and the Barostim device that we implanted. So the guideline recommendation, of course, there is no constraint in treating the RNA, and this is the proposed algorithm with regards to device therapy. But what I intend to propose and suggest and emphasize upon is the need of RNA being so strong in patients with diabetes, with heart failure, that they would not only control diabetes, heart failure very well and reduce the all-come outcome, including mortality, but very importantly, it has got benefits in terms of need for new insulin started and also some amount of reduction in the A1C per se by giving this therapy. So this is to summarize hyperglycemia, insulin-resistant hyperinsulinemia, and diabetes as a cascade of deleterious effects that contribute to development of heart failure. Heart failure and concomitant diabetes increase risk of morbidity and mortality, which is overlooked in diabetics. There are no specific constraint for the therapy, but a heart failure therapy with protective agents against incident diabetes and worsening glycemic control are welcome. And very importantly, Vimeda and its anti-heart failure regimes provide clinical improvement and improves glycemic control in heart failure with reduced ejection fraction and with diabetes. And now we know that it has been approved in even heart failure with preserved ejection fraction recently as the new therapy for patients with reduced preserved ejection fraction also. Thank you very much.
Thank you, Dr. Kamal Sharma, for your wonderful presentation. Also emphasize the need for using these drugs in pre-diabetics also. Thank you. So over to Rajesh again. Yeah, you can introduce.
Yes, nice presentation, Dr. Kamal Sharma. So just want to discuss, because this is basically diabetes conference, and right now there is always, I think everyone is speaking about SGLT2 inhibitor and for heart failure. So in a patient of diabetes particularly, whether it's SGLT2 inhibitor or Vimada, we should, how to differentiate that both these molecule anti-diabetic, because
Good
this is
question. I
actually
think
developed
it's
for
not either
diabetes.
or. Yes, I think it's important that you do control diabetes well, but I don't think it's a question either or, because even in DAPA HF trial or even in the Emperor reduced, both the arms, there were 20% of the patients in one the study were 18%, other patient study was 20%. Patients already were on ARNI. So now we have data enough to suggest that ARNI with an SGLT2 is better choice rather than either alone. But if you ask me if the patient is diabetic, what do I do for diabetes control? I think we'll have to categorize SGLT2 as a heart failure therapy first, because diabetes is not going to kill per se, it's going to kill through heart failure. So you need to have an SGLT2 not just for glycemic control, but even as for heart failure therapy. So if the patient is diabetic, of course, you choose an SGLT2 as the first line as an anti-diabetic. But even if the patient who is not diabetic, 50% of the heart failure patients in both the trials were non-diabetic, they also improved for their heart failure outcomes. So SGLT2 along with ARNI is the best strategy to go. Of course, the concerns are people talking about renal safety and people talking about worsening of blood pressure, fall in blood pressure. But both the trials have clearly shown that you can actually cut down probably on the dose of diuretics and instead continue with this dual therapy, and renal preservation, renal function improvement, all are actually documented in the long run with improved outcomes and CV safety.
If I am allowed to add one or two lines to Dr. Sharma's brilliant presentation, most important thing, why we talk about SGLT2 inhibitors in patients with a possibly preserved ejection fraction and also who have no classical clinical symptoms of cardiac failure. One important thing SGLT2 inhibitors do, they cause volume contraction. The most important, the weight loss is also there, but the weight loss, more than that, there is a fluid loss, which is a desirable thing both for the tired horse and both for control of diabetes. So SGLT2 inhibitor has a very unique role. Apart from blood sugar lowering, it causes volume contraction, and that is beneficial for preserved ejection fraction heart failure patients.
I agree completely with your point of Daniel. It reduces the volume, and that's all volume that is not required volume. The volume that is present in the interstitium, in the extracellular spaces, and it doesn't shut down your intravascular volume. And that's why it's better than the diuretic, because diuretic will kick out the fluid from your intravascular compartment and hence cause pre-renal azotemia. And that's one of the mechanisms why they actually preserve renal function despite causing volume loss. Fantastic point.
Second thing I'll just add to that, many of so-called well-controlled diabetic, when they come to aggressive diabetologists, and when you put a patient on insulin, there is certain amount of volume gain. People who are treated recently on insulin, they gain as much as 3 to 4 kilos of fluid, which you can get rid of with the SGLT2 inhibitor. This is another problem. Insulin-treated patients have a little volume expansion, which we don't want.
Absolutely.
A question to Dr. Kamal Sharma. Is 100 systolic a cutoff limit for starting on ARNI, or can we, carefully monitor once in the hospital, if blood pressures are being monitored? So can we start at a bit lower dose, say 90, 60 or so, or only 100? Only if it is beyond 100 only, then we should initiate?
Fantastic question, because there is another subgroup which is not part of diabetes, so I did not discuss upon it. Like the A1C paradigm that you have for SGLT2, the patients who are more on higher A1C do better with their SGLT2 in terms of weight loss, etc. In ARNI also, the patients who do better are the one who have lower pressures, not the one who have higher pressures. If you do a subgroup analysis, patients whose blood pressure is low actually is reflective of bad LV functions. So these patients whose blood pressure are between say 90 to 100 or 110 would have more reduction in CV events as compared to somebody whose blood pressure is 150. So though safety in tolerability is easier with high blood pressure, but the benefits in long run are better in the patients whose blood pressure have remained lower. So cutoffs for me are 90s, not hundreds. But your point is very valid, because the trial design was like that. In the trial, in the paradigm, it was studied for patients with blood pressure more than 100. But in real world, we do use it up to 80 systolics, as long as potassium is fine, patient is not symptomatic, his creatinine is not rising, and patient is comfortable without any symptoms and giddiness. Because hypotension by definition is defined as a pressure where the patient gets symptoms of hypoperfusion of organ or blood pressure less than 90. So it's not that your 110 is hypotension or 100 is hypotension. It is hypotension if he's symptomatic. If he's asymptomatic, up to 90, patient is not defined as an hypotensive unless he has symptoms of hypoperfusion. The patient's creat is fine, potassium is okay, he's producing good urine, and his blood pressure is still 90. I would not be worried of starting an army.
Thank you. Brilliant answer. Brilliant answer. Thank you.
Dr. Kamal, Dr. Chintan here.
Hi, Chintan bhai.
Hi, how are you? Yeah, excellent presentation. With this SGLT2 inhibitors now getting very affordable with the DAPA available. So do you think that the use of ARNI will increase by the physician? Because the cost is the major concern in our setup. So once SGLT2 inhibitor also going on, plus you add up ARNI, then the cost may not be that much favorable for the routine patient. So I think that what are your
fantastic point. Fantastic point. I think you framed it when you started off. I was worried you will say, okay, because SGLT2 have become cheaper, so somebody would end up preferring SGLT2 over ARNI. But actually what you did is a fantastic line. The money that you save from SGLT2, you pass it on to ARNI. So that's a good strategy to use. Actually, the overall cost will go down. And of course, the ARNI cost is also going to come down. It's what we do, the Indian jugaad we all do, right? So 200 milligram half BD is much cheaper than 100 BD, because that comes at 58 rupees, 78 rupees versus 72 rupees. So you do 78 rupees half BD is 100 BD, but 101 BD is costlier. So this is the Indian jugaad we all play around. I mean, that's what we did with the SGLT2 also. With the 25 milligram of EMPA, we would give half a tablet and make it work like 10. So that's the Indian jugaad that's going to save some money. But I think that's the strategy, that the money saved on the SGLT2 should definitely be passed on to the ARNI in terms of managing the heart failure.
So thank you, Dr. Kamal, for your nice answering this question nicely. And thank you. So thank you. Our next discussion is on seraglutazole. So we know that it's a dual PPR gamma alpha agonist, and it's an Indian molecule. It's developed by Indian company. So we should proud of it. So Dr. Anil Boraskar sir. So I think sir. So he's like basically I am also from Mumbai. So introducing him is a very pleasure for me. So he's a MD FRCP, particularly he did his FRCP from London. He's a honorary secretary of and scientific section of Diabetic Association of India from 1984. He's actually professor of diabetology, and he's attached with Raheja Hospital for almost 13 years. So he has almost many papers, many publications, and oration. He has many chapters on textbooks on diabetes, and he has received many awards. So over to you, sir.
Thank you very much, Dr. Deshmane. I think the time allotted to me on this important molecule, you will be showing the slides, I'm sure, Dr. Deshmane.
No, sir. Slides
I have sent my... No, I have told Hardik.
I'm sharing them.
Okay.
Yeah. So saraglitazar is one of the underrated molecule, unfortunately, all this time. And management of triglyceride is a major issue. And many times we feel that we are chasing wrong phantom. We are running after cholesterol. Well, cholesterol is not a risk factor for Indians. The Indian risk factor is insulin resistance and high triglyceride. Next slide, please. Next slide. Insulin resistance and the major complications. What are the insulin resistance leading to? Next slide. type 2 diabetes, atherogenic dyslipidemia, and non-alcoholic fatty liver, NASH, which is a very big problem today. 45% of the population has this. Asian Indians have low insulin sensitivity compared to Caucasians. Next. Next. Next slide. Next. Yeah, now this is a very famous picture of Yagnik and Yudkin, both having the same BMI. Go back to the same slide. Both having the same BMI, but the fat content of Yagnik is more than Yudkin, and that's a typical Indian phenotype, a thin fat Indian. A prevalence of insulin resistance seen in children. Obese children are increasing. In India, between 14 and 19, we have a very large number of obese population. Next slide. Next slide. So insulin resistance is associated with elevated triglyceride. In Indian typical atherogenic lipid profile, what we have more synthesis of cholesterol and the triglycerides. We have more low density lipoprotein. We have low HDL cholesterol, overproduction of VLDL cholesterol, defect in triglyceride hydrolysis, defect in hepatic trigyl remnant uptake. And therefore, we have insulin resistance, which is coupled with the decreased free fatty acid tapping, increased free fatty acid in plasma, increased triglyceride, and increased very low density lipoprotein, everything amounting to early atherosclerosis. So this is a typical Indian lipid profile. Next slide. Next slide. So now ICMR INDAB study have shown clearly that we have low HDL. Most common dyslipidemia is low HDL followed by high triglyceride. Next slide. So Indians particularly, we have extremely vulnerable with a high triglyceride, high low density lipoprotein and low HDL. The protective HDL is low. So typical atherosclerosis of an Indian. Next slide. Next slide. Next slide. Yeah. Elevated triglyceride, elevated triglyceride is a major risk factor of cardiovascular disease. It is the native triglyceride. And if the patient has to be female, the elevated triglyceride has a risk factor 4 times than that of man. The triglyceride elevation in female is more dangerous, and that is why we are extremely careful in controlling triglyceride in a female type 2 diabetic. Next slide. BARI 2D study shows that the mean follow-up of 5.5 years. Next slide. What does it show? It's very important. Higher triglyceride is associated with higher CV risk in diabetics. If you are a diabetic, you have a risk of CV. If you are a diabetes with high triglyceride, risk becomes double or sometimes 4 times. And if you are low HDL, it still enhances. So a diabetes with a high triglyceride and low HDL is a prescription for trouble. Next slide, please. Next slide. Next slide. I think we go back. We'll skip these slides. Next slide. Next slide. Next slide. Next slide. Next slide. Next slide. Yeah. Does reduction of triglyceride reduce CV mortality? Now this is a question. The present molecule that we are discussing, because it is unique. Saroglitazole is a unique. Saro means good. It's a saroglitazole. Saroche. Why does it help? Does reduction of triglyceride reduce CV mortality? Yes. Next slide. Next slide, please. CV outcome data of TG lowering drugs. Studies in field, accord, and reduce it. In subgroup analysis, fenofibrate therapy effectively reduced CVD study with triglycerides more than 204 and HDL less than 34, and the definitely improvement in CV deaths. Next slide, please. And MI and stroke. Next slide. Next slide. Saroglitazole, the first NSC of India. Next slide. What is the progress? 2013 DCGG approved treatment of diabetes dyslipidemia, and in 2020 it is approved for NASH. This is the progress in not only type 2 diabetes, but NASH is seen in many non-diabetics. So this is a drug which has been found effective in taking out all the rubbish from the liver, put it back into circulation, and we had a big problem of fatty liver even in healthy population. In Bombay, they did a survey. They found that 48% of Bombay's type 2, not type 2, people above the age of 45 had NASH. So it's such a prevalent condition. Next slide. Next slide. Next slide. Yeah. Now this saraglitazole is a unique drug. Next slide. It has a fantastic action. Next slide. If you see the action of saraglitazole, next slide. It is effective both on PPAR gamma as well as PPAR alpha. PPAR alpha is a major action. Next slide. It is not a thiazolidinedione. It is not a thiazolidinedione having only PPAR gamma action. It has a PPAR alpha action. And how does it benefit us? Next slide. Now see this carefully. Mechanism of action. PPAR alpha action reduces triglyceride and non-HDL, increase fatty uptake, increase fatty acid oxidation, increase ApoA1 and LDL, HDL, reduction of VLDL and triglycerides, reduction of ApoC3, and it has an anti-inflammatory action. This is a primary effect of saroglitazole. And PPAR gamma action improves insulin sensitivity, increasing beta function, increasing fatty acid uptake, increasing adiponectin secretion, and it is also anti-inflammatory agent. So this is one drug. You have two major areas covered: PPAR alpha, which is a major action, and a very little PPAR gamma. Therefore, there is a synergism in one molecule. Next slide. Next slide. It improves insulin sensitivity. Next slide. Next slide. We'll skip these slides. Let's skip this slide. It just emphasizes on that point. It improves glucose metabolism and insulin sensitivity index. Next slide. So it has an action on insulin sensitivity. It reduces elevated triglyceride, HbA1c, and ALT. Integrated review analysis, which has come up in cardiovascular disease journal, extensively studied by Kaul et al. Next slide. Upendra Kaul is an authority on this subject. Next slide. Next slide. So integrated review analysis of 18 clinical studies amounting to almost 6,000 patients, reduction of triglyceride, non-HDL, standard LDL, HbA1c, and ALT. So it acts at 5 different areas. 5 different areas, particularly the portion of the liver. Next slide, please. Next slide. Next slide. Next slide. Yeah. Now, insulin resistance, if you see, the triglyceride accumulation is a cause of one finger, two finger, papa liver. And this is because insulin resistance, there is a glucose insulin disparity and leads to fatty liver. Next slide. Next slide. Next slide. Next slide. I think we'll skip these 4 slides because they are just evidence and we already have made a statement. Next slide. Next. Evidence reduction. Next slide. What is the conclusion? Saroglitazole leads to significant improvement in transaminases and liver function with NASH. The world's first NASH drug approved, a big feather in Zydus Cadilla's saroglitazole, and it's a landmark year for saroglitazole because approved in 2 landmark indications from DCGI. One is a type 2 diabetes and other is a NASH, which is also equally problematic patient. And we see a lot of NASH, and actually they complicate the insulin resistance. So this is one drug. I've shown you the mechanism of action of saroglitazole. It has a unique action at acting at a PPAR gamma as well as alpha, and remnant, most important, hyperremanentemia, which is a major problem in Indians. The remnant particles are also cleared very easily, and people after putting on lipaglyn for 6 to 8 weeks bring down their atherogenic lipid profile favorably. People treated for more than 2 years have shrunk their liver from 3-finger palpable to 0. This is a clinical relevant studies that we have done in our own clinic, and that is the benefit. It's a well-tolerated drug. There's no problem, and it's a very good accompaniment to other anti-diabetic agents, and I recommend it very strongly. Next slide, please. Next slide. So summary, Indian insulin resistance is pathological hallmark for type 2 diabetes. The major severe risk factors like ADD and liver disease like NASH. High triglyceride, low HDL are a common observed patterns. High triglyceride is responsible for increased risk of residual CVD. You should also know that standalone triglyceride, hypertriglyceridemia, which runs in families. There are atherogenic lipid profile, but some people have triglycerides of 1200, 1500. It runs in family, and they are prone to develop pancreatitis. Remember, elevated triglyceride can also cause pancreatitis. And this drug, in fact, I use double dose in such patients, and we have brought down their lipids, particularly the standalone triglycerides come down into almost less than 140, 150. Next slide. So even in fibrotic liver, when the transaminases are elevated, AGOT, AGPT, alkaline phosphatase are borderline elevated, not grossly elevated, they are in still double digits. They come down after 6 to 8 weeks of treatment with a saroglitazole. So my friends, this is an excellent molecule where I pump heavily on it because I use it very often. Because I have those kind of patients, unfortunately, type 2 diabetes with hepatomegaly, and I find it quite good. Now it's wide open. You can ask me any questions.
Thank you, Boroskar sir, for a nice and the nice presentation and sharing your clinical thoughts on particularly saroglitazole, the only dual PPR alpha gamma agonist available in, I think, world. This is the only available molecule available in world, and importantly, it is basically Indian molecule. So it is developed in India. So it is the only molecule, I think, and anti-diabetic. Many in chronic segment, this is the only molecule which has been developed and developed in India. So, Dr. Raghu sir.
Yeah. Sir, I have a question for you, sir. Dr. Anil Boroskar, sir. Brilliant presentation. Sir, any signal for GI hemorrhages with this glitazars, or any dangerous side effects with glitazars, sir?
I have not noticed any, but routinely all my patients who are on glitazars, every initially every 2 weeks, we do their stool for occult blood.
Right, sir.
And those people who complain of retrosternal burning or epigastric discomfort on 3 consecutive occasions, what I do, I stop this drug for 3 weeks and then see if there is any relief. If there is no relief, then I push them to endoscopy.
Right.
And luckily, till today, I have got only 1 or 2% who had some hemorrhagic changes in the gastroesophageal junction. But it was definitely not related because simultaneously, these people are also taking aspirin, dabigatran. So we don't know that alone this drug can cause any GI bleed. But GI bleed is a contraindication. Active GI bleed will not give this drug. Drop in hematocrit, drop in stool, occult blood positive on 3 occasions, then I would tend to stop this.
Yes, sir. Thank you, sir. Thank you. Thank you, sir. So we have few questions here in the chat box. Up to what level of EGFR voglibose can be used safely? Question probably to Dr.
Raju, as usual, I must have disappeared because he must be busy in some other webinar. I can answer on his behalf.
Yes, sir.
EGFR more than 50, we will give this drug very safely. Between 25 and 50, I would be reluctant using any drug other than voglibose. This is my take on it. I deal with such patients very often. Very rarely my patients have EGFR more than 80, very rarely. Most of them are below 80, but with below 80, between 50 and 80, I am not worried. Only thing, I reduce valsartan, I reduce ACE inhibitors, but voglibose I don't reduce.
So voglibose and acarbose also can be safely used if the EGFR up to the 30, I think. Up to 30 we can safely use, sir, the message.
Yeah, actually, acarbose has been a time-tested drug, quite a lot.
Yes, sir.
All acarbose.
Yes.
Bayer had pushed it so much that practically every prescription I could see that it contained, glucobay. But now what happened, over a period of time, people have preferred voglibose than to acarbose. And we have hardly any complaints about people worsening their renal functions after use of voglibose.
Right, right. I don't think there are any more.
Sir, can we combine this pioglitazone, or we should stop pioglitazone when we give the saroglitazole?
No, pioglitazone has a unique action. Pioglitazone is also unnecessarily incriminated after the debacle of rosiglitazone. I don't think it's the right thing to do because pioglitazone in Indian subjects is a truly drug which acts on insulin resistance other than metformin. And pioglitazone, luckily, we can give it in 7.5 milligram dose also. It is the 30 milligram dose which may cause water retention, which may cause some kind of but there is no evidence showing that 30 milligrams of pioglitazone has caused coronary artery disease like in rosiglitazone. So in some patients where metformin alone is not effective on insulin resistance, I do give 7.5 milligram of pioglitazone with the idea that he might retain water. And here what comes to help me is the SGLT2 inhibitor. A combination of SGLT2 inhibitor, 7.5 milligram of pioglitazone and metformin works in almost 60 to 70% of patients. Even using insulin also, I found this drug effective. But remember, if a patient is exclusively using insulin, giving him only pioglitazone can cause more water retention. Patients treated with insulin, you should use pioglitazone with caution.
Can we use combination of saroglitazone and pioglitazone, sir?
Combination fixed dose?
No, sir. Separate.
Yeah, why not?
Because Because it will also help for DPP4 inhibition.
Yeah, sure. You see, DPP4 inhibitor is an independent action.
So,
And
sorry, PPR gamma action. So it's
PPAR
has
gamma
both
action
action. Sorry.
is not likely to enhance. Remember that. It will not have a synergism between the PPAR gamma action. Both act independently. Unfortunately, I didn't have a chance to use it saraglitazar with any of these, PPAR gamma. The drugs like pioglitazone, if the patient is already on for a long time, the issue of NASH is also taken good care. You see, I've seen many patients who are treated with this drug, they have comparatively less hepatomegaly. Now, you must also remember clinically, because we are all basically clinicians. हम लोग सब उंगली के ऊपर ध्यान देते हैं. We are all, our fingers, we touch the right side of the abdomen and we feel one finger, two finger. I have developed an expertise talking too much. I mean, you will not like it, but I can do that. When I touch the liver, I can tell you this liver is because of chronic passive congestion. This liver is because of early cirrhotic fatty liver, or this liver is due to fatty liver. उंगली लगा के ये हाथ तैयार हो गया अभी. Many times I don't do sonography also. So the feel of the liver is different. Only thing you should know how to feel it without hurting the patient. And particularly when I'm taking a clinic, the dictum is I allow only 1 or 2 students to come and palpate the liver. Not more than 3 people should palpate the liver on the same day. Remember that you can hurt that liver if it is through the chronic passive congestion. So keep these certain principles in mind.
I think there are no more questions. So over to the host for winding up.
Thank you very much for listening to me.
Thank you, sir.
And thank you, Bansi Bhai, for giving me an opportunity in this great feast of academics and galaxy of Indian diabetologists. Thank you very much.
Thank you, sir. Thank you.
Thank you, sir.
Thank you very much, everyone. On the behalf of the organizing team, I myself, though I'm a speaker in the next session, I would like to thank all our previous speakers and esteemed chairpersons and our reporters for conducting this session wonderfully. We had a great discussion at the end also, and I heartily thankful to all of our speakers and chairpersons again for the wonderful session. And we are on time right now, and we'll be proceeding for this session. I'm a part of the this next symposium, so I would like to invite our rapporteur, Dr. Nihar Gedia from Surendranagar, and I would like to invite him for starting the session, introducing our esteemed chairpersons also, and the proceedings of the
Thank you so much, sir, for your kind
session.
words.
Over to you, Dr. Nihar.
Yes, sir. Thank you, sir. Hello, everyone. Very good evening to all of you. Last session was very interesting and acknowledgement. So we shall move to our new session. In this session, we took those topics are discussed very lastly, like diabetes with gut microbiota, diabetes and nutrition, sleep, and what is important of oral health and important of exercise. So I would like to invite our chairperson of this session, Dr. Aswin Dabhi sir, he is from Ahmedabad, and Dr. Chintan Vyas sir, he is from Anand. Welcome, chairperson, and I would like to hand over this session to you, chairperson Dr. Aswin Dabhi sir and Dr. Chintan Vyas sir. Welcome, sir.
Thank you so much, entire DiaCare organizing team. Welcome, friends, and my colleague, Dr. Chintan. And all of you know that Bansi always give me, and I and Bansi just like to walk a road which is less traveled. So what is being discussed about the therapeutics management in the diabetes? We have been loaded with number of intervention targeting some 8, 7, 15 pathways. So the good intelligent topic about this session is the less discussed topics in field of diabetes. So unfortunately, most of us in the COVID pandemics in the countries grappled with, all of us have become literally physically inactive. So that fasting feasting phases had learned into continuous feasting phase. So we start off with our first speaker. Our first speaker is Dr. Supratik Bhattacharya, and he's going to speak on the diabetes and the gut microbiota. He's a director of SCAN Diabetes and Endocrine Center. He has been awarded for a best diabetic awareness activities, and also he was a part of multiple phase 3, phase 4 studies, including the global DMARD studies. And he has been a speaker at various national and international conferences. And all of we learned that the origin of disease, whether it is a cardiac disease or a metabolic disease, now we believe that gut is the culprit organ. So we have a wonderful speaker, Dr. Supratik, to elaborate on such a nice topic in such an august audience. Over to you, Dr. Supratik.
Thank you, Chairperson sir, for your kind words of introduction. Thank you, Dr. Bansi Sabu and the entire team DiaCareCon 2020 for this invitation. It's a pleasure listening to all my previous speakers, and I'll just take 1 minute to share my screen. And hopefully it's visible to you now. And I'll just put it on full screen mode. So,
Yeah, it's visible.
Great. Thank you so much once again for this kind invitation. And this is my topic for today. I'm going to talk about the diabetes and the gut microbiota. And so we all know about this very interesting story. So the brain, the heart, and the liver were having a conversation between themselves as to who was the most important. And then the gut was there as well. So the gut kind of said, well, why not me? And then the brain, the heart, and the liver started laughing at the gut. So this made the gut very, very annoyed. And he decided to shut down for some time. And we all know what happened a little later. So after this, I think unanimously, all the organs of the body finally agreed that gut was probably the most important part of the body. And if we go back all the way to Hippocrates, we know that he had actually mentioned that all diseases begins in the gut, and the health is determined by the microbiota in the gut itself. And 70% of our immune system is located in our gut itself. So if you consider the human being, who are composed of about 40 trillion cells, and you look at the gut now, there are about 100 trillion microbial cells, which we call the microbiota, and about 10 million microbial genes, which we call the metagenome. And if you look at the average weight of the microbiota, it's about 1.5 kilos. And they go through evolution, changing from infancy into the adulthood. And if you consider the microbiota, 95% is constituting of Firmicutes, Bacteroidetes, and Actinobacteria. And this is the classic development of microbiota. So if you consider in utero, the GI is completely sterile. And at birth, whether the person is having a C-section or a vaginal delivery, you acquire certain bacteria. For example, in C-section, you'd be acquiring Staphylococcus, Corynebacterium, Propionibacterium, for example. On the other hand, if a person is having vaginal delivery, then you'd acquire Lactobacillus, Prevotella, or Smithia. And then this keeps on evolving. So Enterobacteria, Bifidobacteria, Bacteroids, Bacteroidetes, and Firmicutes, as soon as solid food is introduced into the system, and they kind of help in the carbohydrate utilization, etc. When you come to the adulthood, depending on the pathological condition, for example, if a person is obese, then we see certain changes in this microbiota. For example, in obese individuals, the Bacteroidetes decreases and the Firmicutes increases. Similarly, there are changes for Crohn's allergy, or if a person is having a course of antibiotics, we see that the bacteroids actually go down. So just a short story about the bacteroidetes, because it's one of the very important microbiota, and they're gram-negative, non-spore forming. They could be aerobic or anaerobic and rod-shaped in nature, and they're abundant in the guts as well as the skin. Now, you can see that I have highlighted bacteroidetes in red and bacteroids in green to differentiate between the two. You see that bacteroids are opportunistic pathogens, they can be, and bacteroidetes, on the other hand, are symbiotic in nature. So bacteroids are highly abundant in intestines, and they take part in degradation of the proteins or complex sugar polymers. Bacteroid species are selectively recognized by the immune system, and bacteroidetes, on the other hand, colonize the GI in the infants, as non-digestible oligosaccharides in mother's milk support the growth of bacteroids and bifidobacterium, again, another very important microbiota. So in GI, microbiota or bacteroidetes have got a very broad metabolic potential, and they're regarded as the most stable part of the GI microflora. And there's a reduced abundance of bacteroidetes in obese individuals. They're also sort of involved in the pathophysiology of irritable bowel syndrome, type 1 and type 2 diabetes. And if you consider the bacteroid species, they are sort of found enriched in the metagenomes of the subjects with low gene richness, and were associated with adiposity, insulin resistance, dyslipidemia, etc. Other ones that are very important, we talked about, one was Firmicutes and Lactobacillus. So lactobacilli administered in combination with other probiotics are beneficial in irritable bowel syndrome and a host of other things. Just a quick difference between what is probiotic and a prebiotic. So probiotics are products which are aimed at delivering living, potentially beneficial bacterial cells to the gut ecosystem. On the other hand, prebiotics are indigestible carbohydrates which are delivered in food to large bowel to provide fermentable substrates to the selected bacteria. Now, if you see in health, there's absolute homeostasis, and the density, diversity, and activity of gut bacteria is maintained, whereas in dysbiosis, there could be diseases. Now, there can be external influences in terms of diet, so prebiotics, probiotics, etc., restore the balance. On the other hand, antibiotic usage or illness or lifestyle changes can cause dysbiosis. And also the internal host properties like the age, genetics, stress, etc., also are influential. So there's a lot of association between the microbiota and the diseases like fibromyalgia, IBS, IBD, depression, anxiety, diabetes, rheumatoid arthritis, etc. And there is a very convincing link between diabetes and gut microbiota. And, you know, we commonly ask about the diet, what kind of physical activity, whether the person is a smoker or not, whether the person consumes alcohol, what kind of medications they're on, what is the mode of birth, and you know the relevance why. And all of these, it does have a potential sort of an influence on the gut microbiota itself. So gut microbiome balance controls the long-term health, and gut microbiota and host metabolism. In transition from the infants to adulthood, the gut microbiota changes and interacts with the host metabolism, leading to metabolic and cardiometabolic diseases. So basically, gut microbiota can act at various levels. So whether it's the adipose tissue influencing fat storage, or the skeletal muscles involving in energy metabolism, liver, cardiovascular system like the heart and the blood vessels causing cardiovascular disease, and a host of other organs. I wanted to emphasize that there is a very different kind of microbiota that is seen in the obese individuals and lean individuals. So obese individuals, you can clearly see that the lipopolysaccharide-mediated inflammation is more. The small chain fatty acid lipogenesis is more. Incretin secretion becomes less. Butyrate production, again, something which is beneficial, becomes less. And because of all these changes that you see, there is increase in the insulin resistance. However, in the lean gut microbiota, which is healthy, you see that there is more incretin secretion, less small chain fatty acid lipogenesis, etc., and thus you have more of insulin sensitivity and less of resistance. Now, microbes and host metabolism, and we know that there is a direct link, and I'll be talking to you shortly about this. Now, let's look at the various mechanism of action that are proposed. So lipopolysaccharide, which is sort of you see in the outer membrane of the gram-negative bacteria, they attach to the toll-like receptors that you see in here, and that signals the pro-inflammatory pathways. When it comes to the short-chain fatty acids, the dietary fibers are converted this is converted by the gut microbiota into butyrate, acetate, and propionate. And if you look at the G cell coupled receptors, GPR41 and 43, they sort of mediate whether they act on the inflammatory cells or the immune system, causing less of inflammation, or they act on the L cells and increase the endogenous GLP-1 levels and the PYY levels, causing increased incretin action. So all of these are beneficial for
Dr. Sudhir, sorry to interrupt you. You have last 1 minute to end up the session.
Sorry, I thought I have 15 minutes.
Yeah, it's already 4:05. Okay, continue.
Okay, thank you. Okay, so quickly going into the gut microbiota and possible molecular mechanisms which are related to the cardiovascular system. And I can sort of give you in a nutshell that it has got the potential to change the whether it's the increased atherogenesis or increasing the cardiovascular risks or the heart failure potentiation. All these can be related. And we have already talked about the various mechanisms, how it predisposes. So gut connection to diabetes, the concept of eubiosis and dysbiosis was not just a theory now, and it's already established. And we know that the obesity mediated the microbiota you see in the obese individuals are very, very different from that in the lean individuals. And I'll try and show you some of the studies which will go and tell you what is the relationship. So gut microbiota and role in diabetes mellitus, we had said that the Western diet, the antibiotics, etc., causes dysbiosis and causes decrease in the short-chain fatty acid production, decrease in the GLP-1 secretion, and also increased inflammation. And we had already shown you the mechanism of decreased incretin secretion and PYY. So the mechanisms that are actually mediated are increased in obesity, postprandial spike, etc. I'll skip all of these and come to a few of the randomized control trials, as well as the meta-analysis. 15, if you consider 15 randomized control trial and a meta-analysis done by Wontao with around 902 participants, they concluded that the probiotic treatment may reduce the HbA1c fasting and insulin resistance in type 2 diabetic patients. This is again by Akbari et al. A meta-analysis of 13 randomized control trials shows that probiotics appear to have a beneficial role in the management of type 2 diabetes. Again, 32 clinical trials meta-analysis conclusively proved that probiotics could be a supplementary therapeutic approach in type 2 diabetes and can improve dyslipidemia and promote better metabolic action. So the whole idea is to combine. So you take multi-species probiotic supplementation, and in doing so, you see this double-blinded placebo-controlled study, which conclusively shows that multi-species probiotic supplementation prevented rise in the fasting, as well as decreases the serum HSCRP levels, which could be cardioprotective. And the final meta-analysis that I wanted to show you was of 16 studies. 12 out of the 16 studies had actually shown that IBS, diarrhea, atopic disease, immune function, all of them got better with the use of the probiotic itself. So yes, there is a convincing link between diabetes and dysbiosis. And the day is not very far when the doctors are going to do a gut profiling and give food plans to the patients and individualize the care. So with this, thank you so much for your kind and patient hearing. And I hand the mic back to the chairperson, please.
Thank you so much, Dr. Supratik, for a wonderful elaboration on the origin of disease. What we used to believe that this diabetes has arisen from a pancreatic beta cells, but now we have a number of theories which can lead us to the origin of disease is nothing but a gut. So whatever we eat in our day-to-day life, not only it alters the gut microbiota, but there is a cross-link between the microbiome genome and the human genome, and that crosstalk leads to an adverse cascade in form of metabolic endotoxemia. And it was wonderful elaboration, Dr. Suprati, about the diabetes and dysbiosis. With that, I invite Dr. Chintan to introduce our next speaker.
Exact.
Anyways, yeah.
Dr. Supratik ji, it was very nice and elaborative presentation, and we move ahead to the next topic by Dr. Arvind J, and the topic is uh, regarding diabetes specific nutritional formula, when and how much. Very interesting topic. And Dr. Arvind J is also from Bangalore and have vast experience being worked in various hospitals in UK in field of diabetes and endocrinology, and one of the few who have got MRCP London with triple FRCP. That is a unique degree he has possessed, and without much ado, we can go ahead with his topic, Dr. Arvind J. Over to you, Dr. Arvind J.
Thanks, Dr. Chintan, for the nice words. Thanks, Dr. Banshi and his team for making me a part of this event. Give me 1 minute's time so that I'll share my slides. Are you able to see my slides?
No, no, Dr. Arvind. So this likes a Formula One race. All of us, we know that the nutrition plays an important role, and lots of us are having a very hectic lifestyle. Many of our patients, they do not have time to prepare their meals. And therefore, there is an evidence that obesity and overweight has increased in prevalence across the country. So number of ways we are targeting to reduce the obesity and the overweight, and one of them is in form of using the disease-specific formula. And all of you know that these disease-specific formulas which come with special nutrients, which are apart from nutritional benefits, they have lots of other functional benefits. And I think, Dr. Arvind, we can see your screen.
Yeah. I'll put into the PowerPoint mode.
Correct. Thank you.
I hope my PowerPoint, are you able to see my slides now?
Yeah, please go ahead.
So good afternoon, everybody. My today's talk is on diabetes and specific nutritional formula, when and how much. It's very difficult topic because to finish in 15 minutes, it's a tough job, but I'm trying to make it justifiable. So first of all, greetings from Bangalore. I hope all of you are doing well in this tough Corona times. Kindly take care of yourself, your family, as well as your patient accordingly. So if you see diabetes and obesity, obesity is known to be directly linked to type 2 diabetes, and not surprisingly, the growing prevalence of diabetes parallels the increased prevalence of obesity. Obesity and insulin sensitivity, the modest weight reduction of about 7% over a 6 months period through calorie reduction and increased physical activity improves the insulin sensitivity. On the right hand side of the chart, you can see the relationship between the body mass index and the risk of type 2 diabetes. So as the body mass index increases, the risk for type 2 diabetes also increases. You can see it's more so in women as well as in men. So factors associated with poor glucose control in hospitalized patients. You can see one of the reasons is uncontrolled or undiagnosed diabetes, medications that alter glucose level, critical illness, nutrition support, surgery or traumatic injury. 69% of the Indian diabetes have uncontrolled diabetes in spite of medication. The challenge is hidden in our plates. That is the most important thing for every diabetes. There is nothing like diabetes diet. It is always an individualized diet. Because in Bangalore, for example, I'm telling, we come across so many different population where we have to advise the diet according to the patient needs. We can't just take say that you don't eat this, don't eat that. It has to be an individualized diet. So high refined carbohydrate intake is the universal common problem in irrespective of the states, like whether it may be north, east, or south and west. So low fiber diet, low protein diet. So Indian diet scenario, if you take several studies, show that Indian diet mostly comprise of high carbohydrate, low protein and low fat diet. Studies shows a comparison of macronutrients by region in India revealed similar patterns of dietary consumption that is relatively high carbohydrate and low fat and protein. Another study done on an Asian, Indian and Chinese showed that as proportion of total energy intake, Asian Indians consumed less protein and more saturated fat than Chinese. So coming to the topic proper today, that is DSNF, that is diabetic specific nutritional formula. The nutrition therapy and physical activity are first line therapies for patients with diabetes. DSNF may be used as a component of MNT, that is medical nutritional therapy, to improve glycemic control, reduce body weight. The DSNF are included in the ADA guidelines for diabetes management. That is very important. ADA as well as included in the criteria in the management of diabetes. So what is DSNF? It's a diabetic specific high protein formula containing MUFA, that is slowly absorbed carbohydrates, and omega-3 PUFA enriched with EPA, DHA, and fiber gives rise to better glycemic homeostasis than a standard high protein formula and may also reduce the risk of acquired infection in ICU patients. So managing glycemic response. In Elia et al. Study, conducted a systemic review and meta-analysis on the impact of using DSF for nutrition as oral nutritional supplements or as an enteral tubic feedings for inpatients or outpatients with diabetes. Compared with standard formulas, DSF significantly reduced the post-meal rise in the blood glucose, including lower peak glucose concentration and lower glucose area under the curve. The studies within the analysis found reduced requirements for insulin and fewer complications with DSF compared with the standard nutritional formula. Elia et al. Concluded that short and long-term use of DSF as oral supplements and tube feeds are associated with improved glycemic control compared with standard formulas. Managing glycemic response. In another study, a systemic review by Ojo and Broke provided further evidence that DSF are effective for managing glycemic status of hospitalized patients with diabetes on enteral nutritional tube feeding by improving postprandial glucose levels, HbA1c levels, and insulin responses. In outpatients with type 2 diabetes, Human et al. Showed that DSF improved glucose stabilization and management compared with a standard formula. D. Lewis et al. Showed reduced glycemic and insulinic responses after administering DSF when compared to a standard formula. In these studies, DSF were found to safely and effectively lower high blood glucose level without increasing risk of hypoglycemia. So clinical evidence supports the use of DSF to help improve glucose level, reduce hypoglycemia,
Dr. Arvind, there is some audio problem.
reduce insulin
Doctor,
requirements,
Dr. Arvind, can you
reduce
solve the
length
audio?
of stay. So ADA recommends MRT, that is medical replacement therapy. Yeah. Okay. Now it is okay.
Yeah, now it's okay. Go ahead.
ADA recommends MRT. So to
I think there is some internal
delay or
glitch
prevent
with
the
you, doctor.
complication.
Can you share the screen
Now it's
again,
okay.
doctor? We just share the screen, sir.
Now are you able to see?
No, not yet.
Okay, 1 second. Sorry.
Not an issue. Or else you go ahead with yeah, we can, I think screen is, yeah, perfect.
Sir, you can switch off your video, sir. You can switch off your video so that the internet connectivity issue will be less troublesome. You can switch off your video.
Okay. Yeah.
In video.
You can just expand the screen and
yeah.
Yeah, you have, doctor, now 4 minutes to complete the presentation.
Yeah, I'm almost done. So are you able to see my screen?
Yeah.
So ADA recommends MRT. So type of replacement in dietary content, that is liquid meal, solid meal, and breakfast replacement. There's a partial meal replacement is there. That is the plan where one or more meals are replaced by commercially available vitamins and mineral fortified calorie reduced products, and at least one daily meal consisting of regular food, a meal that can be taken along with breakfast, lunch, and or dinner depending on the individual calorie intake. Recommendation as per various organizations, you can see these. The commonest thing is carbohydrate is around 50 to 60%, fiber is 40 grams per day, protein is 12 to 20%, and fat is less than 21%. The goals of MRT is normal or near normal as possible glucose, lipid, and blood pressure, prevent or slow down the rate of development of chronic complication, address individual nutrition needs, maintain pleasure of eating by only limited food choice when indicated by scientific evidence. So MRT decreases A1C by 1 to 2% and reduce LDL by 15 to 25%.
Again, Dr. Arvind, there are lots of audio problems. So you,
dietary plan is carbohydrate 40%, fat 7%. So meal high in fiber content. So structured dietary plan for weight reduction. So 40% of intake with a total daily intake of no less than 139 grams per deciliter. Compromise up to 20 to 30% of daily calorie intake. Remaining 30% should come from fat. Trans fat should be eliminated. Saturated fat should be reduced to 10% or even 7%. Meal plans should also focus on increased fresh fruits and vegetables and healthy carbohydrate consumption, especially foods high in fiber and with low glycemic index. High protein and high dietary fiber helps in managing diabetes. So protein shakes and diabetes, everyone needs proteins, which enables every cell to function. They help to maintain, rebuild, and repair muscles. So protein is a building block for the skin, nails, bones, and blades, and it makes up the hormones, enzymes, and antibodies. So our bodies create some proteins, but others must come from the diet. Protein food, such as the whey, meat, and tofu, enable the body to create the protein it needs. Apart from playing a key role in bodily process, protein may also have the other benefits for people with diabetes. Protein plays an important role in the management of diabetes. If you see this, high protein intake does not necessarily lead to weight loss. In some cases, higher protein intake may influence diabetes risk through weight loss. For individuals with type 2 diabetes, studies have demonstrated that moderate weight loss is associated with decreased insulin resistance, improved measures of glycemia and lipemia, and reduced blood pressure. So if we see the protein supplement in CKD, you can see around 0.8 to 8 grams per kg is recommended for stage 1 and stage 2. Stage 3 and stage 4, it is 0.6 to 0.8 grams per kg. In one of the clinical trial, it shows partial use of formula diet was much more effective in reducing body weight and also in improving coronary risk factors than conventional diet, in part due to reduced body weight through decreased energy diet intake and due to dietary composition of the formula diet. So greater weight reduction, reduction in the HbA1c, reduction in the systolic blood pressure, and increase in the HDL, reduction in the dose of medicine. So it really works. So liquid replacement and glycemic control in obese type 2 diabetes. They have looked into three aspects, three types of food were given to the patient. What it says is liquid medical replacements are a safe and effective weight loss tool for improvements in body weight, glucose, insulin, HbA1c, and lipid levels. So in another study, it's a randomized control study where it says a significantly greater weight loss in subjects receiving the meal replacement plan compared to the regular diet. Depending on the analysis and follow-up duration, the meal replacement group lost 7 to 8% body weight and the regular group lost 3 to 7% body weight. So in another one of the studies, Cochrane Library, taken from the Cochrane Library, the low glycemic index or the low glycemic load diets for diabetes, what does this says is a low GI diet can improve hypoglycemic intake. From all the above data obtained in the various clinical trials, very clinically suggested that management of meal therapy proved to be beneficial in weight management in type 2 diabetes candidates with improved level of glucose. So benefits of MRT, effective structured plan, behavior compliance improved, increases the nutritional knowledge, more regular meals, less snacks, a well-defined alternative to calorie-dense foods, portion control choice. So ladies and gentlemen, to conclude my talk, higher protein intake may reduce the risk of developing diabetes and improve metabolic control only when weight loss is achieved. 2020 ADA standards of care recommends including using an individual approach in diabetes medical nutrition therapy with regards to protein intake and dietary macronutrient composition. Factors to consider in tailoring advice include cardiometabolic risk status and renal function. The ADA recommends 0.8 to 1 gram per kg of proteins per day in earlier stages of CKD and zero point 0.8 grams per kg per day in the later stages of CKD. These recommendations for protein intake are like those of the National Kidney Foundation. So medical nutritional therapy, diabetes nutritional supplements is a big topic and it has to be individualized, and you as a whole you have to consider whether it's a patient with a diabetes and associated conditions like hypertension, IHD, or any other medical problems the patient has got, you have to individually titrate and educate the patients accordingly for the better outcome of the patient. Thank you for your patience. Sorry for the disturbances.
So thank you so much, Dr. Arvinda, for a wonderful presentation on nutritional therapies in a patients with metabolic syndrome. I have a one question that since these meal replacers are very expensive, they are costing almost 150 bucks for one meal serving. So with an Indian economic situation, do you recommend we can customize those kind of meal replacer in some other way?
Yes, Dr. Ashwin, is a very apt question because as rightly pointed out to you, the meat replacement therapy in India, the whatever the commercial available brands are very, very expensive. What I personally feel always is, for example, Gujarati people eat something, Bangalore people eat something, Kolkata people eat something like that. We have to modify so that the carbohydrate is around 50 to 60%, as well as the proteins. So proteins content has to be increased. That is the problem with the Indians. We Indians don't consume the proteins very much. So in our diet, like it may be a dal or anything like that, we can increase the diet proteins accordingly so that we can balance the medical nutritional therapy in our own way. In my center, I do the same thing. So if the patient is affordable, we ask them to take the nutritional supplement. Otherwise, we create the own diet rich in protein.
So thank you so much, Dr. Arvinda. Now we move on to the next session that is about the diabetes and oral health. And we people be scratching our head that what is oral health to do with diabetes? But many simple infections like gingivitis, they also leads to some kind of cytokines which are released from those necrotic debris, and that can also alter the insulin resistance. So today we have a wonderful speaker with us, Dr. Jimit Vadgama. He is a good friend of mine and he's a consultant endocrine diabetes and metabolic physician in Surat. He is the executive editor of RSSDI textbook of diabetes 4th edition. He is also a member of American Association of Clinical Endocrinologists, and he has a multiple research publication, more than 10 chapters in books. So we will now learn about what we simply means like keeping a good oral hygiene also improves your metabolic profile. So over to you, Dr. Jimmy.
Thank you so much, Dr. Aswin sir. It was great meeting you after a long time, though virtually. We hope we will meet next time physically when
Yeah,
Dr. Ban.
my pleasure. Our pleasure too. Thank you so much.
So we are in a symposium where we are discussing some of the less discussed topics. And oral health is also one of the things that we commonly miss out in our discussion. So we'll start with some, I would say, some rare things that we don't see in OPD, or I would better say we neglect them. Oral health is one of the most neglected subject in our clinical OPD. So oral health is also very important, as Dr. Ashwin sir has clearly said. We need to know about that and how it affects sometimes insulin resistance and our health also. So we all know diabetes is a syndrome of carbohydrate, fat, protein metabolism, and nowhere there comes the issue of oral health or dentist or something like that. So it is important. But we all know diabetes treatment. No, a patient once become diabetic, it needs lifelong treatment and lifestyle changes. You cannot stop it anywhere in your life. Similarly, dental health also requires lifelong intervention to either prevent the derangement uh, in quality of life also, and ultimately the living also of an individual. So both are require lifelong intervention. So we all know traditionally complications of diabetes. These are the old classification. We know macro and macrovascular are the major classification, but traditionally in the old way, 5 classical complications of diabetes have been described: retino, neuro, nephro, cardiovascular complication as a whole, and delay wound healing. These are the 5 common classical complications. And if you see the older literature, periodontal diseases have been recognized as 6th complication of diabetes. And diabetes is a common disorder with concomitant oral manifestations that impacts the dental care. And there is a concern about the ability of the oral manifestation to profoundly affect the metabolic control of the diabetes. So this is very, very important. We know oral complications of diabetes varies widely, being either subtle or many of the times it get unnoticed, either by the patients also, and I would say by majority of our practitioners also. They go unnoticed, and rarely it can be devastating for the patients also. And this may include, but not limited to, candidiasis, dental caries, tooth loss, gingivitis, lichen planus, neurosensory disturbances, periodontitis, salivary dysfunction, xerostomia, and taste impairment also. So broadly, you can divide them into either dental caries, xerostomia, candidiasis, oral mucosal diseases, periodontal diseases, or even burning mouth syndrome. So these are classically defined oral complications of diabetes. Let's start with periodontal diseases. No, it is shortly called PD or perio disease also by many of the dentists. It is a chronic bacterial infection that affects both the gingiva and the bone that supports the teeth, and it is caused by mostly anaerobic gram-negative microorganisms most of the time, and that are present in the bacteria plaque that adheres to the teeth. So you can see this is a photo from a 19-year-old woman with uncontrolled diabetes, and she is having gingivitis. So this is very, very important. And chronic periodontal disease results in progressive destruction of supporting tissue to the teeth, as well as it can lead to pocket formation also, recession, or both, and which may lead to tooth loss because of extensive destruction of alveolar wall. So this is very, very important. It has been an important cause of tooth loss also. Now, what happens with the periodontal disease? How it progresses? So you can see on the left side, it is a healthy tooth and healthy gum tissue. You can see here it is a clearly normal. And what happens in gingivitis? So gingivitis, in which the inflammation is confined to the gingiva only, and it is reversible with good oral hygiene. So this is a stage where you can reverse the oral pathophysiology. Or this you can easily reverse with good oral hygiene also, and I would say a good glycemic control also, where there is gum inflammation and bleeding initially limited to gingiva only, and there is some amount of plaque buildup is there. And if it is not halted, it can lead to periodontitis, in which inflammation extends and results into tissue destruction, and even the alveolar bone resorption is also seen. You can see here in the stage 3, the plaque hardens and into calculus, pockets from around the teeth, and bone loss begins. Here you can see beginning of the bone loss. And in advanced stages, there is significant bone loss and pockets formation is also there. You can see here it is a deepening of the pocket surrounding the teeth. It makes the tooth loose more likely, and they are more likely to fall also. So this is a similar thing actually how it looks. Healthy gums, initial stage of gingivitis you can see here. Then comes the periodontitis here, and you can see later on there is a tunnel formation and there is advanced periodontitis, and ultimately the tooth is lost. So it is well documented that periodontal disease is considered to be one of the main reasons for tooth loss among the patients with diabetes. So this is very, very important. You can see here abscess formation is also going to be there, and if it is not controlled, it can lead to sometimes devastating consequences also. And here also you can see there is a bone loss, and you can see alveolar bone is on the other side. You can say there is a kind of osteoporosis due to chronic infection, and can lead to bone loss and ultimately tooth loss. What are the common risk factors for periodontal disease? So non-genetic, we know smoking is one of the major risk factors. We will see. Also, diabetes is considered to be a major risk factor for perio disease, and conditions associated with compromised immune status like HIV, similarly diabetes also, nutritional defects, osteoporosis, and many of the medications like some calcium channel blockers, phenytoins, and cyclosporine. And sometimes local factors also, they affect the perio disease. And many of the genetic factors which are yet poorly defined. We have seen many patients where this kind of diseases they run in the family also. And among the smokers and other things, you can see physical inactivity also becomes an important risk factor. How it is related to diabetes? As we have said, it is considered to be one of the 6 complications of diabetes. Is more likely to occur in diabetes patients also. Patients who are poorly controlled, they are more likely to develop periodontal disease than well-controlled diabetes. So they have seen studies also that they are more in the patients with uncontrolled type 2 diabetes. And poorly controlled diabetes had threefold increased risk of having these dental complications. Very, very important thing is the duration of diabetes is also important factor to evaluate the risk for this period disease. Now, very, very important. You can see the graphics here, how it affects the whole system. Dr. Ashwin sir has clearly said that you need to understand the reverse mechanism or the bilateral mechanism also. Perio disease is also causes bad breath. We know it causes recession in the teeth and pockets formation, can lead to bad aesthetics also. Then this can lead to hypersensitivity of the teeth also. Patients are many of the times unable to take proper food also and nutrition. It can cause root caries and pain. This is also very, very important. Mobility of the tooth. The tooth becomes mobile. It, it moves in the cavity and it is the reason for tooth loss. So mobility and root caries are the main reason for tooth loss. Patient may have chewing difficulties also, while pain and tooth loss can lead to diet difficulties. So this becomes now very, very important. All our patients, we request them to increase the fiber content and which needs to be chewed. The majority of a simple example of green leafy vegetables and salads, they need to be chewed, and without the denture, proper tooth, they are unable to do it. So diet is affected and patients are usually going for liquids and replacements and juices and all kind of high calorie foods and high carbohydrate diet with higher GI index. So they lead to systemic disease and ultimately worsening of the diabetes control also. Very, very important thing is the systemic inflammation. We'll see that also. Then there are many studies and meta-analyses have shown that diabetes have twofold higher risk of developing perio disease compared to without diabetes. There are several mechanisms have been proposed. That is alteration in the host responses. We know it is an immunocompromised state. Collagen metabolism disturbances have also been found and reduced vascularity. This has been also been proposed as one of the mechanism why these dental diseases are more common in diabetes. So there is a two-way association. In addition, severe periodontitis may increase the risk of poor glycemic control. We know it induces the bacteremia. The bacteria they directly go into bloodstream and it leads to elevation in this serum pro-inflammatory cytokines. So these cytokines can lead to increase in the hyperlipidemia and free fatty acids and ultimately causing insulin resistance like syndrome, and which can lead to stress out of the beta cells and destruction of the beta cells. So as Dr. Ashwin sir has said, there can be a two-way association also. And in this bacteremia resulting from periodontitis can lead to insulin resistance syndrome also. Treating chronic periodontal infection is essential for managing diabetes also. Now, simple dental caries, we know it is very, very common. There are so many risk factors, but dental caries are also common in chronic conditions and they can cause pain and disability across all age groups. And if they are left untreated, they can lead to pain, infection, tooth loss, and even eventually edentulism. The presence of these oral complications can hinder quality of life. So this is very, very important. Our patients of type diabetes, they already suffering from multiple chronic diseases or non-communicable diseases, but the addition of this another manifestation, they hinder their quality of life. Nutrition also, as we have discussed, and potentially glycemic control. The patients with diabetes are susceptible to other oral conditions such as this periodontal and salivary disturbances. This could increase the risk of developing new and recurrent dental caries. And there are multiple reviews also they have said that there is no clear association between diabetes and dental caries, but several studies have reported greater history of caries in patients with diabetes. And decreased salivary secretion, increase in the carbohydrate or actual glucose level in the parotid gland secretion, and growth of oral yeast also in diabetes patient, increased count of mutant streptococci and lactobacilli as some of the factors they can be implemented for increase in the dental caries in diabetes patient. Very, very important thing we need to understand the mucosal diseases also. Diabetes is also associated with development of certain oral soft tissue lesions. Although their association is not consistently reported, but there are numerous reports available. And they have seen that greater prevalence of fissured tongue also irritation, fibroma, traumatic ulcer, lichen planus, recurrent aphthous stomatitis, as well as fungal oral infections such as candidiasis or thrush. And this association may be due to chronic immunosuppression or delayed healing and or salivary hypofunction. As you can see here, this is the oral reticular lichen planus, which are mostly missed by our diabetologists or physicians, but they are picked by the ENT surgeons. Another very, very important thing, whenever there is immunosuppression, whenever our patients they receive even glucocorticoids, and whenever they are taking inhalers also with glucocorticoids, they are more prone for oral candidiasis or thrush. People who are diabetes who frequently take antibiotics also to fight various infections, they are even more prone for developing of fungal infections. The fungus thrives on high glucose level in the saliva of the people with uncontrolled diabetes. So this is very, very important. And many of the times wearing dentures also can also lead to fungal infections. Most important thing here remains the good glycemic control. Even it can lead to a pseudomembranous oral candidiasis. Another thing I want to highlight that people with diabetes who smoke also, they are even at higher risk up to 20 times more likely to develop thrush and periodontal diseases. So this is also very, very important. Smoking also seems to impair blood flow to gums. As we know, it also increases risk of other macrovascular complications. The blood flow to the gums is also compromised due to smoking, which might affect the wound healing in the tissue area. Another complication that is dry mouth, xerostomia, people with diabetes face a higher risk. Why? Because uncontrolled diabetes can decrease the saliva flow and it results in dry mouth. So dry mouth can further lead to soreness also, ulcers also many of the times, even infections and tooth decay also. So they can lead to tooth decay. You can see here a patient with xerostomia and with dental caries. They increase the risk of dental caries also. So it is always important to know salivary dysfunction in diabetes. So it is salivary function is essential for maintenance of oral and systemic health. It is important for digestion also, mastication also, taste also, speech also, deglutition also, and even preservation and protection of mineralized and mucosal tissue in oral cavity. And xerostomia is a subjective sensation of oral dryness. So a systemic approach should be employed to determine the etiology, with distinction made between subjective complaints alone or those with some measurable amount of salivary gland dysfunction. And these are the advanced cases which are not usually available in routine laboratory care. Xerostomach complaints may be due to either thirst, a common manifestation of diabetes also, uncontrolled diabetes with osmotic symptoms, oral sensory dysfunctions due to diabetes, dehydration also, and decreased salivary flow. So dryness, many of the times, which our many of the patients in OPD they complain, the dryness is there. They increase the water intake, then they go for urination, and sometimes the whole night the vicious cycle starts. Also, we know.
You have last minute to conclude the talk.
Sure, sure, sir. Sure, sir. Altered taste sensations, and they they are usually given strict diet advices. So they are unable to eat properly, and they have altered taste also. The quality of life is determined. So there are practical tips for reducing xerostomia. You should avoid hydration, sleeping on sideways, and slowing the fan speed or moving away from fan. You can humidify the settings in your air conditions also. You look for other causes that can cause dryness of mouth. You should investigate and treat obstructive sleep apnea. That can be a cause of opening of mouth and dryness, and look for other causes of xerostomia. So last thing is the neurosensory disturbances. These are glossodynia or stomatopyrosis. These are burning sensation in the tooth. They can last for 4 to 6 months, and they are associated with normal findings in oral cavity and tooth, but they can be commonly seen in diabetes. So there are, I may skip it. One of the important thing is the dental treatment consideration. Antibiotics, the diabetic patient will require more chances of requiring antibiotics because of the infection, and they more likely will require supplemental antibiotic therapy also. Very, very important thing, you should go either by your experience that you can give empirical therapy, but for all diabetic patients, cultures are always important before starting an empirical treatment. And we all know adjustment of insulin and oral hypoglycemics are required because patient either might not be able to take oral intake and they might go into hypoglycemia, or whenever there is an infection or caries or sepsis, insulin may be needed for aggressive and rapid glycemic control. The last I would like to say, oral health is required for beauty also, we all know. And many of the times, oral health is required for fulfilling need for living also. But very important thing, you cannot be healthy without oral health. So you need to maintain oral health also. And I thank you again for peaceful listening to me. And we can discuss the questions at the end of the session. Thank you very much.
Thank you so much, Dr. Jimmy, for a wonderful elaboration on the importance of oral health in our day-to-day life, and in particularly diabetic diseases, where we learn that if you don't have an appropriate oral health, then you need to optimize your anti-diabetic regimen. Now we are moving on to a topic which is very important in our physiological system. We define that our body is either physically active or it is in a state of rest. And all of you know that this day and night cycle, or we call it circadian rhythm, has got a very important role in our day-to-day life. So we have a wonderful speaker, Dr. Parimal Swami. He is a diploma in preventive health, Apollo Hospital, Hyderabad, and he is also holding certificate of excellence in diabetes care, NIMS, Hyderabad. And he is a certified cardiac rehabilitation facilitator. He is from a one of the very prominent city of Jabalpur, which is the largest infantry and military establishment. And because of the Indian military, we are able to take a good night's sleep. So now I invite Dr. Parimal Swami to start his session. Over to you, Dr. Parimal.
Thank you, sir. Thank you very much. Am I audible, sir?
Yeah. Please share your screen.
Yes, sir. Is my screen visible, sir?
Yeah. Please go
Thank
ahead.
you, sir. Thank you very much. Thank you for a nice introduction of mine. Good evening, friends, and welcome to this session on sleep and diabetes. In fact, 30% of our lifetime we spend sleeping. So sleep is not a passive state. It's just not a passive restful state. It is an active period of neuropsychological, physiological, and metabolic renewal. It is an important determinant of metabolic health and survival. We will see that too much and too little is bad for health, and the sleep quality also matters. How we sleep, it is not only the duration, the quality of the sleep is also important. Sleep and diabetes are inextricably interrelated. There are two problems with diabetes and sleep. Number one is sleep disordered breathing, and number two is decreased sleep duration and sleep fragmentation. When you see the literature, there is something like chicken and egg situation in sleep and diabetes. Sleep problem, they increase the incidence and prevalence of diabetes, and worsening diabetes status worsens the sleep status as well. First, we come to the sleep disordered breathing. There are multiple types of sleep disordered breathing present in a diabetic patient, but the most common is obstructive sleep apnea. Though central sleep apnea, mixed disorders, obesity, hypoventilation, and various parasomnias are also there. But the most important and most common is sleep disordered breathing, characterized by obstructive sleep apnea. There are multiple mechanisms through which the diabetes may lead to OSA or obstructive sleep apnea. These are altered chemoreceptor activation, decreased respiratory muscle strength, situation that produce airflow limitation, state of insulin resistance, state of leptin resistance, changes in breathing pattern and ventilatory rhythm generator, sympathetic hyperactivity, and defect in the hypothalamus pituitary axis problem. So these are various mechanisms which lead to the causation of obstructive sleep apnea in a diabetic patient. Again, when you search the literature, so there is bilateral relationship between the sleep apnea as well as diabetes. So diabetes may lead to sleep apnea through the weight gain, through the physiological dependent sympathetic activation and inflammation, and at the same time, because of the intermittent hypoxia, sleep fragmentation, there is more of inflammation which may lead to diabetes. So it is a bilateral relationship, as I have already told you. Now, the impact of OSA of diabetes, if we see what is the role of, or what is the importance of presence of OSA in diabetes, and you see that type 2 diabetes prevalence increases with increasing OSA severity. People who are having significant OSA will be having 28.9% prevalence of diabetes. severe OSA has got worsening of diabetes control. Similar to the conclusion of this particular trial was that increasing OSA severity is associated with not only the increased type 2 diabetes mellitus, but the worse diabetes control in patients who are already having type 2 diabetes. Now, when you look at the global prevalence of OSA, the condition is appalling. In fact, 1 billion people throughout the world, they are suffering from OSA. And out of those, almost 500 million people are having moderate to severe obstructive sleep apnea. And India comes in the first 5 countries who are having the highest incidence or prevalence of OSA. In fact, the prevalence of OSA in India is 13.7%, a bit more in male and slightly less in females. Again, you check the literature, the sleep apnea is one of the most important comorbidities with obesity, diabetes, congestive heart failure, depression, stroke, and hypertension. In fact, long-standing undiagnosed OSA may lead to the significantly increased incidence of stroke as well as cardiovascular events and mortality. It is also an important cause of vehicular accidents. Now, the feature of OSA, we all know that the patient may come to us with snoring, somnolence, choking, or gasping at night. There are multiple neurocognitive impairment, presence of depression, reflux, and headache. When we examine the patient, it may again range from, say, very, very subtle finding like obesity or short neck or a large neck circumference, presence of hypertension, which is not responding to the treatment, and the features of right ventricular failure may also be there with the increasing or worsening severity of OSA. Now, we keep on hearing about two things, the apnea and hypoapnea. Basically, apnea is the cessation of airflow for 10 seconds, which results in usually an 4% decrease oxygen saturation. Hypoapnea is decrease of 30 to 50% of airflow for 10 seconds. It may be associated with 4% decrease in oxygen saturation. The combination of both is called AHI, and the OSA syndrome is called when there is AHI of more than 5 per hour with symptoms. Here is a quick guide how to quickly screen the OSA in our day-to-day practice. It is called the stop bang questionnaire. Presence of snoring, tiredness. Somebody has observed that patient had got apnea, brief spell of apnea during the night time, usually the spouse. Presence of blood pressure. The bang denotes BMI of more than 35, age of more than 50, neck circumference of more than 15 inches, and a male gender. 3 or more than 3 signs, they usually indicate presence of OSA. And at the same time, if we care to see the neck of the patient, a short neck, and ask the patient to open the mouth, and the oral cavity anatomy, which is not showing a uvula, the tongue which is thick, large, and obstruct or not obscuring the uvula, may sort of guide us towards the diagnosis of OSA. The diagnosis is made by the proper sleep study. And again, there are classification of the severity of the OSA. The normal AHI, the apnea and hypopnea index per hour is 0 to 5 events per hour is normal. Between 6 to 15 is mild. 16 to 30 is moderate, and more than 30 is severe. Now, again, there are various mechanisms like sympathetic activation, endothelial dysfunction, hypercoagulability, inflammation, oxidative stress, and metabolic dysregulation, which will lead to various cardiovascular disorder. In fact, the association of sleep apnea with a stroke is very, very significant. Not only the patient has got severe stroke, dense involvement of the body, but increased stroke mortality. How to manage OSA in a diabetic patient or in any patient? The mainstay of the treatment is the CPAP therapy, the continuous positive airway pressure therapy. Various other things like weight loss, avoiding alcohol, sedatives, and muscle relaxants before the sleep time, sleeping on the sides, oral appliances, and surgical interventions, they also lead to the amelioration of OSA. You may be surprised that various oropharyngeal exercises are able to reduce the severity of moderate OSA to the mild OSA, and they ameliorate the symptoms as well as the improvement in the diabetic status. So this is again a sort of a field which skips our attention, but again we should teach our patient these oropharyngeal exercise who is having mild to moderate OSA. Now, after OSA, we come to the sleep quality, the duration and the fragmentation. So sleep quality duration is associated with the morbidity and mortality, and it is beyond OSA. A patient might not be having OSA, but if the sleep is fragmented, the sleep duration is not adequate, then the morbidity and mortality is increased. Chronic insomnia is around 33% amongst the adult population in India. With comorbidities like diabetes, it may increase up to 50%. So 50% of our diabetic patient might be having sleep duration problem or sleep fragmentation problem. The quality of the sleep may be abnormal. Again, this slide shows that India comes fourth in the country who has got worse sleep. So in both OSA as well as the sleep quality, India is in one of the comes in 5 top countries in the world. Now, diabetes is also associated with sleep disorder, not only sleep disordered breathing, but sleep architecture also. With the same amount of OSA, diabetes disrupts sleep more. It affects all the stages of restful sleep. It also leads to the fragmentation and micro arousal during the night time. This slide or this study shows the importance of presence of hyperglycemia, where the increasing hyperglycemia is associated with fragmentation of the sleep, micro arousals, and decreased efficiency of the sleep around 76%. In pre-diabetes, a slightly better glycemic status, the sleep efficiency improves to 86% as compared to NGT population, where in normoglycemic people, where the sleep efficiency is around 95%. So again, diabetes is affected by OSA, diabetes can produce OSA, diabetes is affected by sleep fragmentation, and diabetes can produce sleep fragmentation. So always we'll see this thread of bilateral relationship between diabetes and sleep. Now again, sleep duration is important. Short sleep duration of less than 6 hours and long sleep duration of more than 8 hours is associated with all the features of metabolic syndrome as well as chronic systemic inflammation. Also, the sleep reactivity is associated with the stress reactivity, and it sort of impacts the various chronic non-communicable disorders, the gastrointestinal function, emotional reactivity, as well as cardiovascular reactivity. And again, it is associated with increasing amount of events. Sleep fragmentation is also associated with impaired immunity, and this thing I think is more important in our present day scenario of COVID-19 infection, because impaired sleep, fragmented sleep is associated with increasing amount of IL-6, which may be a hallmark of worsening of inflammation with COVID-19 infection. Now, the sleep variability, the sleeping and waking up at different times, say throughout the period of 1 week or 1 month, is associated with multiple metabolic risk factors. Regular sleep schedule and consistent sleep is associated with a favorable metabolic profile. So we have to sleep at a particular time and we have to get up at a particular time. If we change this waking up time or sleeping time, then it may lead to the adverse metabolic profile. Now, how to measure the sleep quality? You can do a proper sleep study, but this is not possible to conduct a sleep study, say repeatedly. So there are sleep quality questionnaire. Again, they are cumbersome and they may require sort of expert administration. There are various mobile phone app which are there, wearables which are there, which are not very, very costly. And through this, you can sort of determine the quality of the sleep, the amount of the light sleep, deep sleep or moderate sleep, the period of the REM sleep, the sleep efficiency, everything could be measured. Some of these apps or wearables are clinically tested also. Once you check the quality of the sleep, then if it is abnormal, if the sleep duration is not normal, then you try to achieve sleep extension. And again, sleep extension is associated with beneficial metabolic outcome. So if the sleep is impaired, if sleep fragmentation is there, you improve the quality of the sleep, you can expect the better metabolic outcome. Now we can also use sedatives, which will increase the sleep time by 1 hour, but they are associated with addiction, risk of OSA in susceptible subjects, dementia, malignancy, as well as mortality. So it is easy to pop a pill, but it may be associated with significant adverse outcome on a long-term basis. Now, before you get a good quality of the sleep hygiene is important. Go to the bed same time. This we have to teach our patient. Comfortable sleep environment. The room should be dark and quiet. Some people may get better sleep with the white noise. And again, there are various app or white noise machine are available through which some people can get a better sleep. The bed should be used only for sleep and intimacy, because again, it makes a neurological sort of a circuit in your brain. If you use your bed for some other thing like watching TV or doing a computer work, daytime exercise improves the nighttime quality of sleep. Remove electronics, especially the smartphone and tablets, which emit blue light, which disrupts the sleep quality. Taking care of the food, caffeine, and alcohol before sleep. Alcohol may induce sleep, but it is associated with poor quality of sleep. There are various techniques to relax, which I'll be describing in short. And if you are having trouble falling asleep for more than 20 minutes, leave your bed, go to another room, and then come again whenever you are feeling sleepy. Now, there are certain sort of a non-pharmacological intervention to induce restorative sleep. The number one is certain types of breathing. This is called a praised breathing. You can get an app which is free from the Google Play Store, and through which you can attain a breathing where you take in breath and out breath in 5 seconds each. So in 1 minute, you take 10 breaths per minute. And through this, you can improve the cardiovagal activity and as well as restorative sleep through this type of breathing. If you do it regularly before the sleeping time, it improves the quality of the sleep. Again, the deep breathing with prolonged expiration and at the same time recruiting your diaphragm is associated with improvement in sleep even in patients who are admitted in the MICU ward. The place which is associated with fragmented sleep, where you need proper sedation to induce sleep, again you use this kind of breathing, it is associated with significantly improved breathing as compared to the control population. Certain mindfulness act like feeling the breath on one of your index finger before going to sleep is associated with improvement in sleep architecture, and it prevents sleep fragmentation. So these things which are non-pharmacological, devoid of any side effects, can be taught to the patient, and we have seen in our day-to-day practice that they are important.
Dr. Parimal, you have a minute to conclude your
Yes, sir.
session.
I'm coming to my final slides. There are certain sort of a technological things like brainwave entrainment, stimulating your brain through the headphone at different frequencies, which will induce a delta wave sleep. The stimulating vagus nerve through your ears, then they are also associated with improvement in the sleep quality, and you can combine both. Again, we have got some experience of using these technologies, and they really induce a good quality of the sleep. So at the end, I would like to say that it is a bilateral relationship. Sleep quality impacts diabetes, and diabetes control also impacts the sleep quality. So with well-managed diabetes, it could result in better sleep quality also. And finally, this is the defining slide from 2020, and it shows that sleep duration is associated with mortality also. A middle path is the best path. Too much sleep and too little sleep is associated with increasing mortality. Probably we are looking at a new treatment for diabetes, which is to address the sleep. Friends, we know both of these things, good laugh and good sleep is important. So let us introduce these in our lives and as well in our patients' lives. Thank you very much for patient hearing. And I would like to thank Dr. Banshi Sabu and team for including me in this sort of epic event of 2020. Thank you very much, sir. Thank you very much.
Thank you so much, Dr. Parimal, for a wonderful explanation on the sleep and its relation to the mind, body, and it's all pathophysiological cascades. So, friends, we already learned from head to hypogastrium. Like we started with a sleep, and then we had a oral health, and then we had a gut and the diabetes, and then we also learn about the important role of disease-specific formula. So now we go to the last bottom part of our body, that is leg, how to exercise and shake our legs. And all of you know that recently WHO has also laid down guidelines about the activity which every individual they have to do. So today we have a wonderful speaker, Dr. Rucha Mehta. Unfortunately, she doesn't need any introduction. She is known to all of you. But just to briefly introduce, she has been trained at the Harvard Medical School, and she had been a phenomenal teacher for a number of students, and she has been on a panel of expert group of diabetes and obesity of RSSDI and the Endocrine Society of India. And her areas of research includes pre-diabetes, obesity, metabolism, and the weight loss, particularly ketogenic diet. Without wasting much time, over to you, Dr. Rucha.
Great. Thank you so much, Dr. Dabi. And I would just like to correct you. I'm not trained at the Harvard Medical School. Dr. DeFranzo, my mentor, is certainly. So just a small correction there. And I'm going to point out that you've taken 3 minutes for my introduction. So you give it back to me.
But you have ample
because I
time
saw
to
that you're a
discuss.
very strict timekeeper, and some of the speakers had to cut short their talk. So the talk
Yeah.
given to me by Dr. Bansi and colleagues today is exercise and diabetes, which one and how much. And, we'll try to just quickly go through as to what is the data out there. My only disclaimer for this talk probably is that I'm an endocrinologist. So bear with me if this talk is not going to sound like that of an exercise physiologist, but we'll come at it more from the angle of diabetes and how a clinician can approach this. So Hippocrates, the first speaker for this panel started with Hippocrates. So I think it's just wonderful that Dr. Supratik and I are on the same page. He wrote, the father of medicine, that eating alone will not keep a man well. He must also take exercise. And therefore we can see that he knew long time ago that all of us need to keep on moving. So here's a very nice study wherein what they did is they took about 6,000 men, BMI less than 24, 24, you can see 25.9 and more than 26. So these are not, very obese men. And they looked at the rate of type 2 diabetes. And this is the exercise amount in kilocalories. So you can see that if your BMI, if you're lean, it doesn't seem to make much of a difference how much you exercise. But the minute your BMI even starts going up to this point, if you exercise more than 2000 calories per week, you can see that lowers your risk for type 2 diabetes. And if your BMI is more than 26, so this is not a big number. If you exercise less than 500 kilocalories, you have a higher chance of diabetes than if you're exercising more. So this is the impact, irrespective of weight that and diet, that exercise can have on the chance of developing type 2 diabetes. We know from several diabetes prevention programs that diet alone and exercise alone, as you can see, if you just look simply at the Indian Diabetes Prevention Program at the bottom, lifestyle had a 28.5% chance of reducing the chance that you progress to type 2 diabetes. So we know there is strong data to suggest, even from the Indian subcontinent, that we can prevent this type 2 diabetes, and therefore it's important to look at it. Okay, so moving right along, I'll try to cover in the next several minutes some of these topics. That does it really work to lower your blood sugar? What is the acute benefit? What is the chronic benefit? And what is the data? And as they rightly asked me which exercise, so I wrote form, dose, and side effects. I never knew sleeping more than 8 hours can also induce or I forgot maybe can have the chance of developing metabolic syndrome. What I don't have a chance to show in 15 minutes is point number 5 is extraglycemic benefits, or CVOT trials, as we always talk about. And some of the things I'll try to show, if possible, how does this translate into real life benefits? This is how it works, taking you back to school, sorry. So we all know that insulin mediated pathway through the insulin signaling receptor and several ligands to move glucose via glucose GLUT4 transporters intracellularly. Exercise through an insulin independent pathway or muscle contraction works through this APK, the protein kinase C pathway, the calmodulin, and the AMP kinase pathway with an intermediary of LKB1, also to increase signaling and increase transcription of glucose transporters 4. So this could be an acute effect of exercise. Now let's see what happens in our patients with type 2 diabetes. So here's a meta-analysis done by Dr. Boulier and colleagues, wherein they looked at exercise on glycemic control. 12 aerobic training studies, meaning you are staying in the aerobic zone while you're exercising, as well as 2 resistance training studies were included in this particular analysis. Half of those participants were women, mean age of 55 years, and duration of diabetes 4.5 years. What they found is the difference in post-intervention body mass between the exercise groups and control groups was not significant, proving yet again that diet is a huge part or plays a huge role in weight loss. However, what we did find is that the HbA1c was certainly lower in the exercise groups compared with the control groups with a p-value less than 0.01. So yes, from this meta-analysis, we could conclude that exercise does have a role in lowering HbA1c. I'm just showing one study per question, because that's the interest of time. So what about different modes of exercise training? So we've heard about you should do running, cycling, yoga, Zumba. But when we start thinking of exercise, we have to think in terms of exercise as, is this aerobic exercise, meaning something like walking, slow running, jogging, cycling, swimming? Or is this a resistance training wherein you are actually causing tension on the muscle? So weightlifting, it could be using resistance bands, some forms of Zumba and yoga. So these are the various types of exercise you may want to combine for your patients with diabetes, depending on their tolerance or what their underlying musculoskeletal structure is. And let's see what happens. So again, in this particular meta-analysis, 27 studies were included, and there were some that had aerobic training, only resistance training, or combined training. Almost 1,000 type 2 diabetic patients, and the studies lasted from anywhere from 5 to 104 weeks. What we found is that the HbA1c reduction, if the training was less than 12 weeks, had a very small benefit. Combined training was superior, meaning both aerobic and resistance training, to either alone. Now, some of the extra glycemic benefits is we found that there were beneficial effects certainly on blood pressure, cardio CV fitness, as was mentioned by VO2 max testing and treadmill in some of these studies. And with the exception of a small benefit on HDL cholesterol, they had very trivial benefit on the blood lipid levels. So what I'm trying to tell you is, would you be like PT Usha and just go and run very fast, or like Carl Lewis? Or is this something we should be doing chronically in the long run, like our ultra marathoners, Dean Karanzis, wherein you can do an endurance training? So that is the second question. Yes, exercise helps, but how much, and how much is too much or how much is too little? So intensity versus volume, that's what I'm trying to sort of show you. So in this particular study, if you will look over here, this is the HbA1c, and this is a bout of high intensity interval training done in about 266 patients with type 2 diabetes. And in this particular, we can see it's the volume, so it's hours per week. And you can see that the peak or the slope of the drop in HbA1c is much steeper with a higher intensity. So yes, exercise intensity predicted that there could be a significantly more drop in the HbA1c. We need to combine all this for our patients. So yes, high intensity resistance training does improve glycemic control, especially when it's done for a long duration. In this particular study, which was done for about 6 months, what do we find? In addition to exercise, resistance training plus weight loss. So if your patients lost weight and did resistance training versus weight loss alone, so this is the 0 to 3 months results, and this is the change in HbA1c. And if they continue doing that, they can have a better and more significant drop in the HbA1c. So yes, doing chronic exercise seems to induce different pathways versus simply acute exercise wherein there is a glucose or an insulin independent stimulated pathway for glucose translocation intracellularly. And we'll look at those mechanisms in just a minute. So combining what I've told you so far, certainly exercise has an important role in bringing down or lowering blood glucose by its own independent mechanism. Combined resistance training, meaning a combination of aerobic and resistance training, is superior to doing either alone. If it's feasible, including 1 or 2 bouts of high intensity interval training is very significant to be done in your patients with type 2 diabetes and may have other benefits beyond what you can simply see. So intensity plus volume plus chronicity. Okay, mechanisms. So I promised I'm not going to explain all of those little molecules on the slide over here. Instead, we'll try and focus on 2 key players. So you leave the room today or you're at home, so you stay at home and learn something. So I mentioned already to you the glucose transporter 4 and the AMP kinase. I sort of like to say that maybe the GLUT4 is a Virat Kohli because he's the one, doing short term. But we have AMP kinase, who's kind of our Dhoni, who seems to have overarching benefits. He seems to be, he's a senior player. He seems to understand what's going on. So let's look at this. Here is a very interesting study, small study, but it's a mechanistic study, wherein 14 obese patients with type 2 diabetes, they actually looked at a mechanistic 2-stage euglycemic clamp procedure before and after they were made to exercise for 7 days. The training consisted of 30 minutes of cycling and 30 minutes of treadmill walking at 70% of maximal aerobic capacity. So you're in the aerobic zone. And what do you find? So here's the glucose disposal. We can see that this is the pre-study and post-study with the 40 million, this is the 40 MU insulin clamp. The glucose disposal increases and increases even more with the 1000 milliunits of the euglycemic clamp. Similarly, the hepatic glucose production at baseline is this much, and you can see how significantly it drops. So you've lowered both your fasting glucose from the liver as well as cleared. So you've improved both insulin sensitivity as well as responsiveness in your patients with just 1 week of exercise. Also, in this particular study, what they showed is a single bout of exercise can increase your glucose transporter 4. So Virat Kohli doesn't need much stimulation, and you can sort of get him going with just a single bout of acute exercise. And this is shown clinically. Again, it's a small study, but done by a very good group of people. So this is normal patients, and even in type 2 diabetics, even though glucose transporter 4 are less compared to normals at baseline, you can see how significantly they also go up with an acute bout of exercise. So even if your patient wants to exercise once or twice a week, do not discourage it. So now let's move on to MS Dhoni and understand him a little better. He's the guy who is sort of the gauge. He's gauging what's going on. So AMP kinase, truly the word I like for it is that it's a fuel gauge. It's gauging how much glycogen is in the muscle, how much fat is in the muscle. And accordingly, whenever there's a stimulation, namely contraction of the muscle, it has 3 units. It's called a heterotrimer. And therefore, the alpha subunit, which is the one that has to be activated, can get activated either to stimulate your ATP generating pathway or the ATP consuming pathways, depending on the fuel store of the muscle. Now, beyond this, AMP kinase has been implicated in several metabolic regulatory pathways. At the muscle level, it increases insulin sensitivity, glucose transport, fatty acid oxidation. At the level of the liver, it reduces gluconeogenesis and de novo lipogenesis. At the level of the heart, it can increase glucose transport and improve fatty acid oxidation. Drugs like metformin and pioglitazone can stimulate the production of AMP kinase, and hence they might be doing so well in our patients with type 2 diabetes. Now, these are other suggested and proposed mechanisms for AMP kinase actions. So for example, I already mentioned to you glucose transport, mitochondrial synthesis, fatty acid oxidation, mTOR pathway, the sirtuin pathway, also some pleiotropic effects on oxidative stress such as mitochondria, reducing ER stress. The second epigenetic pathway signaling is that with genes and environment causing overnutrition and obesity and lack of exercise, of course. Look at this up top. One of the early pathogenic events is a decreased AMP kinase. And eventually, all of this collectively leads to diseases that we dread in our patients with type 2 diabetes, hypertension, ASCVD, NAFLD, cancer, and Alzheimer's disease. So AMP kinase is really of interest to us. I'm not showing all the studies for AMP kinase, but metformin over here in muscle of subjects with type 2 diabetes, you can see as early as 4 weeks, we have an increased signal for the AMP kinase. This is done with skeletal muscle biopsies and Western blotting. So now I propose to you the mechanism for the chronic effects of exercise, that exercise training and repeated muscle contraction through the calcium calmodulin pathway increases calcineurin, the CMK pathway, the P38 MAP kinase through an intermediary of ATF2. It now works on this very important molecule we are all familiar with, known as PGC1 alpha. Also along this other pathway by the AMP ATP balance, it increases the AMP kinase pathway. And collectively, as you know, all of these can work on increased GLUT4 translocation, mitochondrial biogenesis, as well as muscle fiber growth. And therefore, Susruta rightfully said that exercise should be taken every day, but only to the half extent of your capacity so it does not prove fatal. I'll move on to the clinical studies and wrap it up in the next 2 minutes. You guys probably thought I would start with the look ahead study as I always do, but this time I kept it for the end because all of this now explains why in the study with look ahead, where 5,000 type 2 diabetic patients for the first time underwent an intensive lifestyle intervention versus a simple support and education group, And they manage to stay in remission if they continue taking exercise and the dietary support given to them in the intensive arm. So this is important that just like a medicine, you need to be exercising and following your dietary guidelines every day. From our very own Indian diabetes prevention program, Dr. Ramachandran's group has shown that in the lifestyle arm, and it's very interesting to read this lifestyle, it was not as structured as a look ahead or the US diabetes prevention program where they were given gym memberships. But here they were simply asked to walk from their farm to home, walk as much as they could. And even this simple lifestyle intervention had a very significant effect of reducing their chance of getting type 2 diabetes by a significant about 28 to 30%. Here's a very nice systematic review looking at a structured exercise program in South Asian patients with type 2 diabetes. They looked at the effect of aerobic, resistance, combined, and last but not the least, balance training in your patients with type 2 diabetes on HbA1c, blood lipids, blood pressure, and anthropometrics, muscle strength, balance, functional well-being, and quality of life. And you can see that the aerobic training seems to have the most benefits, followed by the resistance training. So this is important to figure out in your patient what works well and make sure you're guiding them for the aerobic as well as resistance training path. Now, I thought this was very interesting. This is engaging South Asian women. Women are very reluctant in India to come out and walk, or they're very, not willing to go to a class, maybe even. So this was an 8-week pilot study of Bollywood dancing done for South Asian women with type 2 diabetes. A 1-hour class was offered twice per week at the India Community Center, and they had to do 30 minutes of Bollywood exercise, 15 minutes of muscle resistance and weight training. And lo and behold, there was a statistically significant drop in HbA1c, not a very great drop in weight, but all of the data was very supportive, and the quality of life questionnaire was actually very encouraging. And lastly, yoga, which is very important in India. We all believe in the yoga way of lifestyle, the Ayurveda way of lifestyle. So these are 23 studies. So we have a large amount of studies with yoga, with 2,500 patients almost. And you can see that patients who did yoga were successful in improving their HbA1c, fasting blood sugar, as well as postprandial blood glucose. Yoga also caused improvements in cholesterol, blood pressure, BMI, and waist hip ratio. So I think this is very important that in the Indian scenario, where the lifestyle is much different from the Western world, we need to use a good combination of all of this. We do have our RSSDI guideline, wherein it says the duration should be about 30 minutes. But as Dr. Dabi pointed out, which I have not included, is the WHO guideline, wherein now we really talk about you need to be going the extra full hour and you need to be exercising 6 days a week or almost every day. Muscle strengthening activity, we have modified charts for our patients with type 2 diabetes, easily available on the website. And we can certainly share those with you also. The ADA also has guidelines for exercise in type 2 diabetes, that you need to be doing this aerobic exercise, not on one day, but it needs to be spread over several days of the week. Resistance exercise also is important, flexibility and balance training. And as I suggested, yoga or even some kind of dance training or one bout of high intensity interval training. So in conclusion, in individuals with type 2 diabetes, the insulin-dependent regulation of skeletal muscle glucose transport is impaired, known as insulin resistance. However, the exercise pathway seems to be intact. So we need to take advantage of that. GLUT4 is a predominant glucose transporter seen in the skeletal muscle and can be recruited by the exercise pathway. Accumulating evidence suggests that the energy sensing enzyme AMP activated protein kinase has an important role in contraction stimulated glucose transport. There's a lot of interest in developing medications that will kind of stimulate the exercise pathway. And last but not the least, just like you're writing a medication prescription, you need to give a customized exercise plan for your patients with type 2 diabetes. And with that, I'll just stop right there. Thank you very much.
Thank you so much, Rucha, for a wonderful presentation. And we already learned that right from head to toe, everything is important in our life. And as you rightly explained that days are not far off, like medical nutritional therapy. The word used is therapy, which comes under law. We will have a PET pad, that is a physical exercise therapy. So this we have to be incorporated in our day-to-day prescription. Thank you so much, all the speakers. And now we move on to the questions thrown to all of you. So the first question is for Dr. Supratik. Probiotic has a significant effect to decrease HbA1c, as you said during your presentation. So the question is to take yogurt in diet to type 2 diabetes. Do you feel it should be advised? Yogurt and diabetes. What is your advice on day-to-day consumption? Can you unmute yourself, Dr. Supratik?
Yes. Oh, thank you for the question and thank you for the invitation. Yes, I think it's more sort of asking about the lactobacillus, which is an important component of our microbiota that we have. And of course, we had shown that, like if we can alter the microbiota favorably, then that is going to sort of increase the short chain fatty acid mediated actions like increase in the incretin effect, increase in the endogenous GLP-1 levels. And that, of course, is going to help you in terms of reduction or sort of in management of diabetes as such. And,
so, Dr. Supratik, the question is in India that lots of people, that we are a hardcore fan of full fat. So the fat content in our milks are very high. So do you feel that by eating more dairy products like this fermented yogurt, are we going to increase the intake of saturated fatty acids and which subsequently lead to increase in LDL cholesterol?
So I don't know, the commercially available one, we are not talking about the sweetened, we are not talking about the Bengalis mishti doi, which is very nice to have once in a while, but we are talking about the regular curds, I believe, without adding sugar in it. Isn't that what you're talking about?
Correct.
Yes. So yeah, I think we are, what the question is intended to do is to sort of alter the gut microbiome by adding lactobacillus, which would sort of direct it favorably. I think that's the question. So we're not very concerned about whether it's made from, I'm not really sure. Yeah, so it's a fermented that is, so I'm not very sure whether you're talking about the full fat curd or not. And I am not very sure it's going to make a very big impact, so as to say, as long as the quantity is sort of specified and you're not adding sugar to it.
And there is a question to Dr. Parimal, that is, what is the role of melatonin supplements in sleep induction? All of you know that this melatonin is now available over the counter, though the dose strength is very low in India. So what are your comments on melatonin usage?
Sir, the role of naturally occurring melatonin is of course there, because pancreas has also got the melatonin receptor. So natural amount of melatonin would improve the sleep quality as well as the glycemic status. But the supplementation of melatonin is not supported by a good quality data. All the interventions, non-pharmacological intervention in sleep hygiene is going to increase the naturally occurring melatonin, and probably that is going to improve the sleep quality, not the outside melatonin, which is not supported by good quality studies.
But in India, the preparation are generally containing 3 milligram versus 12 milligram in the foreign countries. So what do you think the actual dose of melatonin, if at all?
Minimum dosage is 3 milligrams, sir. Minimum dosage is 3 milligram. Anything more than 3 milligram is sort of some small studies have shown to be improved the sleep quality. As you are saying rightly, the usual dosage is around 10 milligram, but anything more than 3 milligram would be required.
Okay, thank you.
There is some emerging data. Melatonin is inducing insulin resistance, so we do have to be careful using melatonin without judicious understanding.
And all those studies which are there with showing melatonin improvement are very small, non-randomized trial and case of observational studies, not very good quality studies.
A question to you, Dr. Rucha, is what are the best exercise for diabetic patients with osteoarthritis? You know that most of our patients, they develop osteoarthritis at a quite early age. So what do you think? How are they going to optimize the physical activity recommendation?
So certainly, if the osteoarthritis depends on which joints. If you're talking about lower body, so knees or feet or something, it becomes very challenging. But doesn't mean they have to stop walking. Using a good physiotherapist or physiotherapy department, they still have to be encouraged to at least do the minimum amount of walking they can. Some balance activities, yoga or just at least yoga breathing, and all of those can be done. Upper body exercises, which all of us have a lot of those handouts that we can give them to in clinic and etc. has to be done. So in terms of aerobic activity does become really challenging if the joint or osteoarthritis is really affecting them. That's the time when we need to think about doing, if necessary, a surgical intervention early on versus waiting, for a joint replacement too late when it's beyond the point of scope of help to them also.
Any
Swimming,
idea?
some other sedentary bicycling, these can be also included, of course.
Rucha,
If I just could add to that, I think
Please.
hydrotherapy is something that
Yes.
has been talked about quite a lot actually in these patients.
Absolutely.
yeah, so in most of the patients with osteoarthritis, we recommend water-based activities where there is minimum stress on the joints. But Rucha, what are your comments that this physical activity is must for chondrocytes to release the lubricants in the joints? So are these physical activity, on the contrary, going to improve the osteoarthritis in patients with
I
diabetes?
mean, we have studies looking at that, of course. So, the data is always depending, they're small studies, but we have good data looking at that. Again, like I said, it has to be a structured program and therefore with a good physiotherapist or physiatrist, as we are calling them. So, not every place has that structured program. So, do no harm should be very important. So, working with your patients, not knowing what is going to release the chondrocyte, stimulate is not a good way to go. So, that is important to keep in mind.
Question to you, Dr. Jimit, as you rightly said, the important role of oral hygiene. But what are your comments that how frequent, what is the actual advice we should give to our diabetic patients, apart from good control of diabetes? Or do you think good oral care will improve the diabetes?
Yes, sir, definitely the oral recommended care is same for diabetic patient and non-diabetic patients. Only thing they need to be observed or they need to be examined more frequently as compared to non-diabetic patients because we need to screen these complications. And if the complications are there, we need to treat them aggressively because I have shown that they have bidirectional relationship. So if they have complications, they should be treated aggressively and if we screen them early, then we can treat it very.
Correct. So, Dr. Supratik, what are your comments on regular use of probiotics since lots of expensive probiotics are available, say, for example, VSL3, and people have documented the benefit in form of improving the gut health. But what are your comments on the regular use of probiotics with respect to the metabolic benefits in an Indian perspective?
No, so I think we do have a very robust study that was done with VSL3, which has shown improvement in terms of like obesity management and diabetes management as well. But like now the idea is to use something which is multi-species. One of them, of course, I forgot to put up my disclaimer slide. But like Iman's, as I was going to talk about, was a combination of say. Bacillus clausii and subtilis, which is known to sort of replace the healthy bacteria and alter the microbiome in the right direction. So I think, as we were saying, that maybe in future we are going to do a profiling to understand what kind of prevalent microbiota is there, and then try and alter it favorably. So going from obese towards a more healthy spectrum. So I do see it a very important area of research, and I think there is a scope for regular utilization of this kind of replacements.
Dr. Rucha, as you rightly...
Sorry. Sir, is there any test to find out whether the patient microbiota, gut microbiota is okay or very bad or slightly bad, or some indicators on laboratory findings?
I don't know. I think it's more sort of the scopy still now, like because the microbiota on the upper part and the lower part is quite different as well. So I think a specific sampling has to be done. And as of now, it's probably in the form of biopsy and which is coming from the endoscopies that we perform. But I'm not very aware of any other tests that are being done routinely in our clinical practice.
Dr. Rucha, as you said that the exercise very important component of diabetes management, but in India we do not have any skill trained trainers to teach all our patients. And as you said that most of the studies in North America that the trainers are usually American board sports medicine certified. So in that scenario, how do you feel we as a physicians will cope up with our day-to-day
So I
task
think we
with
can take and we can be encouraged by Dr. Ramachandran's Indian Diabetes Prevention Program, wherein he simply asked them to walk as much as they could. And truly speaking, when you walk even more than jogging or running, you're going to stay in the aerobic zone if you can do a brisk walk. So that's what we actually guide our patients, even when we don't have, we of course have a little bit more time than general practitioners because we are specifically geared towards diabetes. But in our exercise practice, when they first come into clinic, a very simple thing is when they are waiting to be seen the first time, they fill out a recall sheet, which includes not just diet, but also what they're doing in terms of exercise. So they might write down they're walking twice a week. So that's where we can guide them on, using aerobic heart rate zone training as to you. Nowadays, everybody wears a smart watch or has a Fitbit, or even their phones can check their heart rate. So it's really become interesting as to how we've been able to move this whole exercise training in a much more interesting way than 5 years ago. So we actually guide them based on heart rate zones, even if they've had a cardiac event. If they're on beta blockers, we kind of guide them that you need to keep your heart rate in this zone. We customize it for every patient. And we have actually been able to do several interesting studies with them, looking at their aerobic capacity, VO2 max, 6-minute walk test, and exercise tolerance. So the simplest thing is if they are couch potatoes, we even tell them walk around your dining table after each meal, for 5 minutes, 3 times a day. That's how we start sometimes. So it could be something as simple as that. You don't need a fancy gym. COVID has taught us all of that we can use, things we have at home, like just simply lifting a 500 ml water bottle or doing weights with that. So we train them for all of those. Just simple things, guiding them for YouTube videos, yoga pranayam can work. So yes, walking is one of the best forms of exercise for your patients with type 2 diabetes, and combining some form of resistance training would be the next step, using videos and those kinds. Yoga, most of them are smarter than I am at yoga. So yes.
So thank you all. If there are no questions, we conclude the session. And any questions from the participants to any of the panelists? The podium is open for the discussions.
Yeah. So Dr. Parimal, if I may ask a question.
Yeah,
Because
please.
you showed a slide where sleeping less than 6 hours or sleeping more than 8 hours can all lead to metabolic syndrome. So this more than 8 hours thing, is that a done deal? Because that was something I was surprised to see. I thought 7 to 8 hours, we always say that, but if your patients are sleeping more than 8 hours, am I supposed to now tell them that?
Yes, ma'am. Actually, the data about more than 8 hours is more robust than the less than 6 hours.
It's interesting.
So
Okay,
more than 8
for
hours
some,
sleep is
I've not come
associated with
across that.
increased mortality. And the slide I have shown you is from the Lancet 2020. So there is a
Ask you
big
to email me that article later because I'm really interested to read about
So
it.
that Dr. Parimal, it's a one-time sleep or it is a sleeping time all throughout the day?
No, sir. Again, good question. You can have good quality sleep in
afternoon
in segments. It is
Correct.
not necessary that you have to sleep 6 hours continuously, but you if you got a good architecture sleep, say 3 hours twice during the night time, then it is sufficient.
So there is a question from Dr. Deepak Bandhu to Dr. Parimal that if a person gets up at night and say probably at around 2 o'clock midnight, and then he doesn't get into the sleep. So what do you think? What is to be done for such a kind of fragmentation? So
He's unable to sleep after 2 a.m. in the night. That was
correct.
Sir, I have shown you 3 breathing exercises, and believe me, if we learn very simple exercises, those exercises basically stimulate the parasympathetic nervous system, and they are supposed to quieten the activity of the default mode network. which makes the mind chattering. And a brief intervention of, say, mindfulness training, where a person sort of feels all the sensation on the index finger, which is produced by the breath, and that puts the person, the mind chatter is reduced, and that person is able to sleep. So there are certain app which can produce binaural beat. They are also sort of make the brain entrain at the delta level frequency, and then they can induce sleep. Some patient, despite all these things, might not be having the good quality of sleep, but those will be minuscule. Most of the patient who have got no other psychological or neurological problem, they can have proper induction of sleep with these non-pharmacological interventions.
Just on a lighter side, just since the year is getting end, if you pay your advance tax on time, I think you will be able to sustain sleep all throughout the morning. There is a question for Dr. Supratik that nowadays we have a big fashion going on, is all about the intermittent fasting. So does this intermittent fasting affect the gut microbiota?
So that's a very brilliant question. I think there's a
It's from
study that
Dr.
was
Sanjay.
published. Right. So thank you, Dr. Sanjay. So there is a study published in PubMed not very long ago, and which showed that intermittent fasting did reduce significantly the LDL cholesterol levels and also restored the liver steatosis. At the same time, it did sort of improve the the gut microbiota. And the proposed mechanism that was shown was by increasing the abundance of YH2 and RF32, if that makes sense. So basically altering the levels of lactobacillus and the other essential microbiomes in our gut. So it does affect in a favorable way. So that's a good question.
So thank you so much, all the panelists, Dr. Rucha Mehta, Dr. Supratik Bhattacharya, Dr. Parimal, Dr. Jimit. Thank you so much for all of you to give a wonderful presentation on the Diacor conference, and thank you all participants, and thanks Diacon organizing team to give us all an opportunity to interact and network with all of you. Thank you so much.
Thank you. Thanks for
so much for
wonderful
this
chairing, Dr. Dabi, as always.
Thank you.
Thank you so much.
Thank you so
Great
much.
sharing. Thank you.
And thanks,
Thank
Dr.
you. Great to
Bansi and
see you all.
Diacare team. Thank you.
Thank you,
Thank you
Chairman
so
sir,
much.
and
everybody.
thank you, Dr. Bansi sir. Thank you very much.
Thank you very much to all respected speaker for a wonderful talk, and thank you very much to our chairperson of this session. We shall move to our next session. I would like to invite our rapporteur, Dr. Kunal Jhaveri. Over to you, sir.
Is Dr. Kunal is here?
It seems like Dr. Kunal is not there.
No problem, no problem. On the behalf
Shall
of,
we? Yes, sir. Please go ahead.
on the behalf of organizing team, let me first thank you all our panelists from the last session. We had a wonderful session here, and we are moving towards our next session that has at least many interesting hotspot or very hot topics in diabetes, and we'll be discussing one by one. And we have 6 speakers for this session. And if Dr. Kunal is not there, let me introduce our esteemed chairperson. We have Dr. Padma Gulati from Jhansi. We welcome you, ma'am. And we have Dr. Rahul Dhupre from Pune. We welcome you, sir. And we would like to invite you to take over the session and invite the speakers and for the proceeding of the next wonderful session, hotspots in diabetes. Over to you, chairperson.
Okay, Dr. Padma.
Yeah,
Okay,
so we are going to have 6 topics in this session, and the first one is going to be on monogenic diabetes by Dr. Kashyap Patel. Can I have the introduction slide, please? Yeah, so Dr. Kashyap Patel is a Wellcome Trust Career Development Fellow and consultant physician in diabetes and endocrinology. His main area of research includes understanding the genetics of diabetes with a focus on monogenic and type 1 diabetes. He was a Wellcome Trust PhD Research Fellow in prestigious MRC protein phosphorylation unit in Dundee, where he was awarded his PhD studying the glucose metabolism in liver. He is the recipient of prestigious Young Investigator Awards from Diabetes UK. So over to Dr. Kashyap Patel. And as we know, we have 15 minutes time for your talk and 5 minutes for discussion. Dr. Kashyap Patel, please.
Thank you very much. Let me share my screen. Okay, can you see me? My slides okay?
Yeah.
And can you see the mouse, the pointer?
Yeah.
Brilliant. Okay, so good afternoon, everyone, and thank you for the introduction. I'd like to thank Dr. Sabu Bansiji for invitation. So really, next 15 minutes, I'm going to talk about monogenic diabetes, and really, this is the diabetes where people think this is not in my clinic. You know, everyone says, "Oh, this is not for me. It's too rare." But let me tell you this, that it is the diagnosis. If you make it, you're going to make a huge impact on your patient for lifelong. So when we really talk about monogenic diabetes, what I really mean is a diabetes due to a single gene defect. And there are lots of different words out there, but it's essentially a genetic forms of diabetes. It can be either due to what we call a heterozygous mutation, so where you have a normal allele on DNA1, and then you have another one which is mutated, so you call heterozygous, or dominant forms of diabetes you get because of this. Or really, you can have both alleles of DNA has been mutated, which is what we know is a recessive mutation, and is often seen when the parents are consanguineously married. And really, if you want to put them in some sort of categories, these diabetes, you can broadly put them in 3 different ones. The one we call them neonatal diabetes. This is a diabetes essentially described as the one someone get diabetes under the age of 6 months. So really purely based on age. It is rare, and we have done a lot of work in Exeter, and we now know at least 27 different genes causing this type of diabetes. The second one, which I'm sure a lot of people are aware of it, are called MODY, which is a maturity onset diabetes of the young. Now, the MODY is essentially a physical description of diabetes, which was done many years ago in 1974 by Robert Tattersall in Oxford in the UK. And essentially, it is a non-insulin dependent diabetes, which present under the age of 25 and has a dominant history of diabetes. It's about 11 genes causing this, and if you think it is rare, think again, because we have done some population studies in the UK, and I've done some in Turkey, and we know that is about 3% of clinic, 3% of your patient with diabetes under age 30. And there are certain tips I'm going to give it to you to increase that number to nearly half of them. The patient you see might have a MODY. And then finally, which I really like to group them, is a recessively inherited ones. Again, you might have come across this. Is often seen in a young pediatric patients, but they have insulin-dependent diabetes, but often they have some extrapancreatic features. And one of the famous example of that is a Wolfram syndrome. And really what I think is monogenic diabetes is like detective work. In the UK, you might say it's a Sherlock Holmes, but this is my favorite character, Byomkesh Bakshi. I know people with my age might remember in 97, I think, it came on. Wonderful series. It's really about observing your patients and really just taking in history. And that is the biggest clue you can get, finding those elusive monogenic diabetes patients. And actually, and I'm going to get you through a few cases just to kind of get feel for it and what I'm trying to say here. So this is MP. He's 18 years of age now, and he diagnosed with diabetes at 3 months, and he's really ill at that time. He has been treated for the last 18 years as type 1 diabetes and with insulin, and he had an extremely terrible time. Hypoglycemia all over the place, glucose high, low. I mean, this life of him and his parents were really very, very poor. If you measure C-peptide, he was not making any. So what we describe this is that MP has something called neonatal diabetes. So when did we kind of think about it being a monogenic diabetes? Well, this is the most important data, which kind of first suggested that something is quite odd about the people who get diabetes under 6 months. So what you have here is a high risk type 1 diabetes HLA distribution in people who are normal. So you get about 30% background rate. And what was interesting is that those under 6 months of age, they had a similar level of type 1 associated risk alleles as the people who were normal. And as soon as you kind of looked at the people diagnosed after, suddenly they get high risk HLA allele increased, which is inconsistent with type 1 diabetes. So that was the clue that something, those under 6 months, is not a type 1 diabetes. And indeed, Lisa DeFranco, Nexusa, did the wonderful work over last many years, and we sequenced nearly 1,000 patients with the neonatal diabetes coming from more than 76 countries. Now, this number at the moment is 99. And we know that they're caused by roughly 27 genes, depending upon which background you come from. If you're a consanguineous pedigree, you get a different sort of gene mixture compared to from non-consanguineous ones. But what is clear was that at least more than 80, and now this data is all in 2015, and we haven't published the up-to-date ones, but right now we get diagnoses for 90% of people who get diabetes under 6 months. And one of the exciting finding of this one was these two little genes you can see at the bottom, which is a KCNG11 and ABCC8. Now, those genes are the genes forms what we call KTP channel. Now, KTP channel, you all aware, is really the binding site for well-known drug sulfonylureas. We use it left, right, and center for many, many years. So essentially what happens in these patients is that when they have a mutation in one of these genes, which forms these subunits of KTP channels, essentially they don't respond to these high ATP levels, which happens in normal beta cells because of metabolism. And because they don't respond, you don't get depolarization and you don't get insulin secretion. So you basically essentially get diabetes. So once I think Andrew identified this back in 2004, it was very clear that the best way to treat them is use sulfonylureas because essentially it closes the channel. And that's exactly what happened, that when you put sulfonylureas, it closes the channel, it depolarizes the membrane, and you got insulin secretion. So not only we found the reason for diabetes, we also found the treatment. And that was such an exciting finding, and it has a massive impact in people's life. So left end of the panel here, what you're seeing is that the study done by Ewan Pearson when he was in Exeter, that took people who were on insulin with the mutation in the KCNG11, so that is that KTP channel, and then he took the insulin off and put entirely of those children, or in some cases adults, were on sulfonylurea, and you can see that all came off and they had a better glycemic control. You can look at some traces of the glucose. This is the single individual patients who are on insulin pump, and then after glibenclamide, you can see how tightly the glucose is controlled. And that's exactly what we did. But one of the things I'm sure you might have noticed is the dose I put here for glibenclamide. Now, so basically JM had a mutation in KCNG11, so he then went on with the glibenclamide treatment. Now, what is the fascinating biology here is that these people need really high dose of glibenclamide. So about 3 to 5 fold than what we use in type 2 diabetes. And on average, they need about 0.5 to 0.8 milligram per kilogram per day. And they don't really get any side effects. They don't get any severe hypoglycemias. But what really they get is that their life is transformed. They completely come off of the insulin, no more testing, no more hypos. They can do any exercise, diet, anything you want, any trips abroad or vacations, sleepovers, cricket, which he used to love, he went back in it, and his life was completely transformed. So it was just a simple question: when do you get your diabetes? And if you just ask that question, you found those patients in your clinic. How long the effect of this treatment lasts? Well, the Palm in Exeter followed some of those patients for up to 10 years and showed that actually 94% of people who had the mutation in KCNG11 actually maintained on sulfonylurea. Only 6% who had to have some insulin treatment, and they almost all required some basal insulin in addition to sulfonylureas. And here is their long-term control, and you can see before on insulin and then sulfonylureas, and for 10 years their HbA1c remained exactly the same. And this is the dose of their sulfonylureas. And as I said, it's roughly about 0.4 to 0.2 they need for the life. So it is not only useful that particular time, but the effect lasts for 10 years. And I'm sure the longer data will go on, we'll have a better understanding. And particularly, I'm predicting that almost all will respond for many years. So this is my take-home message one. If you really want to find your diabetes, ask one single question. It's like Böhmke's Bugsy, nothing fancy, just ask, when do you get diabetes? If they got under 6 months, the answer would be always do genetic testing, because 40% of those children would have this mutation in KTP. And if you find those, you can transform their life. But remember, they need a high dose sulfonylureas. Now, the good thing is that we offer in Exeter the free testing for any kids who diagnosed under 6 months on a research basis. So if you have those patients, you can write to me, or you can go on a website and you can send the patient's blood to us, and we will do the testing for you. Okay, so let me talk about this second patient. Now, this is a slightly patient which you will come across more often than not. He's a JN, he's 34 now. He's got diabetes when he was 19. His BMI was 22, so wasn't particularly heavy, not even from the South Asian BMI point of view. He was treated as type 1 from diagnosis on an insulin basal bolus therapy, and the HbA1c was not great. What was interesting is when you kind of talk about this patient a bit more, you realize that actually he was missing insulin, but he wasn't getting the DKA or having any problems. And then you kind of did more digging and you find out that his mother and his maternal grandmother also had diabetes. So really, what type of diabetes he's got? On the face of it is a bread and butter type 1 diabetes, but is it really? He's got some family histories there. He's missing insulin without any problem. He was could it be type 2? Well, probably less likely with the BMI, even with the South Asian standards, as I said. What about monogenic diabetes? Now, this can be MODY, as you can describe. It's a thin, it's early onset, and it's got dominant history. So how do you really pick the people for genetic testing? What things can help you?
Well, it's a very interesting this thing, but your time is almost over. So if you
is it 15 minutes already?
Yeah. So, but you can take another 2 minutes to,
because I thought I started at 12:18 on my clock here. Okay, so well, but basically you got two things to do. One, which is C-peptide, which you can do, which can help you type 1 and MODY. Or second thing you can do is you can actually do antibodies, which is hardly ever seen in MODY patients. So if you can really use them to exclude patients from genetic testing. If they don't have antibodies, this is the new test we developed in Exeter, where you can test their common genetic risk and help you to discriminate between type 1 and MODY. So I'm going to stop that. I'm going to show you that he basically had 1 alpha MODY, HNF1 alpha MODY, and he was antibody negative and a lot of C-peptide. And how do you treat them? Well, you can treat them with low dose sulfonylurea. So this is the only randomized trials which shows that the people with HNF1 alpha MODY were 5 times more sensitive to sulfonylureas. If you have another type of mutation, which we call glucokinase MODY, that don't need any treatment. So essentially, it does matter. He came off from insulin and his control was much, much better. So this is the second take-home message. I'm going to stop there, is that if you have a patient who is normal weight, had a family history of diabetes, particularly the HbA1c at diagnosis were not as high as we shown in the recent study, and if they're in non-insulin treated, then you really have to suspect MODY in those cases. But if they're insulin treated, but they have this lack of antibodies and C-peptide, then those ones you must consider MODY. If you find 1 alpha and 4 alpha MODY, then they need low dose treatment. You stop insulin completely. And if they have a glucokinase MODY, then it doesn't need any treatment really. And I'm going to stop there, and I'm just going to say to you that in conclusion, really all you need is a simple history. If they have neonatal diabetes, they definitely need a genetic testing. If they have a MODY, which is filling in certain simple criteria, you can consider MODY. And then finally is the recessive, which I didn't have a time for today. Sorry about that. Where if you have a young onset diabetes with any additional features, then they also need a testing. And both of these we offer in Exeter on a research basis. So feel free to contact me anytime, and I'm happy to help you on those. So I'd like to thank the organizers, particularly Bansiji, for the invitation, my mentor, Andrew Hattersley, and all the team we have in Exeter. Thank you very much.
Thank you, Kashyap. It was a fantastic talk. I'm sorry my video is, I'm not able to show face here because I don't know why the video is not getting started. But the fantastic talk which you had given. But just to share with you, I have also similar type of two patients where they were taking insulin. Rather, both the patients are from medical school. They were doing their MBBS, and one guy had come with me in his postgraduate, and other is a girl. And both of are irregular in irregular. They never been admitted with diabetic ketoacidosis. I stopped their insulin. They are on sulfonylurea. Unluckily, we had sent their genetic testing also. Both, not only for the 12, even for 18. We have at Bangalore as well as at Chennai, you know, with Madras Diabetic Research Foundation. And unluckily, the report came negative. But these patients are autoantibody negative. They are having C peptide, which is not so low as we were not expecting that much. And the point is now, Kashyap, is it there are few more mutations which we are not able to diagnose, or there are few more genes which are responsible for it, or are we collecting some type of such data only on basis of clinical cases? I mean, each and every patient may not able to get the genetic testing, but still in India now we have a ICMR in India, and one more Mohan had started with one project with Serdia. I am the part of it, and across the country we are going to collect the data. So there is a MODY score, you know, that we can calculate as per that, and we can suggest. But if similar type of patients and cases are there, we can just compile all the cases, and some of the patients we may not get the genetic testing routine in those 18 parameters or 18 this. But are you doing for other than these 18 few more genetic testing?
Yes, I think what you say is absolutely right, Bansiji, is that the selection on these clinical features finds some atypical patients, right? But we've not been able to find a cause in substantial proportion of it. I think it depends really how you define the phenotype. But let's say it's about 10 to 20% of cases, and you're absolutely right. So I do some gene discovery work, and we did find some new gene a couple of years back. It is very hard to do it, but I think if you have those patients, and I think if you do think that there is no known cause, please feel free to send the samples to me, and I can do whole genome sequencing and then kind of look for the new causes that we can find. So I think you're right. You're absolutely correct. There are some patients we can't find diagnoses, but I think those are the one very interesting because we might find some interesting biology about it.
So, I mean, how we can send the sample? Because does it require any sort of the government approval? Because blood is sent from India to outside the country. I don't know, because, but Kashyap, if you remember last time also we talked about it, and I could not find, what is the best way to send the sampling to you?
So let me tell you that we get a lot of samples from India, particularly for neonatal diabetes. So absolutely no, what is a problem is sending a research samples. So if you send like a bulk of like 100 samples, let's say we want to do a study where we collected about 1,000 DNAs from India and we want to do this and that, then those are not allowed. But for diagnostic testing, samples are allowed to send it. So if you send it just a normal EDTA tube, like just 5 ml of blood in the post with the form. And
so then I will send you for those two patients. First, I will send you their complete reports.
Yes, absolutely.
Their history and their genetic testing, which has already been done in India, and then I will send you the.
Yes, I mean, I think it's often better to send their parental samples if you have, because I think those helps to kind of narrow it down what we need to do.
We can do, because they have the parent, grandparent, three generations are possible.
Yeah, so if the more
and
more
both of
the
them are
merrier.
medical students.
Yes,
both of them are medical students.
Yeah, absolutely correct, Bansiji. So please do send it. The one you can't find the diagnosis and we're not quite sure, do send it to us, because what happens is that our panel, so the thing is, a lot of people use a panel which has only 7 genes on it. We on our panel has a 40 genes on it. So often what happens is that we get an extra diagnosis just because we test more genes.
Okay, that's great.
But then most of the time, it really are the ones we don't know the cause. And those ones are really fascinating because you find some lovely biology. So we found one gene, it's called RFS6, which is causing a dominant disease. And we just found 2 more recessive genes, which just been published. So I think there are more to find. So if you have patients, do send it to us and we can do something about it.
Thank you, Kashyap. Just to introduce, I have a close friend with me, Dr. Anuj. He is also there in the panel. And Kashyap, to introduce Kashyap belongs to Ahmedabad, and Anuj, he's at the leading center of the world where he's sitting just now, and they are the authority in the world as far as monogenic diabetes is concerned. I met him last time, Kashyap, at Diabetes UK meeting, and we have Dr. G. Vijay Kumar, Padma Gulati. So just I'm introducing all of them to Kashyap Patel. So we will have, we would like to have you more and more often in our meetings. And now I hand over to the mic to the chairperson next. Thank you.
Hi, Kashyap.
Thank you so much, guys. I really appreciate this. Thank you.
That was wonderful lecture, Dr. Kashyap. Now I would like to invite Dr. Anuj Maheshwari and to introduce him. He is Vice President of RSSDI as well as Governor-elect American College of Physicians India chapter. He is having a very good introduction, but I will cut short it because the time is already running out. And he's going to speak on hypertension in diabetes at deadly duo.
Good that you have not wasted much time in the introduction. I thought 5 minutes of my talk you will take from that. So first of all, thanks to my dear friend Dr. Bansi Sabu for inviting me here in DIACON. I'm going to talk with you in next 15 minutes on the hypertension in diabetes, the deadly duo. We know that whenever we talk about the hypertension in diabetes, it is not 1 + 1, 2. It becomes 1 + 1, 3. It is associated with 57% increase in all-cause mortality in diabetic patients. And unfortunate thing is that we are not being able to control blood pressure in 85.1% people in diabetic. Only 15%, less than 15% diabetes individuals are able to keep their blood pressure less than 140/90, and only 3% of them are able to keep their current recommendations of 130/80, what has been given by the American College of the Cardiology and American College of the Hypertension regarding control of blood pressure in diabetes individual. It is more common in the individuals with diabetes than general population, with estimates of the prevalence of hypertension in diabetes ranging from 40 to 80%. In India, it is approximately 33% in the urban class and 27% in the rural class. And if combinedly, it comes around 25.3% prevalence of the hypertension in India against the diabetes prevalence, which is 7.5% to 9% ranges according to different studies. So we can see that 3 times people are more suffering with the hypertension as compared to the diabetes. And once these two come together, they become the deadly duo because of multiple mechanisms are there which are being shared by both the diseases, which takes towards adverse cardiovascular outcomes. Both of these diseases are sharing the common soil and leading towards the adverse cardiovascular outcomes as well as towards the microvascular disease through the hyperglycemia, through the RAS, immune activation, oxidative stress, inflammation, and miRNA. At the same time, accumulated glycemic end products are also important reason for causing these diseases. If we talk about the phenotypic characteristics of the patients of hypertension, those who are also having the diabetes, we find there are a lot of similarities. And the important phenotypic characteristics which are leading towards the hypertension in diabetic individuals are the macroalbuminuria, then followed by the microalbuminuria. Of course, there may be the myocardial infarction. The history of any cardiovascular adverse outcome makes the person more prone for getting the hypertension if the person is already having the diabetes. And this is in addition to the familial hypertension, this is in addition to the obesity and increased age, as well as diabetes duration also plays an important role in this. So patients with diabetes have more isolated systolic hypertension. They have enhanced variability in blood pressure. They are prone to develop orthostatic hypotension because of the this autonomic dysfunction. They have got a hypertension which is more resistant to the treatment. They have less reduction in nocturnal blood pressure and higher baseline heart rates than their non-diabetic counterparts because of the, again, autonomic dysfunction. Blood pressure control in these patients present a great challenge because the target blood pressure is quite low and the response of the treatment is often poor. So cerebrovascular disease also becomes an important and adverse outcome of these hypertensive individuals, those who are having the diabetes also. Mainly systolic hypertension they develop and directly related to the stroke in all age groups. The presence of the diabetes more than doubles the risk of the stroke in patient with hypertension. Lowering blood pressure in patient with hypertension and diabetes reduces the risk of the stroke by 44%, which is a very significant reduction in the risk. When we talk about the diabetes, a salt-sensitive hypertension, again, it becomes very important, especially in the diabetic individuals, because they are having the high glomerular blood pressure and a flatter pressure diuresis curve. Hyperinsulinemia caused by the insulin resistance is also involved in accelerating the reabsorption of the sodium from the renal tubules. Excessive salt intake inhibits the nocturnal blood pressure reduction. Again, we know that hypoglycemia also leads to the hypertension, adverse cardiovascular outcomes, including the arrhythmia, not only the hyperglycemia only. A number of studies has shown the relative risk of the cardiovascular disease occurring during serious hypoglycemia to be 2.05-fold more as compared to those who are not having that. So we could see that the standardized association of the 10 millimeter of mercury systolic blood pressure reduction with all-cause mortality, microvascular adverse outcomes, which has been stratified by number of studies which has been done in the past. If we go towards the chronobiology, we see that morning hypertension has significantly higher frequency of the development of nephropathy and retinopathy. Frequency of the development of cerebrovascular disorders also significantly higher. The prevalence of the microvascular and macrovascular events in hypertensive individuals as well as in the normotensive individuals or those who are not having morning hypertension has been compared, and it could be found that those who are having the morning hypertension, they were clear-cut on the higher risk of developing nephropathy, retinopathy, as well as cardiovascular adverse outcome. We could see the ACE inhibitors and ARBs have been found to be having better renal outcomes as compared to the other antihypertensive therapies, especially the patient those who were having the proteinuria, may it be micro or macro albuminuria. More intensive blood pressure lowering improves the cardiovascular outcome irrespective of the baseline systolic blood pressure and atherosclerotic cardiovascular disease. We could see that RAS blockers have been found to be better than calcium channel blockers as compared to the cardiovascular adverse outcome. Relative risk was much higher with the other calcium channel blockers as compared to the RAS blocker. When it has been compared with the diuretics, again RAS blockers have been found to be the advantageous sides. Similarly, we could see the comparison with the beta blockers, especially in the patients of the cardiovascular mortality and myocardial infarction, angina, have been found to be better performance with the RAS blocker as compared to the beta blockers. Effects of the many anti-glycemic drugs. Although we all know that anti-glycemic drugs plays a very important role simply by reducing the blood sugar level, they also keep a control on the hypertension. But SGLT2 inhibitor have been found to be the wonderful anti-glycemic drug which controls the hypertension through its other mechanisms, including the osmotic diuresis also. So beneficial effects of the SGLT2 inhibitor has also been found in the hypertension patient, those who are also having the diabetes. It decreases the uric acid, decreases the glycated hemoglobin. It has got the beneficial effects on the lipid profile. It has got the correction of the blood pressure, reducing weight, reduces the inflammation, arterial stiffness, myocardial fibrosis, reduces the sympathetic nervous system activation, decreases the ventricular arrhythmia, and of course, it reduces the oxidative stress too. So ADA has recommended in 2020 guidelines that we must not forget that Screening and diagnosis is a very important part of the hypertension treatment, especially in the diabetic individual. Those who are having the blood pressure 140/90 or more than that, they should be confirmed it again, including multiple times of their clinical visits. At the same time, they must be kept for the home blood pressure monitoring. Those who are having higher atherosclerotic cardiovascular disease risk or already having the atherosclerotic cardiovascular disease, they must be kept for a tighter target of the hypertension control that is less than 130/80. Those who are having it less than 15% risk of the coming 10 years atherosclerotic cardiovascular disease, they can be given a liberty to less than 140/90 blood pressure. In pregnant patient, it is recommended to be kept less than 135/85 millimeter of the mercury. It says, ADA says that if your blood pressure is more than 120/80, lifestyle intervention should be started at that time, and dietary approaches to stop hypertension should be initiated with a significant improvement in the physical activity. ADA 2020 guidelines again says if the patient with confirmed blood pressure in office 140/90 or more than that, it should adopt lifestyle therapy in addition to the one drug treatment from the pharmacological therapy. Patient, those who are having their office blood pressure 160/100 or more than that, they should adopt the lifestyle therapy together with the dual drug approach of antihypertensive treatment or a single pill combination of the drug demonstrated to reduce the CV events in patients with diabetes. ACE inhibitors or ARB must be initiated if the urinary albumin creatinine ratio is 300 milligram per gram creatinine or more than that, or it is between 30 to 299 milligram per gram creatinine, then it must be considered as a first choice of the antihypertensive drug. For patients, those who have been treated with an ACE inhibitor, ARB or diuretic, serum creatinine, eGFR ratio and serum potassium levels must be monitored at least once in a year. ADA 2020 recommendations for the treatment of confirmed hypertension in people with diabetes has shown that if your patient is having the blood pressure more than 140/90 but less than 160/100, you can start on the one agent. But if it is having the more than 160/100, the patient should be started the two agents together with the lifestyle modification. If the albuminuria is there, then preference should be given to the ACE inhibitors and ARB. If the albuminuria is not there, then you can choose any of the drug which is being given, including the ACE inhibitors or ARB. Still, the ACE inhibitors and ARB should be given the preference there. But if you are going to choose two agents, one agent must be ACE inhibitors or ARB, another agent you can choose any other one. Treatment well tolerated, has got the response, continue the therapy. If not meeting target, you are free to add the third agent. If getting the adverse effect, again consider change to the alternative medications, whatever has not been used by that time. If you are getting the adverse effects, again you can switch over to the medication which has not been used. Again, assess the blood pressure control and adverse effect. If it's still not meeting the target and adverse effects are there, then you must send your patient for the specialized center. In 2017, American College of the Cardiology and American Hypertension Association has shown that in adults, those who are having the diabetes and hypertension, antihypertensive drug treatment should be initiated at the blood pressure of the 130/80 mm of mercury, and it should be targeted for the treatment goal of less than 130/80 mm of mercury also. In adults with diabetes and hypertension, ACE inhibitors or ARB may be considered in the presence of the albuminuria, which is recommended by the ACC-AHA guidelines also. So people with high blood pressure, diabetes are those people, those who are developing this condition because of their poor lifestyle. If you change the lifestyle, those conditions will leave. This has been broadly accepted by across the world. Thank you very much for your kind listening. Hope I completed in time.
That was fantastic overview of hypertension and diabetes, sir. And I think we are already running out of time, so we will not take discussion or questions at this stage. And straightway, I think we'll go to the next lecture. Over to Dr. Padma for next lecture.
Yeah, so we are moving on to the next topic, metformin controversies, a review by Dr. Vijay Kumar. And his presentation is again going to be for 15 minutes, and then we'll have a session of question answers collectively at the end. So over to Dr. Vijay Kumar. He's He's from Apollo Specialty Hospital Diabetes Medicare Center, Chennai. He has many papers published in various journals, and he's got the Best Doctor Award from Dr. MGR Medical University. Dr. Vijay Kumar, please.
Dr. Vijay Kumar, yes.
Yeah. Dear chairpersons and co-speakers of this particular session, it's a wonderful session. Namaste and good evening to all of you and all to the delegates as well. And my heartfelt thanks to my good friend, Dr. Banshi Sabu, who has given me this opportunity. In the next 15 minutes, it's a very important and very novel topic that is given to me. Metformin controversy is a review. You know, first love never dies, isn't it? So it is 60 years, more than 60 years since metformin has been used, and it's beyond glycemic control. You can see that it is usefulness in PCOS, in cancer, in aging, microbiota, cardiovascular disease, pregnancy, you name it, everything, you know, including type 1 diabetes. They're supposed to be having a benefit, especially when they have insulin resistance along with that. It's going to be supposed to be useful. So it's something extraordinary, you know. The drug is such an extraordinary one. No doubt why every association in the world has said that recommended metformin as a preferred initial pharmacotherapy for type 2 diabetes. Now, you know, it's a very old drug. It is more than 65 years old by now, but with a lot of new tricks, if you can see that. Straight from the way it acts and the metformin in cardiac events, in pregnancy, it may cause B12 deficiency, lactic acidosis, you know, kidney, and so many things, you know. But it is still, after usage of 65 years, it's still mired with enough controversies and debates. And so the question often, of late, recently, in the last 1 year, asked is that, should metformin remain as a first-line therapy in type 2 diabetes? Is change overdue? Now, do you think we need to change it from the first-line therapy that metformin has been all these years? Well, let us review the facts. First, let me look into critical appraisal of metformin data in the form of metabolic parameters, how it pathophysiologically, glycemic durability, CV outcomes, if there's any benefit at all. Now, if you look into the insulin sensitivity, because basically metformin, all of us know, is an insulin sensitizer. Metformin does not improve muscle insulin sensitivity. You know, by it is measured by euglycemic clamp in type 2 individuals, and in the absence of weight loss. In the weight loss, you can see that it doesn't improve the muscle insulin sensitivity. But how it works is basically it reduces the hepatic glucose output, where it sensitizes the hepatic tissue, but no skeletal muscle tissue. This is what we need to understand. Now, way back in 1998, you know, the Lancet has published that effect of intensive blood glucose control with metformin on complications in overweight patients with type 2 diabetes in UKPDS. What it has been, if you can see the statement that again, since intensive glucose control with metformin appears to decrease the risk of diabetes related endpoints in overweight diabetic patients. Mind you, that is in overweight diabetic patients, and is associated with less weight gain and fewer hypoglycemia than our insulin and sulfonylureas. So it may be the first line pharmacological therapy of choice in these patients. So the controversy here is that, is it only for overweight and obese patients, or it can be used for every patient? And then maybe is a catchword there. Now, metformin is a very effective anti-hyperglycemic drug, but even sulfonylureas are equally effective and durable as well. let us compare with another insulin sensitizer, pioglitazone. If you look into that mean HbA1c reduction, both are equal. 1.41 versus 1.5. Fasting blood glucose reduction equally good, 205, 203. But look at the HDL and fasting plasma insulin. There is no change with metformin, whereas by using glitazone, another sensitizer, compared to metformin as a sensitizer, there is a reduction in plasma insulin and increased HDL as well. Comparatively, it is better with pioglitazone compared to metformin. So there's been controversy that it may not be effective as a good insulin sensitizer. Now we have also the latest drugs such as GLP-1 receptor analogs, SGLT inhibitors are seems to be more superior metabolically compared to metformin that it has shown. As far as the durability is concerned, all of us know that a monotherapy with metformin at the end of 5 years, if you can see that it is inferior to thiazides. No doubt why in most of the studies, like including UKPDS and ADOPT trial and other studies, have clearly shown that effect of metformin on HbA1c, because metformin does not affect the muscle insulin sensitivity or beta cell function. Following an initial decline after metformin administration HbA1c, it rises progressively in type 2 diabetic patient. This is the fact that is happening. But still, I would like to say that please don't think it's a negative information that I'm giving. A metformin in combining with other drugs is a very good combination that we can think about. We cannot imagine metformin without able to control diabetes without metformin. Now, with all those things, if you can see that, okay, look at the beta cell preservation. And this is the most important thing. Suppose, in the natural history of diabetes, over the time, the beta cell numbers comes down. All of you know that at the time of diagnosis, only 50% of the beta cells are available, and over the time they also get reduced. One of the reasons why beta cells go either to apoptosis or to hibernation is because of the glucotoxicity and as well as the lipotoxicity of the beta cells. So metformin and TZD were able to give both reduction in glucotoxicity, reduction in lipotoxicity, and so that it rests the beta cell. This is a very, very important thing. So though it is beta cell sparing, but it is still a useful drug in preserving the beta cells. Now, whenever we are trying to treat diabetes very less than 7, we always get into hypoglycemia and also increase in weight gain that has been known that. Now, do you think that only metformin, which is weight neutral drug, which is available? Yes, we have glitazones, though they have increase in weight, but better insulin sensitizer. Glutins are also weight friendly. Alpha glucose is weight friendly. Again, they can reduce the weight as well. And GLP-1 analogs as well as SGLT inhibitors are there to reduce the weight. So as far as weight is concerned, there are superior drugs to metformin. Now, as far as the cost is concerned, yes, every time, every part of the world, people say about the cost of metformin is a big advantage. Even sulfonylureas are equally cost effective in our country. Nevertheless, though the debate, the controversy has been there, what we need to understand is that metformin is beta cell sparing. It is in fact beta cell protective. It is weight neutral. In a few patients, weight reduction has been there. And it doesn't disturb the metabolism. Though you can see that it may not do too many things like other sensitizer, but it is still a metabolic friendly. It doesn't disturb the metabolism. And it's a very, very good anti-hyperglycemic drug. So I think we need to rest the controversy about the critical appraisal of the metabolic factors to rest now as far as metformin is concerned, but still is a good drug to think about. Now, whenever we talk about any molecule, anti-diabetic molecule, we always think about safety and protection to the heart. Now, the UKPDS has always been projected to state that, okay, metformin is very cardio-friendly, it reduces the microvascular disease, apart from glucose-lowering medication. But if you can see that in 2009, Diabetology is saying that however, the sample size was relatively small by current standards in UKPDS. So these findings require confirmation. This is a controversy that has been brought in 2010. Apart from these things, there are several meta-analyses which have done. At least I will show you two meta-analyses. You can see here one meta-analysis regarding the cardiovascular events and mortality. If you can see that the 35 clinical trials, about 7,000 plus patients in the metformin group, and control group is about 11,300. So that is comparator, metformin versus comparator. There is no CV benefit. And there is overall effect on CV events, no significant benefit. Benefit depends on duration and age. So it has been like that. And another meta-analysis regarding the all-cause mortality and CV mortality in about 13,000 patients out of 13 trials has clearly shown that the primary endpoint of all-cause mortality, CV death, and secondary endpoint of myocardial infarction, stroke, congestive cardiac failure, peripheral vascular disease, leg amputation, microvascular, all those things, no effect on primary and as well as secondary endpoint. So there seems to be no benefit on that. And the same thing, even the several one more meta-analysis shows that it has got no benefit. But mind you, there are some studies which have shown, especially in UKPDS and as well as that's a Harton study, there seems to be slightly favoring in metformin. So overall, if you can see that it is neutral, it is not cardio, it is cardio safe. That's what we need to understand. So the language should be that it is cardio safe, and we need not worry about using metformin, so that it doesn't increase any cardiovascular. If it's not cardioprotective, reduce it. Now, there are several other benefits that by using metformin. You can see that several inflammatory markers such as plasminogen activator inhibitor, fibrinogen, C-reactive protein, and a platelet addition and improvement in blood flow, all those things are benefited with metformin. So we expect the metformin to have some cardiovascular benefit as well. But though it has not been there, but you can see that these are the benefits that we need to consider for use of metformin. As far as the heart failure is concerned, if you can see that compared to the other sensitizer glutazone, you can see that definitely the metformin usage when you don't use any insulin sensitizer, you can see that metformin is beneficial in reduction in outcomes after somebody is admitted with heart failure. No doubt, not all antibiotic agents are equal in their ability to CV risk. Only GLP-1 receptor analogs, SGLT inhibitors have been very beneficial, and rest of the medications that includes DPP-4, sulfonylureas, insulin, and metformin, no effect on CVD risk, but they are also cardio-friendly, except saxagliptin, they are cardio-friendly. That can be DPP inhibitors is cardio-friendly. That's what we need to understand. Right? Then, if you want to look into, though it's a small number in UKPDS, look at the benefits that we can get of metformin. So we can see that any diabetes-related point reduction in 32%, diabetes-related deaths by reduced by 42%, all-cause mortality reduced by 36%, myocardial infarction by 39%, and microvascular disease by close to 30%. In compared to sulfonylureas, you can see that the more benefit. The comparator, you just look at the comparator of metformin. So friends, I would like to suggest that metformin is cardio safe for sure. Whether you expect benefit like what you see in UKPDS or not, it is a cardio safe. Don't worry about using it. Now, the other controversy that we have in many tricks that it has got is metformin in pregnancy. In metformin crosses the placental barrier, and that may affect the fetus. That has been the controversy that has been thought about and debated all along. But whereas in MIC trial, you can see that the gestational diabetes, where the metformin or insulin has been used for treatment, in women with gestational diabetes mellitus, metformin alone or with supplemental insulin is not associated with increased perinatal complications compared with insulin. The woman preferred metformin to insulin treatment. This is what has been the conclusion that has been come out. Now, later on, people started talking about metformin. The controversy is that what happens this fetus is exposed in utero to metformin, what happens after they give birth? Now, then what they have done is that in the first follow-up of the mixed study, infants of women with GDM who have been exposed to metformin or insulin during pregnancy, these fetuses have been examined after 2 years of age. What has been found is that the offspring exposed to metformin in utero has increased subscapular and bicep skin folds when compared with the unexposed infants, while total body fat was similar to every child. This hypothesis that a possible benefit as the signal of healthier fat distribution for those infants who have been exposed to metformin in utero. So again, the controversy is laid to rest as far as pregnancy and the fetus is concerned. Now look into the lactic acidosis. This is another contentious thing. Lactic acidosis by gonads, especially in hypoxic conditions, and renal insufficiency as well as hepatic insufficiency. When time and again it has been raised in debates. Now, here is one a systemic review and meta-analysis that is published between January 1959 and 2002, where they have taken about pooled data of 194 studies in about 37,000 patients in the metformin group or in 30,000 patient years in the non-metformin group. What has been found in this particular concluded is that there is no evidence to date that metformin therapy is associated with an increased risk of lactic acidosis or with increased levels of lactate compared with other anti-hyperglycemic treatment. This says a fantastic conclusion of safety about metformin that has been given. Now, all along, okay, this is in general population. How about in renal insufficiency? Again, this is a retrospective cohort study. What they have been found is that overall lactic acidosis rate for patients on metformin in this study was within the range of rates reported in the literature of patients with type 2 diabetes. No significant difference was observed among patients with normal, mild, moderate, and severe renal function defects. This is how. So again, the lactic acidosis part of it, let us keep it to rest. Does metformin protect the kidneys like others can? Because in view of the latest drugs like the SGLT2 inhibitors and as well as GLP-1 receptor as well, the genoprotective effects have been very well established. We cannot compare metformin to that. But one thing is that metformin, you can see that the recommendation says that metformin, according to the renal function as estimated by glomerular filtration rate, if the EGFR is, depending on the EGFR is less than 30, you should stop the treatment. 30 to 45, half dose, or don't initiate. 45 to 60, yes, you continue, and then but you be cautious, very important, because increasing monitoring of renal function every 3 to 6 months is necessary whenever you're trying to get into giving the patients with renal insufficiency. Avoid any nephrotoxic drugs and stop metformin if dehydration arises. Look at Indian conditions where the NSAID drugs are left and right used without prescription, and also we have hot, humid conditions, and where the dehydration is very common. We need to be extra careful whenever we are trying to treat with metformin. This is not there has been a lot of change, in usage of it. You can see that there have been a lot of vetting has been done to state that we need to change the guidelines for use of metformin, but we need to be extra careful. Now, are there any renoprotective effects of metformin, like what we see with SGLT2 inhibitor? No, in this particular study, they suggested that apart from anti-hyperglycemic, metformin could also decrease AG formation, advanced glycogen products, which are implicated in vascular complications in diabetes by reacting with alpha dicarbonyl compounds. So this is relevant to a potential clinical use of metformin in prevention of diabetes complication by inhibiting carbonyl stress, that is antioxidant effect of metformin. This you need to take that. Though we have in renal insufficiency, be careful, but it seems to be having a renoprotective effect before they develop renal insufficiency. Though the guidelines say that be careful in using, and as American Diabetic Association said that less than 30 to be contraindicated, less than 45 you need to reduce the dose, 45 to 60 you have to be carefully watching, more than 60 no contraindication. So should restrictions be relaxed for metformin in kidney disease? No. We should never again compromise on safety because of the dehydration and nephrotoxic effects of other drugs that can happen. So it's a protective drug before you develop a renal insufficiency. But once you develop a renal insufficiency, you need to be careful. So this is a controversy, and this is the review and explanation that we can do as far as metformin is concerned. Now, in NAFLD, now there are several studies to state that metformin has no significant effect on NASH, like pioglitazone is superior to that. So it can be used in FLD without any hesitation. It's not hepatotoxic, but don't expect any thyroid. So the argument and the controversy is that whether it should be used in metformin or not, it can be used, but there may be no reduction in the fatty liver. That's what you need to say. As far as the old age is concerned, let us not worry about that. As long as the EGFR is normal or fairly normal, we can go ahead and using the metformin even in older. So that controversy also has been settled down. Now the latest controversy, this is just in April or May, we had that the extended release metformin can cause cancer. It has become so popular in social media as well. This is basically because of in extended release preparations, it contains what is called as NDMA. We should not it should not cross the acceptable intake of limit. That's what has been done. But mind you that most of the companies, except a few, one or two companies even in the country, they have NDMA levels have been slightly increased, about 2 or 3 companies, not more than that in our country. And most of the other metformins are very safe. We need not worry about the controversy about the NDMA content, and it can be carcinogenic, which US FDA has come out with stating that. And one more thing is that understand that another statement FDA, physicians are suggested not to stop the metformin which you already used. Till then you get a replacement where NDMA levels are within acceptable limits. So this is a statement. So again, the controversy as well as the explanation for the metformin has been there. So you can contradict, you can contradict, you can. What I would like to suggest to all my friends, the delegates, is that look into the situation of the patient and wisely use metformin. But still, metformin is a wonderful drug to be used. We cannot imagine good control of diabetes without metformin. Look into the contraindications more before indications. Thank you for patient here.
That is fantastic video of metformin, sir. We are running little late for timing. So I will straight away invite our next speaker, Dr. Dakshita Pandey. She is going to talk about glucose data for personalized diabetes management. To introduce Dakshita, she is our respected and renowned senior from Nair and Raja Hospital, and she is presently diabetologist from Mumbai, and she is director at the Conquer Diabetes Center, which is an ISO 9001 Diabetic Care Center. She is also founder member of our group, that is United Diabetic Forum. And over to you, Dr. Dakshita.
Thanks, Rahul. Thank you so much, chairpersons, all the chairpersons and delegates. It's a privilege to be part of this scientific feast. A big thank you to Dr. Vanshi Sabu for making me part of this. One second. Making me part of this. I want to see the presentation. A big thank you to LifeScan as well. And a big thank you to Dr. Vanshi Sabu for making me part of this presentation. So without wasting time, I would just go into my presentation. So topic given to me today is glucose data for personalized diabetes management. We all know that, one size doesn't fit all. When it comes to shoes, clothes, we are always particular then it should be perfect with our needs. So whenever we are wearing perfect shoes, our feet are comfortable. Whenever we are wearing perfect size clothes, we look smart, and everything, the overall result is very good. So when it comes to our delivering diabetes care to our individuals with type 2 diabetes, type 1 diabetes, for that matter, any individual with diabetes, we have to have a customized approach. We should not have a very rigid, suboptimal approach when we are treating our patients. We are still treating our patients with a glucocentric approach, which is right. With respect to our guidelines, landmark studies, we are always, a fan of that number, HbA1c less than 7%. And what has happened in the past, from 2005 to 2018, there are numerous technological innovations, but there is absolutely no change in percentage of patients. There is no increase in number of patients who are less than HbA1c, which is actually our target. Now let's see what are the challenges in diabetes management in last few years. There is definitely ever-growing number of lot of diagnostic and therapeutic options, so many novel drugs, so many novel insulin delivery system, insulins and monitoring devices, but still our people with diabetes are not able to achieve the treatment goals. First thing, the guidance maybe is not sufficient right now from our side as well. What is the option? Option is there has to be a shared therapeutic decision making process. We have to involve physician and a patient both as a team, and we have to integrate digital tools. In this era of pandemic, we have realized the importance of digital education, digital tools, telemedicine. So we have to integrate digital tools in the patient education process, in the monitoring process, and we have to analyze and visualize that data, and we have to incorporate that data for management of type 2 diabetes successfully. Now, what is the real world approach? Personalized diabetes care is definitely a real world approach where we are catering to specific and unique needs, preferences, and values. We have to have an individualized approach. And what is this individualized approach? American Diabetic Association, EAST, and all the numerous professional bodies, all the bodies have endorsed a fantastic approach. It has to be a patient-centered approach. It has to be a personalized approach for the successful management of type 2 diabetes or type 1 diabetes as well. Now let's see, whenever we are saying personalized diabetes management, few points we have to consider. First is clinical characteristics, second is personal characteristics, and we have to look into the last but not the least, psychosocioeconomic factors. First thing, patient's age and life expectancy. We cannot have a standard approach for all the patients. If the age is young, life expectancy is definitely more, the exposure to hyperglycemia is more. In view of metabolic memory legacy effect, we have to have a very tight glycemic control. But if a patient is with long-standing diabetes, age and presence of comorbidities, if they are present, then definitely the A1C targets can be little relaxed. Duration of diabetes matters, same with what I just mentioned. Glycemic control history is very important. Whenever we are flipping through the file, we are seeing the A1C control, and then with good history, we have to pinpoint what is the adherence to the therapy or treatment inertia, or maybe patient some depression factor. What are the points which are responsible for bad glycemic control? We have to correct those factors. Comorbid conditions, vascular conditions, definitely patients with renal impairment, or patients who have long duration of diabetes, who have autonomic neuropathy, risk of hypoglycemia unawareness. These are few clinical characteristics we have to pinpoint whenever we are starting treatment with patients. Now, few personal characteristics. So every patient cannot be the same patient. What are the patient's preferences, his lifestyle, his health beliefs? Whenever we are educating patient, in education, busting the myths is very important. If you have to have a very successful treatment in your type 2 diabetic patients, health beliefs, if they are not if they are myths, you have to bust those myths, and we have to have a dedicated diabetes educator if possible with us to pinpoint these factors. Something like treatment inertia, injection inertia. If patient requires injectable, if patient requires insulin therapy, we have to see to it, that we help our patient to overcome that inertia, and we help our patient in adherence of the treatment. Now, what are the psychosocioeconomic factors? Patient who is having complex treatment regimen for oral glucose lowering therapy, injectable therapy, he has to have a good support system for his nutrition management, his exercise management. So support system history is very important. Psychological status: 50% of our type 2 diabetic patients, or for that matter type 1 diabetic patients, are depressed. We have to first treat that depression and then go ahead with the treatment. Economic issues, I don't have to elaborate on that in our Indian Asian setup, but definitely these are few factors we have to look into. So after analyzing the clinical and the history, what are the successful steps for personalized diabetes management? First thing is patient education. I am so happy that I am allotted this topic, because I believe in strong patient education foundation and patient empowerment. So structured patient assessment and training should be done at the first stage. Then there is structured with respect to individual therapy. Then documentation of all relevant patient information and progress should be done. This documentation is very important. The history point of view, patient's blood sugar point of view, because this is our Bible. This documentation of information is what is going to help us in future to manage that patient. Then there has to be a systematic approach in analyzing this situation, the reports and blood glucose management. And there has to be a very important point, joint decision making. It has to be a shared decision making between healthcare professional and a patient, so that we can have a successful individualized treatment strategy. And lastly, treatment effective analysis and necessary actions should be taken for adherence of the treatment and the success of the treatment. The last line of this slide is very, very important. SMBG is a very powerful tool of patient education, behavior modification tool, but it is absolutely meaningless if it is not structured. Everyone knows that and everyone believes in that. So this structured SMBG involves checking the blood glucose levels at predefined times each day. It has to have a very methodical approach. We have to give them pre-meal, post-meal days, and there has to be one sequence in which patient has to monitor the sugar, so that we can understand glucose patterns throughout the day, and then we can have appropriate therapeutic adjustments. Now, when a clinician and patient, they have to have a good willingness, they have to be motivated, very important. That motivation for performing repeated SMBG is very important, at least in the initial part of treatment of diabetes. And then we have to have a proper knowledge to interpret the glucose levels, the patterns, and then eventually taking actions by looking at these patterns is very important, because these are the actions which are going to escalate our diabetes care. We have a fantastic digital tool to empower us and our patient in personalized diabetes management. Smartphones have revolutionized everything, education in all the areas and in diabetes as well. It has provided a real opportunity to improve diabetes care by enabling patients and HCPs as well to exchange information. This is a very I would say a novel word. Exchange of information always leads to great results. So exchanging information remotely with potential to minimize or eliminate some routine office visits which are unwanted. So on the regular basis, patient can be in connection with us. Let's see how easily it works. Whenever patient is performing blood sugar, at that moment, it is a very simple way to check your blood sugar and deliver insulin or maybe any glucose lowering therapy. Then later on, when that is connected with our smartphone, we get the information and it helps our patient to take the right decisions. Then later on, over the time, when the data gets collected, personalized visuals and tips are there to help you achieve success. And when you come to your doctor, you go to your HCP, during the visit, these visual reports, I'm going to show you a few examples of visual reports, which will help you and your doctor to discuss lot of options, and that is going to have a patient-centered approach when we are treating our type 2 diabetic patients. So few particular events and activities from patient data can be pinpointed, which can go unnoticed. It is a very easy way for your patients to see the patterns. When it is an excellent behavior modification tool for the patients, when they see the pattern of the blood sugars and then they take the actions, and patients feel a lot of empowered. Seamlessly, it shares your data with your physician. It is a digital tool, so you don't have to physically visit your patient. And in this pandemic, we have realized the power of this technology more. Exchanging specific insights, you can have some feedback from your HCP digitally, and it enables your patient to review this patient case in one glance. It is very, very time saving, and you can make the therapy adjustments absolutely correctly. Now, how does it work? This glucometer gets connected to your Android phone or any iPhone. There is a web app for the patients, and there is a web app for the HCPs as well. Patients, they have personalized visuals and colorful visuals that has got a lot of impact, and it gives them some tips to help them achieve success. There is a web app for HCPs as well, and visual reports can be downloaded, and you can discuss these reports with your patients. What is working for patients, what isn't working for the patients, that can be discussed at any time and from anywhere, any part of the world. And looking at the academic part, it can be used as a population management tool. It can filter and sort the patient information according to multiple factors, whether it is a type 1 patient, you want to see the patients who are below 70 sugars, or out of the range, or age group wise, everything can be done. And this data can be used fantastically for producing your academic work or a scientific work. Whenever it comes to technology and logging in, patients are really scared. This web app, patient's web app login, should be, according to me, done in your office, in your clinic, in front of you. It's very simple. Your educator or your sister, in fact, you can also help the patient. That login, once it is done, I think the half the job is done. And this web app is from the doctor's side. Patient accepts the request from the patient side. This is the list of the patient's data. And if one patient is coming to me, and if I want to have a quick glance, there are these you can see the windows, and there is one window which can just show you the fastest way to see patient's report, then patient's average SMBG reading, blood glucose, number of hypo and hyper episodes, and when was the meter synced last. Everything can be seen in this slide. So this data populates automatically, and no manual work is needed. Patient doesn't have to have those logbook which they traditionally used to have. Now you can do a quick subgroup analysis, as I just mentioned in last two slides. That patients subgroup analysis can be done for your scientific work. Patient, you can distribute patient from the type of the diabetes, then age-wise distribution, gender-wise readings, average blood glucose, how many patients were actually in the range between 120 to 180, how many were above 250, how many had hypos, and how many patients had assisted device, pumper patients. Everything you can produce from this software. Then you can download the whole report. Now there are few things which we can see. This is the report, graph by the time of the day. Many readings are recorded by patients religiously, and at one glance you can identify the problem area. If you see this patient, on the horizontal axis time, and on the vertical axis there are glucose readings. This is a patient who is going in hypo typically between 12 and 2 a.m. and then later on the fasting is going high because of Somogi effect. The maximum high sugar is, I think, probably post evening snacks, just before dinner. That is the time our Indian patients, they binge. So these are few problem areas we can pinpoint. Red is high, green is normal, and blue is lower, hypoglycemia. Now, let's look at the glucose excursion. Nowadays, TIR, time in range, that is the main thing, indicator of glycemic variability, and we don't want our patients to be not having hypo, but we want patients to be in the time in range. And I think this patient, 52% of the time he was in time in range, and only hyperglycemia was not the problem. Hypoglycemia and hyperglycemia, they had equal episodes. So these are the patients who had equal glycemic variability. So now we should not be just pinpointing toward hyperglycemia, but there were 25% time that patient was below target range. So I feel if we want to have less glycemic variability, first thing what we have to do is correct hypo. Once we correct hypo, I think the hyperglycemia will be taken care of. So these are few readings. Now, comparative statistics, it's a fantastic tool. These are the patients, dedicated patients who are performing sugars. Probably this is the type 1 patient, type 2 patient having at least 7 to 8 sugars per day. I'm not recommending those many numbers for all the patients, but these are probably some problematic patients who are doing SMBG so religiously. So in the month of November, in the month of say December, from 29th of November to 28th of December, in that month, overall average sugar was 169. Probably he visited the doctor on 28th, some or maybe telemedicine, and few insights were given, few treatment changes were done, and his average sugar dropped from 169 to 126 in the month of January. Again, standard deviation also improved. It was 78 milligram per deciliter, which came to almost normal 60 milligram per deciliter. Number of readings were escalated. Probably patient was a highly motivated patient. So this is the kind of progress report we see in patient, and compared two period values of patient to know the prognosis at glance, and then we can customize the therapy accordingly. Again, this is a fantastic study from 5 UK centers. Around 128 patients were included in this, and this is can patient insights between visits and remote HCP via text message improve glycemic control. This is a diabetes app related text messages from healthcare professional in conjunction with this new wireless glucometer technology. Color range indicator improves glycemic control in patients with type 1 and type 2. Both the type of patients were included in this randomized control trial. And subjects were switched from current blood glucose meter to either VideoFlex, and one group was allotted VideoFlex plus additional OTR, that is one touch app technology, for 24 weeks. SMS sent by HCP every 2 weeks after reviewing 14 days OTR app reports, and all subjects asked to reflect upon on CRI alone or CRI plus OTR app for insights and decision making. And what was the result?
Sorry to interrupt, Dr. Vikshita.
I'm done, sir.
Yeah, okay.
There was A1C reduction of about 0.5% with blood glucose meter alone, and glucometer plus OTR app, there was a reduction, very significant reduction with 1% of A1C within 24 weeks. So this assisted digital technology is definitely proving to be very, very effective. So in summary, the diabetes management definitely involves complex decision making. A personalized approach is definitely for the care of individuals, and it is going to provide a unique management plan for each patient. This connected technology will support personalized diabetes care to great extent. Again, just to emphasize that education is the most powerful weapon we can use to change the world. And if we have a better, sharper weapon in education to deliver diabetes care, effective diabetes care, why not? Thank you so much.
So thank you, Dr. Dakshita, for your lucid talk on glucose data for personalized diabetes management. So now we are going to have yet another talk on one of the hotspots in diabetes, that's vaccination and diabetes by Dr. Ashish Dingra. Dr. Ashish has done his diploma in diabetes, Cardiff UNEV UK, and he's done a certification course in diabetology, certification course in evidence-based diabetes management, certification course in management of thyroid disorders and diabetic foot management. He's organizing secretary Jabalpur Diabetes Update, Jabalpur Thyroid Update, and MMRF Insulin Workshop. He's a past vice president API, president Jabalpur Endocrine Society, organizing secretary of RSSDI MP Chapter 2020, vice president and RSSDI MP Chapter, honorary secretary and founder of Mahi Medical and Research Foundation. And he has presented various papers in various national and international journals, and he's received many awards and recognition. So over to Dr. Ashish.
Thank you, Padma Madam, for kind introduction. And today I am here to discuss the vaccination in diabetes patients. As we know, can you see my screen?
Yeah.
So vaccination in diabetes is a hot topic, as you told, as we are dealing with the COVID scenario also. So to begin with, I will thanks Bansi sir for inviting me here, for giving me opportunity to discuss this important topic in the mega show, DiaCare, Diabicon new conference, which he has given the name through the digital world. And to start with, I will introduce that diabetes has emerged as a disease of major public health importance in India, affecting the rich and poor alike. Conventionally, comprehensive diabetes management is aimed at preventing micro and macrovascular complication. However, morbidity and mortality due to infections are also significant. The diabetes and infection also confer an increased risk of developing and dying from infectious disease and is now considered an important complication of diabetes. So indeed, the morbidity and mortality associated with infectious disease like influenza, pneumonia, which are preventable by appropriate vaccination, are also very high. Although people of all ages are prone to infectious disease like pneumonia and influenza, but the extreme of age and certain underlying medical condition population like diabetes, asthma, and cardiovascular disease, they aggravate the risk. We all know this thing. So why there is a need for vaccination in diabetes? Because there are recommendations for vaccine assume great significance due to increased prevalence of drug-resistant influenza and pneumococcal disease and related complications in the elderly population in the past. So the increased susceptibility of diabetes population is due to hyperglycemia, poor long-term control of diabetes, long-term duration of diabetes, decreased immunity, which we are talking about in COVID situation also, impaired lung function, pulmonary microangiopathy, the increased risk of aspiration and coexisting morbidity. So these are the need for vaccination. To begin with, we will talk about the pneumococcal vaccination and the infection, why it is important in diabetic population. The risk in diabetes, we all know according to WHO, the mortality rate due to pneumococcal infections averages 10 to 20%, while it may exceed more than 50% in high-risk groups like diabetes, elderly, CKD. It is estimated that people with diabetes are almost 3 times at higher risk of death due to the pneumonia-related complications. So patients with type 1 and type 2, they have 4.4 and 1.2 fold risk of pneumonia-related hospitalization respectively. So it is very much important to tackle this pneumococcal disease in diabetic population, which is caused by streptococcal pneumoniae. Infection in the lung, blood, or meninges of the brain and spinal cord can be seen with this bacteria. And the diabetes increases the risk for acquiring pneumonia and invasive pneumococcal disease. Morbidity and mortality from pneumococcal infection may be higher in this population. And the pneumococcal vaccines, which are now available, are of variants: 13-valent pneumococcal conjugate vaccine PCV13 and 23-valent pneumococcal polysaccharide vaccine, that is PPSV23. So one is conjugate and another is polysaccharide vaccine, which helps to protect against the pneumococcal disease, including the bacteremic disease. So it is very important to vaccinate our diabetic population with this vaccine. So what are the vaccines available? I will let you know simply, because it is very confusing every time in our clinical situation that what to use and what not to use. So the two common types of pneumococcal vaccines are conjugate vaccine, that is PCV7, which was previously used, and PCV13, which is now used, and pneumococcal polysaccharide PPV, and the minimum age for administration of PCV and PPV are 6 weeks and 2 years respectively. This is recommended by various organizations like ADA, ACIP, Canadian Guideline. The ADA recommends this vaccine again to the patients of 19 to 64 years of age, pneumovax, that is PPSV 23 and PCV 13 between the 19 to 64 years of age. Detailed description I will let you know in this slides. The PPSV 23, it is recommended for adults with diabetes aged 19 to 64 years. And adults above 65 years with diabetes, they should receive 1 dose of PCV 13 if not previously received. Between 19 to 64, which is recommended, PPSV 23. If the patient is above 65 years with diabetes, he should receive 1 dose of PCV 13 if not received previously, followed by another dose of PPSV 23 at least 1 year after PCV 13 and 5 years after the last PPSV 23. If PPSV 23 was previously administered but not PCV 13, administer PCV 13 at least 1 year after PPSV 23. So to simplify, if the age is 19 to 64, you have to give PPSV 23. If the age is more than 65, the patient should receive 1 dose of PCV 13 and then another dose of PPSV 23 should be given at least 1 year after PCV 13. This is the recommendation which you should remember. Now, whenever both PCV 13 and 23 are indicated, the PCV 13 should always be given prior to PPSV 23. This is the dictum. And adults who have received a dose of PCV 13 at the age below 65 years, they are not indicated to receive additional dose when they turn 65 years of age or older. So this is the thing which we should remember. So certain population require additional vaccination like age more than 19 years with immunodeficiency, that is HIV, anatomical or functional asplenia, chronic renal failure, nephrotic syndrome, CSF leak, cochlear implant. They should receive 1 dose of PCV 13 followed by PPSV 23 at least 8 weeks apart. And second dose of PPSV 23 at least 5 years after the first dose of PPSV in the immunodeficient, chronic renal, nephrotic syndrome or asplenia patients. Now, this was the recommendation for pneumococcal infection, pneumococcal vaccine. Now, the influenza infection, again, it is mortality is high in diabetics, around 10,000 to 30,000 annually mortality due to influenza, and people with diabetes are 6 times more likely to hospitalize during an influenza epidemic. Report that people with diabetes are 6 times more likely to hospitalize during an influenza epidemic than those without diabetes, with the mortality rate varying between 5 to 15%. It is high. Evidence that influenza can trigger coronary complication when taken in context of diabetic subjects, they gain more significance since the risk for CVD is already high by 2 to 4 fold in the subgroup of diabetes. So the influenza infection is harmful itself, and it also trigger the coronary complication if the patient is infected with influenza infection. So it is very important to tackle this. And subgroup analysis and subsequent studies, they have shown vaccination to be efficacious as well as cost effective in reducing the hospital admission as well as its associated complications. A prospective study on the effect of large scale intervention with influenza and 23-valent pneumococcal vaccine in adults aged 65 years or older, they revealed that in general the vaccination leads to substantial health benefits and to a reduction of mortality from all causes in this age group. So the studies have proven that if we vaccinate the diabetic population with influenza pneumococcal vaccine, the hospital admissions are reduced, the complications of future complications, respiratory complications are reduced. So what is the recommendation for influenza vaccination? The influenza vaccine is recommended for all persons aged more than 6 months who do not have any contraindication to vaccination. So all person age above 6 months, they should receive influenza vaccine. What are the vaccines available? The trivalent inactivated influenza vaccine. It is the most common used vaccine. It can be given to person age more than 6 months of age, including those with high risk conditions like diabetes, CKD, immunocompromised state. But the live attenuated vaccine, it may be used for healthy non-pregnant persons aged 2 to 49 years, but usually the trivalent inactivated vaccine is used in the age group of more than 6 months, including the high risk condition, that is safe. So this vaccination is recommended by ADA, ACIP, Australian, Canadian, UK department, and the influenza vaccine is recommended annually for all diabetic patients more than 6 months of age. It is the simple guideline given by ADA. Moving on to the third infection, that is hepatitis B infection. It can cause a life-threatening liver infection that often leads to chronic liver disease and puts people at high risk of death from cirrhosis of liver and hepatocellular carcinoma. In my clinic, I see many patients who are converting into chronic liver disease due to the hepatitis B infection. So we have to act early now in the diabetic population, because the patients with diabetes are at 2.1 times increased risk of infection by HBV than the non-diabetics. So twofold higher risk of getting the infection of HBV in the diabetic population. So on the basis of available information about HBV risk, mortality, morbidity, available vaccines, age at diagnosis of diabetes, and cost effectiveness, the ACIP recommends vaccination for hepatitis B for all unvaccinated adults with diabetes younger than 60 years of age as soon as feasible after the diagnosis of diabetes. So hepatitis B vaccination may be administered at the discretion of the treating clinicians to the unvaccinated adults with diabetes who are above the age of 60 years. So below 60 years, once the patient coming to your clinic, give him the shot of hepatitis B first dose. And if the above 60 years, we have to see and whether what is his seropositivity or negativity. The hepatitis B vaccine is made from the inactivated dead hepatitis B virus. 2 single antigen recombinant hepatitis B vaccines are available. The hepatitis B vaccination usually consists of 3 doses. One to be administered intramuscularly at 0, 1, 6, and booster can be used afterwards. So vaccination is 3 doses, 0, 1, 6. So these are the nutshell vaccination guidelines by ADA. The patient should be given pneumococcal vaccine, diphtheria tetanus vaccine, MMR, varicella zoster, hepatitis B, HPV, and in male and female. So this is the nutshell what vaccines we should follow. But in Indian population, we usually use basically 3 vaccines in our clinic. This you can take a screenshot. This is taken through courtesy of Dr. Sunil Gupta sir's clinic, that he is keeping this sticker, he's putting this sticker in all his files. So I'm thankful to sir that he has made a simple guideline for the clinics, the immunization schedule in adults with diabetes as per the ADA standards. Hepatitis B vaccine to all below 60 years of age. Above 60 years, we have to see the comorbid conditions. The 3 doses, 0, 1, 6 months. Pneumococcal vaccine, vaccination against pneumococcal disease in adults, I have told you, for adults between 19 to 64 years of age. And above age 65 years, the patient can be given PPSV 23 after the pneumococcal 13 dose. The influenza vaccine, every year they have to be given at year 1, 2, 3, 4, 5, 6, whenever the patient is coming to your clinic. So this guideline should be followed in all your clinics. You take the screenshot of this. You can apply in your clinic easily. You will not forget, because we take care of all the parameters: diet, exercise, medications, yoga. But what is very important in this COVID situation, that the patient should be aware of, and vaccination, and the doctor should be aware. We all are lacking this awareness that our patient should be vaccinated, and we are not vaccinating our patient properly. Now, the last few words, that who should not be vaccinated, that is very important, because in my pharmacology, my teacher used to tell me, Ashish, you should know the contraindication of the drug that किसमें use नहीं करना है, इससे पहले की indication याद करो, because it will help you in your practice. So the hypersensitivity to the active substance, history of chicken allergy, history of Guillain-Barré syndrome, and immunization should be postponed in patients with febrile illness or any acute infection. So any hypersensitivity or allergic patient should be avoided with these vaccinations. But last but not the least, the COVID-19 vaccine, it is very important for the diabetic population. The researchers have urged to prioritize vaccination for individuals with diabetes. As such, people once infected with COVID-19, they have 3 times more likely to have a severe illness or require hospitalization compared with the people without diabetes. So we have seen the mortality in our diabetic population due to COVID, due to pneumonia, and we should act early in our diabetic population, which is the message given by this COVID infection. So there are 3 or 4 companies coming at the present, the Pfizer, and what are the how they work, when they are approved, and when they will be coming back. This we all are reading daily. I will tell you only the Pfizer one, which is messenger RNA, Moderna is again messenger RNA, and AstraZeneca is inactivated cold virus. And 95% infection control is given by the Pfizer one, 94 by Moderna, and AstraZeneca 70%. And the 2 doses should be given 3 weeks apart for Pfizer, 4 weeks apart with the Moderna, and AstraZeneca 2 dose 1 month apart. There are side effects also coming up in our daily news channels and the literature. So we have to wait till the new data is coming. So there are the many vaccines are under studies. So to conclude, my dear friends, persons with diabetes often have comorbid factors which increases the morbidity and mortality from infections. Alone glucose management is not sufficient to prevent the patient from developing the infectious problems, and vaccines are among the most cost clinical preventive services and a core component of any preventive service package, because in our clinics we should now combine the package. If you are using the investigations with the medicines, you should also promote vaccination to your diabetic population, and adults with diabetes should routinely receive vaccine as now recommended by ADA 2021 standards of medical care in diabetes and the CDC. They are now recommending the vaccination should be given to all diabetics throughout the range. Whatever the range I have told you, the age criteria, we should follow this. And this very important guideline you should follow in your clinics. You will not miss the vaccination from right now today. We all should follow this guideline. And thanks a lot for your patient hearing.
That was a very good concise summary of vaccination in diabetes, Dr. Ashish. Thank you very much. Now we will go to the next lecture. It is about reversal of diabetes using whole body twin technology. And to deliver that lecture, I am inviting Dr. Jahangir Mohammed. He is from the twin technology. And to introduce him, he is a serial entrepreneur, and he is revolutionizing the way humans see the technology, and his mission is to help people live longer with vitality. Over to you, Dr. Jahangir.
Thank you very much. At the outset, let me thank Dr. Bansi Sabu and yourself, Dr. Babu, and the whole team for this opportunity to speak with you this morning. Am I coming through clearly?
Now you're clear.
Okay. Thank you. Thank you for this opportunity. It's a pleasure for me to be talking to you this evening, your time. What I want to talk to you today, I want to talk to you about a new technology we've invented called digital twin technology that helps physicians reverse chronic diseases, starting with diabetes, but not just diabetes, a slew of chronic diseases, hypertension, dyslipidemia, obesity, and many more. This has been in treatment for about 2 years now. And about 100 doctors are practicing it currently in India. And it's growing fantastically. I would like to cover 3 things today with you. One, what is the idea behind this technology? How did it come about? 2, how does it work? What is the mechanism for its reversal? And 3, share with you some of the peer-reviewed journal data that we published, so you can see the kind of results this is giving. So those are the 3 things I'm going to cover. I'm going to share some slides. Right, my slide coming through, doctor?
Yes, sir.
Okay, so this idea came from a company, my previous company, called Jasper. Jasper is the world's largest Internet of Things platform company. We built. It's used by over 10,000 companies around the world. And one of my early customer was Tesla. The Tesla makes driverless cars. This was like 2005, almost 15 years ago. And Elon Musk, the founder of Tesla, had a vision for his company. He actually wanted to make a car that actually got better over time. As it got older, it would perform better. It was obviously a very strange idea. And the way his team went about doing that is to put lots of sensors in the cars and utilize artificial intelligence and IoT to collect the data from the sensors and create a digital replica of that car, right? And they call this digital twin of the car. And with this digital model that is continuously updated, they would know exactly what is the health of the car. They would know what engine parts are working properly, where the friction is, what is generating heat, which parts are consuming too much electricity since it's an electric car. They would know exactly what is the health of the car, how it's performing. And based on that, they would continuously tune the engine, all in real time, right? It's an amazing idea that started really as a fuzzy idea, but it got better and better and better over time. And truth be told, today, as Tesla gets older, and I have one, I've been using it for 2 years. Today, it works better than I bought because it's been continuously tuned and enhanced. So this gave me the idea. This was the first idea was, that's interesting. I mean, if you do all this for a car to make it perform better and last a long, long time, could we not use the same technologies and models for human body? Can we utilize high quality sensors, simple to use sensors, to continuously collect data about the biology and the body? Utilize similarly artificial intelligence and IoT. Create a digital twin. And with digital twin, you figure out how we can reverse diseases in the human body and make people healthy for life. That was the idea, right? And I was really grabbed by this idea because it has tremendous potential, and whoever is going to figure this out might really make a huge contribution to humanity. So I was really grabbed by it. And I thought about it and I said, sooner or later, someone is going to do this because this is really inevitable. But I thought about it and I said, but the human body is different. It's not a mechanical system, right? It's much more whimsical. You all know this. It's way more complex. So I didn't quite pursue the idea, to be honest. And 4 years went by. I was in India, Chennai, having dinner with family, 7 of us. I found out 4 of them were diabetic. I said, wow, how did that happen? I mean, it's really become so prevalent. And I realized by that time, the technology is so advanced now, and the sensors are become more available. It is now powerful enough we can apply this to human body. That's how the company got started. right? So I quit my previous company and started this called Twin Health, and we've made amazing progress. And I want to talk to you about the progress we made. So after I left, we gathered a bunch of medical scientists, Stanford University PhDs, some of the world's very, very best artificial intelligence IoT engineers, and we went to work. And this is what so let me tell you how we went about doing this and the results we got. So we chose a set of sensors and started collecting signals to create a human, similarly a digital twin of the individual. We call this whole body digital twin of the individual, patient's digital twin. Right? And there are three parts to this. Let me talk about the three parts. Part one is we use 5 different sensors, right? A continuous glucose monitoring patch, a wireless BP meter that you take once a day, a ketone meter that takes blood ketone once a day, a body composition scale that measures not just the weight, but weight, body protein, bone mass, water content of the body, and so on. And a very high definition sensor watch that gives continuous heart signals and activity and sleep patterns and so on. We also did periodic blood tests, comprehensive blood tests, 103 parameters. All this data, sensor data, blood data, and even the people would report what they ate. We created an app that's very, very simple. They press a button and they say what they ate. It has voice recognition, it converts to food, and it logs. These signals feed our platform called Twin Platform. All in all, we take about 3,000 signal points every single day initially. And using this sensor, this data, we would understand how the body is behaving and start to create a digital model of it. This is part one. Part two, we created a database from ground up called Twin High Definition Nutrition Database. It's more than 10,000 food, and we decompose this food to 87 different elements. And nowhere in the world this kind of high definition database exists. So we had to build it from ground up. For every food, we understood every dish, every food, every ingredient. What is not just what is the carb, protein, fat, that everyone has it, but what kind of proteins, what kind of fat, what kind of macro minerals, what kind of micro minerals, what enzymes, what vitamins, right? I have a team here in California that built this from ground up. The second thing we plugged into the platform is FDA medicine database, all the medicines, particularly chronic disease medicines and diabetes medicines. Now, utilizing this, what the platform would do is to recommend very, very precisely what is the right nutrition for this kind of body, for this state. Because see, look, the root cause of chronic diseases, diabetes and so on, is really damaged metabolism. What we wanted to do was not just address the symptom of the diabetes, but actually solve the underlying root cause of chronic disease. And we had a hypothesis that such solving root cause is possible through very precise treatment, very precise set of nutrition, guidance on activity, and some guidance on sleep, and also precise medicine. What is for this body, for this condition, what is the exact molecule, compounds to use in what dosage? And that we would provide it to the physicians, and the physicians would be the one to look at it and go, okay, that makes sense. And they prescribe, right? And we supplemented that with coach who would be in contact with the patient and continuously coach on a daily basis.
So when you give this precision treatment, instantly, in minutes, we would also see how the body is responding. So you give some input, you get some output. It becomes a learning system. So this is why digital twin is a learning system. It's continuously learning. Every minute, every hour, every day, continuously learning how your body is responding to different food, different activity, your sleep patterns, different medicine. And based on that, it actually adapts the treatment to make your chronic conditions get better and better and better. It's amazing. What we've learned is it takes us about 35 days for us to build a very comprehensive digital twin. Thereafter, thereafter, you don't need this many sensors. You just need just 2 sensors. A watch you wear every day. You stand up on the body composition scale every day. It becomes very easy for people to use because it's not only the treatment should work, it's also important. It is something common people can utilize, non-technology people can utilize. So we built this to be highly automated, very easy for people to use, right? So it took us for about a year for us to perfect it. Now we've been offering the service for over two years. We have reversed over 2,000 chronic disease diabetes patients. As I said, we have over 100 physicians practicing currently. And we are really amazed how resilient human body is. And when you do this really, really well, how fantastically the body can recover from diseases. I'm going to share with you some data that from this. And what I'm going to do is to take one patient and share the result we got. Then I'm going to take the first 510 patients that we published and share the data of those. So hope you'll find this fascinating. So this is a 48-year-old male, joined our treatment in Chennai. An endocrinologist was the doctor. He came in with diabetes of 12.3 A1C, 306 average blood sugar. He was taking 2 insulin, 46 units of insulin, two times a day, 3 diabetic oral medications on top. He was waking 3-4 times to pass urine. He was fatigued out, right? Pretty messed up, pretty severe diabetic conditions. So he enrolled in our digital twin program. In 90 days, this is what we got to. His A1C is down to 5.6, remarkable improvement, simultaneously stopping all his insulin and all his medicines, right? And his symptoms are gone, right? Now, since the treatment really is not about just solving for diabetes, but deeply understand the body and solve the root cause, which is the damaged metabolism, and make the metabolism better, we said all chronic conditions should reverse. But let me show you the results of other chronic conditions, right? He was also hypertensive. He was 161 systolic, 103 diastolic, down to 139/82. He was taking 2 hypertensive medicine, was down to 1. His cholesterol was out of whack. The triglyceride over HDL ratio was 15.1, pretty high. He was down to 6.7. His LDL particles was 115 ApoB protein, down to 78. He was on statin. The doctor stopped the statin. He was overweight. We are not a really weight loss program. We are really reversing chronic diseases. But what we found is when you correct the metabolism, invariably people, overweight and obese people, do lose some weight. But more importantly, you lose the kind of weight that are more damaging for our body, visceral fat. So 20% reduction in visceral fat. Improvement in liver health, improvement in kidney health, a dramatic improvement in chronic inflammation, right? His a high sensitivity CRP was 6.45, dramatically dropped to 0.46, right? In HOMA2B, the pancreas beta cell function was 36.3, dramatically improved to 117.3, right? His energy was back up. He was having mood swings before. Now he was rating his mood 4 and 5, average of 4.4. And his race service, he gives us 10 out of 10 for the service. This is very inspiring for us, for me, for my team, for all our doctor partners. The possibility that we can very systematically bring good health back to people is enormously exciting for us. Now you may think, okay, that's one guy. How about all the people? So here are the first 510 patients. What I'm showing is the average of what we got, right? The average A1C of people enrolling in the program is 8.8, and it goes to 6.2. 32 units was the number of amount of insulin, average amount of insulin of patients that took insulin when they joined the program. 94% of them entirely stopped insulin in 90 days, down to just 3 units average. Medicine from 2.8 average down to 0.7. So it's not just that as you correct the metabolism using digital twin technology, it's not just the A1C goes down. It's the combination that A1C goes down and the physicians are able to reduce and stop medicine. That's the beautiful possibility. Improvement in hypertension, improvement in cholesterol, 10% reduction in visceral fat, improvement in liver health, improvement in kidney health. You can see EGFR for people that had EGFR below normal, right? There was an improvement of 9 points of EGFR. So physicians look at it and go, wow, that's really amazing. This is the power of getting the metabolism right. And if you're very precise about nutrition, sleep, and exercise, you're very precise about medicine and reduce it over time, enabled by digital twin technology. This is the kind of results that's possible. Fantastic results. And you may wonder, okay, well, that is pretty good average, but how about, did we choose really people that are just diabetic, like early diabetes? And here is the profile of patients, right? Average age is 48.3. We have people as low as 20 years. People are, about 15% of the people are above 60. Average A1C was 8.8. You can see throughout the whole range. 19% of them are greater than 10.5. Average number of years 8.4. People as old as 30 years diabetic. People as young as less than 2 years. Pretty broad description. And I'm really proud. Some of the physicians were seeing this. They're really encouraged by it. And they enrolled, they were diabetic, unfortunately. They also enrolled and reversed. 27 physicians joined the treatment, and every one of them reversed. Really amazing set of results. So our goal, and I want to say that while we see really good results very quickly, you don't have to wait a long time. This healing the metabolism is a 1-year process. So we ask for a 1-year service. So it starts with just normalizing lipotoxicity and glucotoxicity. Then it reduces the fat in the liver and fat in the pancreas. So it's a progression, right? And it gets the beta cell regeneration. It takes time. So it takes about 1 year to fully heal the metabolism. Then we see this as a lifelong service. People wear simple sensors. They're continuously monitored 24/7. Whenever their health is going little to the yellow zone or a red zone, they get proactively called. The service is about keeping people healthy for life. This is not sick care, that you treat a sick person, get him right. This is truly continuous health care. It's not sick care. The physicians now have the opportunity to deliver this as a continuous service for their patients. And that is our business model. Now, here are some publications that that's out there. You can read it. We've also underway an RCT, randomized control trial. It's the world's first diabetes reversal. But here is how we are coming to market, right? We see this as a service. In order for this to truly have a big impact and a broad population impact, we see this as a service that must be delivered by physicians and doctors. So that's how it is delivered to patients. It's the physicians is delivering the service. Treat diabetes. We are very focused on diabetes now, but invariably all diabetic people that join us, not just reverse diabetes, they improve their hypertension, they improve their dyslipidemia, they lose some bad weight. You saw that, the liver function gets better. And our physicians deliver this as a continuous lifelong service. And we've designed this so that the patients can pay a monthly affordable fee, which is shared between the physician and the twin platform. I'm so delighted that I could be part of your session today, Dr. Banshi, and share these insights with your team. Thanks a lot for this opportunity. Thank you, Dr. Rahul.
It was a very good lecture, sir. And definitely reversal is going to be next big thing in diabetes as well as other chronic diseases. Dr. Padma, we have another 10-15 minutes. So any questions or something?
I just wanted to congratulate Dr. Jahangir for such a fantastic presentation on this twin technology. And I have a question to you, sir. Like you have used this model in reversal of diabetic patients. So can this also be used for obese patients for weight reduction, for reduction of bad fat, who do not have comorbid conditions like diabetes, hypertension, or any liver disorders?
Yeah, thank you, Dr. Padma. Yes, it can be utilized, but we are not offering that yet. Soon we will. Currently, I'm looking at 70 million people in India that are ravaged by this diabetic disease. I've asked my team, hey, let's just focus on this big disease. But soon we are going to offer this to hypertension, obesity, arthritis. We are seeing people that are with arthritis goes away. So I hope very soon we will be able to bring this for obese patients too.
Okay. And one more question, like if patients were keen on, connecting, taking advantage of this twin theory system, how to connect with you?
I'm sorry, you were cutting. Can you please repeat that?
Diabetic patients who are keen on, adopting this mode of, reverting back to normal life, how to get in touch with you, how to connect the patients with you?
Oh, wonderful. I mean, you go to twinhealth.in,
okay.
twinhealth.in, and there they can go choose the doctor they like.
Okay.
They can choose the city they are in. They can choose the doctor they like.
All right.
And someone will call them and help them get enrolled with one of the physicians they like.
Dr. Jahangir, how we can become your partner in this, because we are in different cities? How can we can be enrolled in your program as a physician?
Thank you, Dr. Ashish. You could also go to the same website. There's a page for doctor. Or for this audience, I welcome you to send me an email. It's Jahangir@twinhealth.com. Okay. I'll personally get the right people to contact you and take it forward.
Definitely. And it was a nice presentation. And what actually makes the patient reverse the diabetes in your program?
It is really solving the underlying damaged metabolism. See, one of the things I realized talking to our clinical team and scientists, medical scientists, and some really fantastic AI guys that could take this data on the surface, is there's a singular root cause for this chronic disease. The singular root cause is the damaged metabolism, right? And what this treatment does is using digital twin technology. When you give nutrition, sleep, and activity and medicine, it takes all these signals to understand how the metabolism is changing. For example, how the blood glucose response, real-time blood glucose response changes for food. It's a very simple example. Some people respond very well. Some people are okay eating bananas. Some people respond very badly eating bananas. And you would respond differently than me, and I would respond different from Dr. Padma, right? The system is very precise for the individual, and it's really solving for the underlying metabolic damage. When the metabolic health is restored, very interestingly, we see these chronic diseases reverse.
Thanks a lot, sir.
Thank you very much.
Do we have any questions from the panelists for the speakers? I don't see any questions in the chat box. Do we have Dr. Kashyap here? Dr. Anuj?
Anuj is, I think he's not there.
No, no,
Anuj is there. Yes, very much.
Yes,
Okay,
I'm
please.
here.
Yes, Dr.
If there is
Padma.
any question,
I wanted to ask you one question, Dr. Anuj. In our practice, we normally come across elderly diabetic patients with hypertension and with kidney disease who are, virtually on 4 drugs. And despite having 4 drugs, their systolic blood pressure is in the range of 170, 180, and diastolic is as low as 70 and 80. They have a very wide pulse pressure. So how do we take care of blood pressure in such patients? What should we do?
Most of the time in such patients, the problem is related to the adherence of therapy. In the elderly age group, we find that most of the time patient forgets to take their blood pressure medication. Many of the time it happens that they wishfully don't take that. Sometimes they feel that their blood pressure was normal and they don't take this. And when you do the deep interrogation, usually you find it. Another very important thing I find that does not allow your blood pressure to get under control, that is a sleep deprivation. Most of the time, whenever you are giving 3-4 drugs to your patients and patients is unable to sleep, and if you simply give one tranquilizer and it makes your patients well controlled. Many times it has been seen. And the first problem in which the poor adherence is the problem, you can go for the home blood pressure monitoring or ambulatory blood pressure monitoring. In elderly people, ambulatory blood pressure monitoring is little bit difficult because patient is having difficulty in sleeping every half an hour, that is getting inflated and patient feels a little trouble. But home blood pressure monitoring many of times is successful. But again, there is a problem of the forgetfulness. Sometimes they will measure their blood pressure, sometimes they will forget to measure their blood pressure. And whenever they will measure their blood pressure, they will say that, okay, that is too normal, then I should not take the medicine tonight. It happens with my mother many of the times. I have given her the blood pressure monitoring machine. She measures it, and whenever she finds it very close to 120/80, she doesn't take the medication. And next day she laughs, "Oh, I did not take because I thought I was normal." So it happens to many of the patients. You must do the well counseling to them. You must do the very good counseling, and this problem can be solved then. If a person is really having a resistant hypertension, then we have got a battery of investigations for which we can explore all those investigations before giving. We can go for the advanced medications, and after that we can go for the endocrine causes of the secondary hypertension. And then finally, if you don't find anything, then you can go for the intervention for the hypertension control, which includes the stimulation of the nerves, and you can do that. Those therapies can be taken although they have not proven their worth of this time. So sometimes they may be successful, they may not be successful. And in elderly people, especially this sympathetic nervous system is functioning very poorly. And because of what, they sometimes don't respond to therapies. And that must be kept in mind.
So, Dr. Padma, I totally agree with Dr. Anuj. And one thing only I want to add from my clinical experience, that tobacco chewing, it is a
Yes.
very big cause of resistant hypertension.
Agree.
Because in my clinical practice, I was giving 8 medicines, 7 medicines to the patient, but still the BP was 200/100. The moment he has reduced his tobacco chewing, now he is controlled with only 2 medicines. So tobacco chewing history, you should also take the addiction history, all those things also we should rule out.
Yes, I agree 100%.
Okay, and then thank you, Dr. Anuj. I had one question for Dr. Kashyap, if he is not here, and if Dr. Bansi is here. I mean, if would you like to answer? I mean, Dr. Bansi. I mean, it was related to monogenetic diabetes. Maybe Dr. Anuj could answer this question for me.
I think if Bansi is there, then he is the best person. If he is not there, then I can try. Although
Yeah, you see,
he is the
as the
master
incidence,
of
yeah.
monogenic diabetes.
Yeah. You see, as the incidence and prevalence of type 2 diabetes in India is increasing at an alarming rate, and we do see diabetes in younger age group, So as early as patients in their 30s, early 30s. So what are the clinical pointers for a GP to clinch the diagnosis of monogenetic diabetes in absence of proper, lab backup?
In absence of
Proper lab backup. When you don't
proper
have
lab
other,
backup.
yeah.
That is very difficult because many of the times lab backup is very much required for the genetic studies. Especially you need to send the sample for some other distant places also, especially in India. Apart from that, we can simply think that clinically, if the patient is lean and thin, patient is whether having some obesity. We have seen a lot of type 1 patient, those who are gaining the weight. These type of a patient cannot be kept in the type 1 category, which is a classical type 1 category. They are not the classical type 1 category candidate. So they can be kept in the category, whether it will be MODY or not, whether it will be monogenic diabetes or not. It can only be proven after the test. But such type of the patient, those who are having little bit different from the classical type 1 features, they should be investigated for the monogenic diabetes. That is my take. I think Banshi wants to add something, which can add.
Okay.
So,
Thank you.
I think age less than 25 years, lean, and if there is poor response to insulin, that means no diabetic ketoacidosis, etc. That these are the clinical pointers towards more for MODY or monogeneity.
Yeah, so young age and the pedigree charting is very important. If you go with the pedigree charting, I have diagnosed two patients in my city. There is no genetic testing available. She was on insulin, and by only pedigree charting, I have diagnosed her because I thought her age is 25 years, so we should try to take the history. So her maternal side was all were having diabetes, and now she is controlled only on glimepiride half mg, and she was taking previously insulin. So that is very important. If you don't have any facilities, you can give a trial. If you can keep the patient admitted for 2-3 days, check ketone also. You can take a trial in Indian population if the genetic testings are not available. So pedigree charting, if you will do, and the age, what you are saying, it can help you to diagnose clinically.
Well, look, she's like most of the time we have, made a diagnosis of type 2 diabetes and we put the patient on sulfonylureas and the patients are responding. But, whether the clinical diagnosis of type 2 is correct or should have been MODY. So that was my question, because patient is already responding to the oral drugs.
You have to take the history, proper family history is very important.
And even type 2 you have. With type 2 diabetes also you have history of family history is positive. So how do we,
It is on the one side. It is either maternal side, three generation, or only the paternal side, in monogenic diabetes.
Okay, so you have to go vertically.
Yeah.
You can't label anyone as a monogenic diabetes unless you are not proven it on the investigation basis. You can simply predict that this may be like this or that.
That can be a prediction depending upon the treatment protocol. As she was off insulin without ketosis, and now she's doing well on sulfonylurea with maternal 3-generation history is positive. So we think of it, but we have not proven through genetic testing.
So one must have high index of
I would like to add on just, for this, the terminology diabetes of young is there. If at all you want to label, so that if you have any other whether we should investigate, and if the person or patient agrees, we can go for further investigation.
Yeah.
And one question to you, Dr. Ashish, you had such a lucid presentation on vaccination in diabetic patients. So what's the protocol for patients who are immunocompromised and with diabetes?
The same protocol is mainly used, but we should avoid the live vaccine, like vaccines like influenza live vaccine. I have told you we have to avoid those vaccines. And in pneumococcal, we have to use PCV13 if the age is more than 65 years first, and then after 1 year we can give the PP polysaccharide vaccine 23. So these are the mainly, but because diabetic patients, we take them as immunocompromised only, so we should follow the same guideline.
Okay, thank you.
Thank you.
So any other questions from the house?
Yes. I think we have
there are no more questions in the chat box, and we come to conclude this session. And thank you so much, Dr. Bansi and the organizing team, for putting up such a fabulous show with the excellent activities and giving me an opportunity to be a part of this mega show. Thank you all. Thank you very much.
Thank you, sir, for inviting us here. And congratulations for the great show.
Thank you.
And Jangi sir, your presentation was very nice. Anuj, bye.
Bye-bye. Thank you all,
Bye.
Dr. Banshi, for giving this.
Bye.
Thank you, Dr. Vijay Kumar, being with us.
Vijay Kumar sir.
Bye-bye, Dr. Vijay Kumar.
Thank you.
Dr. Kumar, thanks a lot and thanks.
Jimit is always smiling. Rahul sir.
No, sir, I'm waiting to conclude. On the behalf of organizing team, I have to conclude the session. Dr. Bansi sir is I've got the news. He's in another meeting. He is speaking somewhere else. So on the behalf of him and the whole Diacon conference team, I thank you all for conducting this session. This was a wonderful session. We had a great discussion here. So on the behalf of the Diacon and Diacon conference, I thank you all again. First of all, we should at the end, for what of thanks, I should thank Dr. Bansi Sabu sir itself. We know his hospitality we are missing this year, but we are having this wonderful but last conference of 2020, which we want to forget the year, but we had a wonderful and unforgettable conferences this year. So we are hoping that next year Dr. Bansi sir will call us for physically, and we will again have his taste of hospitality. And I also like to thank the whole DACA team who are working so many days for this, making this conference successful, and the whole team of Dr. Hardik Bhai and RX Events who are working so vigorously, and they are making it technically this possible. Not only this conference, so many conferences from RX Event we have seen, they have done it wonderfully. If Hardik Bhai is listening, can they come on the he can start. Also, from last 2 days, we are having so many lectures. So I would like to thank all the reporters of all the sessions we have here, all the esteemed chairpersons also, and we have all faculties from national and internationally. In this conference, we have seen so many international speakers also who have come to learn, and we thank on behalf of the organizing team. Thank you so much, all the speakers, chairpersons, and reporters. And we also need to thank the industry partners also who have continued their support during this pandemic time also, and in the virtual conferences also. Thank all the industry partners also. And at the end, we have to thank all the audiences. We are seeing huge number of audiences that are joining this conference virtually also. So thank you all the doctors who are listening to this conference in many platforms. Thank you very much.
Thank
Thank you,
you.
Jimit, and congratulations once again for a great show. And we will meet definitely live next year. Let's hope for the positive things.
Yes, definitely.
Wish you all a very happy new year.
Happy New Year. Vijay Kumar sir, bye.
Happy New Year to all.
Happy New Year.
Thank you.
Here, not only
Bye. Thank you.
across the globe. He has been honored with a lot of fellowships. He's the president of the Indian Obesity Society and honorary secretary of Diabetes India. He has launched many projects